uh, Dr. Hanuman Sale sir and Philip Luck to begin with the plenary sessions. Thank you so much.
Professor Rafael has joined us.
Hello?
Good morning. So we'll have Dr. Rafael Blanca online. I hope technically it works a little bit better. Welcome. It's good morning here. So please go ahead with your presentation. As I said, I hope it works better, a little better technically. Good. Thank you.
Yes, thank you very much. I hope so too. Hope you're enjoying your time in Pune over there. Once again, kind regards to all of you. My lecture will start today with talking a little bit about the updates of the mechanism interfacial plane blocks. And the objectives, as yesterday, is just to discuss about possible mechanisms and the anatomy as from today, clinical impressions and conclusions. If we think about the possible mechanisms of fascial plane blocks, we have to subdivide mainly into an action at local level and an action at far distance level. If we start with the local level, I'm trying to bring up a very interesting old paper that it looks at the 3D or the microscopic structure of the lumbar, in this case, tracheolumbar fascias, and what's happening at microscopic level. And what it's found that within the fascia, they found small nerves, and they said in this paper that the mean diameter was 15 microns. Now, this can be a confusion factor or not. It may well mean that most of the fibers seen, they were 15 microns, or it was a selection of fibers crossing the fascia. So this is something that should be clarified in the paper, but nevertheless, we're going to stick to the number that the fibers found were around 15 microns. But it was also interesting to see that most of these fibers, they were staying at superficial level, yeah? And we were traveling in between all these channels that we know the fascias have. So the fascias is like a conduit to to more central inputs. So interestingly also, there are no fibers at the intermediate to deep level. So if you look at this a microscopic preparation of fascia, you can see in the top the superficial sublayer, the intermediate, and here the deep. So most of the nerves that were found were very superficial over here. So what are these nerves? What do they do? And what is the area of action of these nerves? Look at here on your right, this 3D image, and look at this curvilinear thing on the rectangle that it represents those fibers, very superficial. If you look here, also very superficial. If we go back to what we know about neurophysiology, and we always keep in mind that the findings were that these fibers are 15 microns, we know there are three types of fibers, nerve fibers. One is type A, another one is type B, and another one is type C. So interestingly, the type fibers A have a diameter that corresponds pretty well to the fibers found in the fascia. It corresponds to a diameter between 1.5 to 20 microns. These are myelinated fast fibers, and they are related to skeletal-motor fibers and fusiform fibers, and also afferent fibers to the skin. The B fibers are also myelinated, not as fast, and smaller in size. And the type B are the preganglionic fibers, preganglionic autonomic efferents. And at the type C, that's very interesting, are very tiny fibers, slow and non-myelinated. And these ones correspond to postganglionic. So, on a first look of what type of fibers we were looking at, or they found there, we could say they were type A fibers. But could it be there are other fibers like type B or type C? If we stick to the type A fibers, we have alpha, we have beta, and we have delta, right? So the alpha corresponds to IA fibers and IB fibers. And these are related to the muscle spin's primary endings. This is very interesting indeed. So, and the IB are related to the Golgi tendon organs. Also, in a very close relation with the sense of proprioception, the position. On the AB fibers, they have sensory information also about the muscle spindles, and the A delta fibers, interestingly, these are sensory fibers related to pain and related to cold and in the skin. So once again, we're trying to narrow the function of these fibers. We're looking into the thoracolumbar fascia. Now, if you look, for example, to a standard representation of a stretch reflex, you can see here that the afferent, fibers go through from the muscle spindles, intrafusal muscle. They go back to the spinal cord from this arch here. Is the group 1A afferent. This will correspond very well to what is found in thoracolumbar fascia. And they make a stop in the ganglion, in the DRG. If you look at the Golgi tendon reflex, once again, you can see that there's a 1B afferent fibers going back and entering the spine through the back, through the sensory tract in here. And also it's got a connection with the ganglions. Therefore, what we're just maybe looking at in here is the turning back of all these reflexes going back to the spinal cord across the thoracolumbar fascia. If you look at here, another representation of what's going on with this arch, it's here is just the alpha motor neuron at the front, and the return in blue, cobalt blue. But the interesting thing here is that it uses the spinal nerve to go back before make a stop in the DRG, and then goes back in. So there is a possibility that some of the mechanism of action of all these pain transmission, it could happen at the level very close to the midline posteriorly, to the DRG, or very close on the spinal nerve itself. So a stop in the conduction can be an interesting reason why the pain stops and then getting transmitted. In this immunohistochemical study, the same, looking at the sensory innervation of the thoracolumbar fascia, and what it says is that there is a nociceptive effect over the nerves in this interfacial plane. So, and this is important. We're talking about how fascial plane blood can control, the mechanism of pain. There is an inhibitory effect of the muscle compartments, as I explained, and the fascial plasticity, it will affect directly to the sensory distribution. So it tells you how complex the fascial compartment is and in which way could be truly affecting the pain transmission. Hydrodissection or bulk flow, a gradient pressure effect, and absorption, a very important part of this resolution of this mechanism. When we look at the far distance action, we could say that there's a vascular absorption. And this direct vascular absorption could be the reason that can affect the transmission of pain in these patients. And could also be that the distribution, it has to go not only intravascularly, but also can be a diffusion or migration into axial compartments or other peripheral compartments. So with that in mind, I'm trying to look in as a group of possible mechanisms of actions of these fascial plane blocks. This article written by Kijin Ching, it really reflects very well what we know so far about the mechanism. And I just want to go a little bit through things that they are agree here about what we know and what we don't know for sure. So if you look on the left side only for now, what is known there are nerves in those fascias, as I showed you, plus the big nerves as well. We know there's a spread of in the fascial planes, and it is agreed that the concentrations achieved could be enough to create or to produce neural conduction blockade. Now, the spread in the tissue compartments has been proven by anatomy dissections, and also at other level, it's also important to agree that the blockage, it does not require big volumes. The big volumes are related more with the distribution rather than the direct effect of the neural conduction. So there are different fibers, as we mentioned, and there are clinically significant blockade of the nociceptive transmission, as I told you from these two papers. Okay, so it is not necessary to produce a complete block to have a partial effect caused by these fascial plane blocks, and the non-reliability of the fascial plane blocks. It's something we all have seen, in the terms that the consistency of some of these blocks can be related to many mechanisms about distribution, concentration, etc. So we know that the pain from the surgery happens at different levels, not only the skin, it happens at the muscle, it happens at the bone, it happens at the connective tissue. And all of this has to be taken into consideration when someone trying to explain why we stop pain. So it's not as simple as just blocking a spinal nerve that you can see. The peak plasma concentrations of lidocaine, it has been seen that in these fascial planes works in range to what they found intravenously. So does not mean that it is the cause of the primary mechanism of action, but yes, they have seen a similarity between the mechanisms or between the concentrations in both. So, and they also seen that the mechanisms of action, the several molecules, local anesthesia molecules, are very similar when it comes into the action of the receptors. This applies to ropivacaine, and lidocaine, so on. What is uncertain is the implications of cadaveric studies into what happens into human beings. And this it falls into the reflection that clinical studies are our main priority. The first thing we do is anatomical studies, but the main priority is to conduct clinical studies. Okay, it is not uncertain what determines why the local anesthetic spreads differently in between the fascial planes, because these are not clear-cut communications. There's a lot of overlapping, and all these channeling around the fascias, it can become very complex indeed. Again, it is not very uncertain how determinant the vascular absorption is, and so with all of this. And then here, also they say as uncertain, although some people believe more than others, in the molecular mechanism of this local anesthetic into all of this. We have seen lectures so far in this Congress that really addresses a big part of the theoretically part of the molecular level into all of this. You look here, and this is the plasma concentrations of LIVO, and how it corresponds at local or distance level. Very similar. Going back to this graphical representation of the sympathetic change, and you can see here potential connections that could explain why the visceral vein in some studies it's improved with the fascial plane blocks. You can see two important things here. You can see the rami communicantes from the sympathetic change into the spinal nerve here. You can see the looping and how exits through the spinal nerve. Remember, postganglionic, these are the very small non-myelinated fibers that we're not seeing in these histologically papers, but you can see that are part of all these arts and all this interconnection in the spinal nerve. And this is important also for number 2, because according to this graphic representation, and despite we put a lot of interest lately into the DRG, into stopping or blocking the transmission of pain to central level, you can see that these communications, it can occur even more distal to the DRG. So not necessary you have to reach the DRG. That is a very interesting theory, but it's the spinal nerve and the rami communicantes here that can also be affected being part of that mechanism. To finalize, I'm going into the anatomical basis of fascial plane blocks, as I told you before, yesterday. Here, you can see again this interesting understanding between the sympathetic ganglions and the postganglionic autonomic neurons and how they exit and they are efferent and they travel within the spinal nerves. So when we are affecting a spinal nerve, you are affecting to sensory efferent nerve fibers, to motor efferent fibers, and to autonomic efferent fibers. And it's a matter of creating a break in the circuit at this level, what can be the reason why the mechanism of action. Once again, if you act on the dorsal root ganglia here, you can get also part of all of these connections being disrupted, but in this case, rather than being the postganglionic, it's much closer to create the disruption at motor neuron level and the white ramus communicantes. This is the paper that I showed yesterday and I'm showing today from Hassan from Ohio, comparing the QLs with the erector spinae to remind you that they cannot be discarded the effect of the dye of the local anesthetics at local level. We can see here that the local, that the blue dye in this cross-section in the spinal erector spinae block, you can see very clearly in here, DR, 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 DR. These are the dorsal roots, okay? At that level, at planar level, at local level, and how consistently the dorsal intercostal nerves are getting really affected consistently across the plane of the erector spinae plane. So we cannot neglect the local anesthetic effect at local level to explain the the pain, how it affects pain transmission, these blocks. Equally here, you can see here, very interesting, in LCD, this is lumbocostal ligament that adds a little bit like a stop to this distribution. In here, you can see similar action with dorsal root, dorsal roots, and some spread in the QL here. So the anatomy is always important. So we're coming into your conclusions for today. I have been through several of the mechanisms, but putting emphasis on what I believe is one of the main reasons why we break the circuit and we add at different levels and could explain the mechanism of blocking the pain in this type of blocks: local, systemic, anatomic, or microscopic. All of them have to be taken into considerations. It's down to the floor to choose which one likes the most. Thank you very much and have a good day.
Thank you. I'm afraid we will not have much time for discussions, but thank you for your excellent presentation. We'll have to move on. Have a nice day.
Take care. Thank you.
Very good morning to all. Without wasting much time and no need to any introduction to Bala Venkat sir, popularly known as Bala. I welcome Bala and he can proceed with his session. Thank you.
Respected chairpersons of the day, Professor Raval, Dr. Salesa, and Dr. Philip, senior members of the profession and dear friends, and good morning to everyone. And I would like to discuss with you on a very important topic. Slides, please. Intricacies of orthogeriatric anesthesia. Before I move on, I welcome you all to the 18th World Congress of Anesthesiology to be held in Singapore from the 3rd to 7th of March. Early bird registration is from May to November, and abstract submission is from May to October. Look forward for a large Indian delegation in the World Congress of Anesthesia. India, with a population of the geriatric patients over the age of 65, it's more than 75 million people. And thanks to the advancements in medicine, that majority of them past the 8th and the 9th decade of life. The brilliance of creation is, nothing is homogeneous in this world like the newborn. Very difficult to identify between the two newborns. But because of what happens due to the genetic, societal, cultural changes, they completely evolve into two different individuals with multiple medical issues which are not comparable. All of us would like to be like this, but unfortunately, we have to face the reality of life. And it becomes important that when you physiologically age and chronologically age, it all depends on your hands. For example, the one on the left side is a 95-year-old fractured neck of femur who can hear, who can see, who was doing his activity of daily living normal before the fall. And on the right side, you see a person who is 82 years old, 13 years younger than him, and he has room air oxygen saturation of 84, emaciated, severe sarcopenia. Once he retired from his work, he retired from everything. So he lost all the muscle mass, and you see how he is 13 years younger than the one on the left side. So the take-home message is, as we go through this, we need to be very active physiologically, physically, to make sure that we may age chronologically but not physiologically. What are the global challenges we face with the orthogeriatric hip fracture? Perioperative care of geriatric patients with hip fracture is less than exemplary in major parts of the world. High amount of morbidity and mortality. Why is this? It's due to the organizational and anesthesiologist concerns which delays the surgery for more than 48 hours. And the perioperative morbidity increases whenever you go over 48 hours. A great proportion of patients are managed conservatively for fear of death initially, and suddenly they realize that they have to be operated. By then, the damage is done, and many organs started failing when they are in the bed for more than 3 to 4 days. Junior surgical team operates with prolonged surgical time and increased blood loss is another very major factor. And junior anesthesiologists many times are not able to perform neuraxials in these patients who have very degenerative spines, and hence they go for general anesthetic, and in the postoperative period they use large amount of opioid doses, again producing significant morbidity in this patient. And postoperative care in majority of the hospital is not with anesthesiologist and it's with orthopedic surgeon. This is a global research work, and orthopedic surgeons look at them passively and intermittently. So the consequences of this approach is high percentage of mortality and morbidity, prolonged hospital stay, and the more they stay, increased hospital-acquired infection. What are the solutions? Continuous specialized medical care throughout the perioperative period, either solely by anesthesiologist, as a perioperative physician, or a combined team effort of orthogeriatrician and anesthesiologist. But the most important thing is the anesthesiologist should continue to give his inputs, even if they are part of a multi-specialty hospital, because what they did intraoperatively, which was not documented, is only known to them. The physician will never know what was done inside the theater until otherwise it's documented, and he would have never expected that particular scenario until he knows what happened inside. So across the globe, there is something called as NOF unit, that is neck of femur specialized units. Only a senior surgeon operates. A senior anesthesiologist gives anesthesia, and surgeries are done even in the weekends. It's called NOF units to decrease the morbidity and mortality. What I'm going to navigate you through the next few minutes is based on what we do in our hospital. And the 2022 statistics, we operated proximal femur fractures 1,525, out of which intertrochanters were 857, neck of femur was 473, and subtrochanter 195. I want to specify this because there is so much of difference in handling each of this particular case. So the patient arrives into the hospital in the emergency room, whether it's day or night, immediately seen by an orthopedic surgeon. Attached to the emergency room is the X-ray unit, ECG, blood investigation. Immediately they are done. The minute this is done, and you know the fracture pattern and the patient has to be admitted, this patient is shifted to the preoperative room of the hospital, where a senior anesthesiologist is present 24 hours a day. So preoperative assessment is done by him, counseling and informed consent is done. Majority of them, they are dehydrated, so you start on fluid. And the most important thing is we do an on-arrival block, USG guided, and we observe the patient for 60 minutes in this block room, and subsequently we shift to the ward. This is a rigid protocol, happens within 3 hours of admission of every hip fracture. Now next. On-arrival block, the protocol of the block to be performed, we use ultrasound, and this is very important. Neck of femur with intact capsule has very less pain, and the block we choose is a PENG block. Now, neck of femur with capsular disruption, this is more painful because we need to understand there are pain generators. So in every injury, it is the amount of pain generators which are initiated, which conduct the pain and the nociception. This is very important to analyze. You shouldn't put in a broad term just a hip fracture. You need to analyze the smaller factors. So if there is a capsular disruption and the anterior capsule is richly innervated, so you have to go for either a PENG block, a SIFI block, or if you are not good in that, at least a femoral block, because 80% of this region is supplied by twigs from the femoral nerve. If it's an intertrochanter fracture, we either go for a femoral block or a high-volume PENG block. We are completely concerned about the osteotomal pain, and we are not worried about the dermatomal pain. That's why we don't give lateral femoral cutaneous nerve block. Now, this is what you need to assess. So I think it's very important. This is a neck of femur fracture. And so this is an intertrochanter fracture. And this is an intertrochanter fracture with subtrochanteric extension. I wanted every anesthesiologist to look at this before deciding on what they wanted to do to this patient. What is the essential difference as an anesthetist with neck of femur and trochanter? Very crucial for you to understand. Neck of femur fracture happens with trivial fall, severely osteoporotic bone, and very minimal injury was needed to produce this injury, which means his activity of daily living is poor. His morbidity is going to be more. The 30-day mortality and 1-year mortality is going to be more. This is the first inference that you get in when you see an osteoporotic neck of femur fracture, and you upscale everything regarding the perioperative care of this patient. But when it is a trochanter fracture, you are much more relaxed because it happens after a significant physical injury. Patient's bones are stronger, but the fall that produced this, the physical injury, the physical force that was transmitted were high enough to produce this. Activity of daily living has been excellent. Their perioperative outcome is excellent. So one X-ray can suggest so much of insights to each one of you. And sometimes you're confronted with the patient. So she was a 94-year-old, 4 grams hemoglobin, 110 sodium, and this patient is delirious, drowsy, and we need to correct her internal milieu. So we can't get her done within the first 48 hours. In this case, you go for a perineural catheter and put them on an elastomeric infusion pump. This was 6 hours after the pump was inserted, and you see a smiling patient. Cognitive dysfunction can be changed with adequate analgesia, and you may need 2 to 3 days or 4 days to correct the internal milieu before you take them for surgery. So one of the most important things is to establish a block room 24 hours a day. Next important history is loss of consciousness when you take a history on the anesthesia. Whether the loss of consciousness, if it happens after the fall, it becomes important to do a CT scan to rule out a subdural hematoma or an extradural hematoma. Considering this fact, many of these patients are on antiplatelets and anticoagulants. If the loss of consciousness is before the fall, the root cause analysis, you need to do a carotid Doppler, arrhythmia studies, middle ear disease, and vertebrobasilar insufficiency. In our the statistics and the data that collected, the comorbidities in the last year, the significant comorbidities in terms of the order is diabetes, systemic hypertension, coronary artery disease, chronic kidney disease, COPD, bronchial asthma, Parkinsonism, CVA, hypothyroidism, cirrhosis liver. And most important things that you would look into is if they were taking alcohol, the minute you know that they're taking alcohol, put them on thiamine supplements, 100 milligram 8 hourly. Substance abuse, very important to elicit constipation, and put them on laxatives because in the postoperative period, the commonest cause of perioperative ischemia in a patient with coronary artery disease is straining at stools. So this is such an important adjuvant to your perioperative care. And look at his drug allergy and whether he's on antiplatelets. Clinical parameters, many of them are hypoxic, so you need to start them on oxygen therapy. And it's important to focus on the rhythm, and atrial fibrillation is the commonest arrhythmia that we noticed. Look at the blood pressure, hypertension, and hypotension. You catheterize the patient in sterile atmosphere. This is very important because women have urosepsis, and it's very, very important to do it at the first 1 hour when they arrive, and important to maintain an hourly output chart because prerenal azotemia is very common. So as I said, prostate in men and urosepsis in women are such an important factor which will tilt the balance. Single most important cause of sepsis in trochanter fracture is urosepsis in women. So it's so important to catheterize them. And biochemical parameters of great relevance is anemia, serum lactate, especially when they come later, hyponatremia, very common, hypokalemia, increased urea creatinine, hyper and hypoglycemia, serum albumin, very important. If the albumin is less than 2 grams per cent, the morbidity is going to be very high, and you need to take this into consideration. And when they come later, you also have to do a procalcitonin level. Some of them have pressure sores and infection has started. Initiate multimodal analgesia the minute you see the patient, like paracetamol, non-steroidal, if the renal parameters are all right. Opioids sparingly used, weak opioid patches, we use butyphenol and tependol. Now nasal puffs are available, which are very effective. In this age group, we need to know this pain that happened because of the fracture is acute or chronic. Because they were suffering from osteoarthritis, they were nociception happening from the significant degenerative osteoarthritis even before the fall, and hence there was a peripheral sensitization and central sensitization in them. Hence, multimodal analgesia have to be started immediately on their arrival. Clinical pathway in the first 3 to 24 hours. Timing of surgery. Surgery at the earliest. We try to accomplish this within 24 hours after correcting the internal milieu. Extremely good outcome. Clinical pathway once posted for surgery. They arrive to the preoperative room. We do the WHO form checklist. Consent forms are checked. Preoperative vitals are checked. Check the blood sugar if they're diabetic. And the choice of anesthesia is combined spinal epidural with a very low dose spinal. And we do the block for positioning on arrival. Now it all changes. Now it's neck of femur with intact capsule, ping with LFCN. Now we want the dermatomal along with the osteotomal. And all these similar to the on-arrival block, just that we add the lateral femoral cutaneous nerve. And the clinical pathway in the OR, the pre-induction monitoring. And the 0-hour medication includes cefuroxime, very important to give it. Anesthesiologists should take the initiative to prevent surgical site infection. We use tranexamic acid, 1 gram intravenous, paracetamol, 1 gram intravenous, ketorolac if there is no contraindication, dexamethasone, an excellent addition as a multimodal analgesia, as a postoperative nausea, vomiting, and to prolong the duration of analgesia, ramosetron for PONV, pantoprazole. And in patients who are very uncomfortable, you may have to go for conscious sedation, highly individualized, and the drug that we use is dexmedetomidine infusion. Just because the patient had delirium, we don't keep on postponing the surgery because it becomes worse. I think it's a wonderful drug. I found this as an excellent drug for infusion in delirium. I've just taken a live case. This patient is not yet discharged. 110 years old with a hip fracture. That is the spine. We did a combined spinal epidural, low volume. Intrathecally, we gave 0.6 ml of 0.5% bupivacaine heavy. And it's a very, very normal thing that I keep on emphasizing. Keep the mean arterial pressure almost equal to the age of the patient. If you are doing 100 years, keep the MAP at around 100. Anything below that is a hypoperfusion to the tissues because of the accelerated atherosclerosis. Intraoperative monitoring, it's nothing very specific, but very important to go for a 5-lead ECG, temperature, and continuously monitor the urine output. They have very vague positioning on fracture table, and intraoperative even, sometimes if there is an arrest, it's so difficult to do a CPR in a fracture table. So always keep one stretcher there. And blood loss, you need to keep on closely watching blood for blood, and we use leukodepleted packed cells uniformly in all these patients so that we don't produce any hyperthermia because of blood transfusion. When it's a neck of femur fracture, it's very important to look at the bone cement and be prepared for the BMIS and hypotension that is following. Intraoperative hypothermia is extremely important. Online warming, body warmer should become a component. And the clinical pathway in the HDU in the first 24 hours post-operative is very, very careful monitoring. We do not send this patient to the ward. We closely observe for the urine output. This is the commonest problem we have seen, the kidney shutdown. Another important thing is if these patients have been on diuretics, please continue the diuretics in the perioperative period. If you had stopped it, then you will see the urine output drastically falls and you're very confused why this is happening. So it's very crucial, blood for blood, and excellent quality of analgesia you need to give. So the first 24 hours is very important. And since we do it with a low dose spinal and epidural, just wanted to inform you, when we do with the low dose, at 0.6 ml, the 2-segment regression happens within 45 minutes. So we start topping up the epidural at the 45th minute itself with aliquots of 3 ml of local anesthetic for every 20 minutes of 0.5% bupivacaine. This is very crucial. Otherwise, suddenly you will see the patient start moving the limb, and then you have to give a higher volume of epidural, producing significant hypotension. So I just want you to avoid that, and also be prepared that even when you are using very low volume, it's very vital, as I said, to maintain the intraoperative mean arterial pressure. Use drugs like phenylephrine infusion to make sure the drop is because of systemic vascular resistance. You have to tide over the crisis by maintaining the MAP, and the infusion that we use is the phenylephrine infusion, and sometimes we even go for using a noradrenaline infusion. So the postoperative concern is mainly pain, and I think with the regional analgesia that you provide, it's become excellent to handle this patient. And as I said, you need to go into multimodal analgesia. Just because they had a good block, you don't think that they don't need anything. DVT is common, and we go for mechanoprophylaxis with the intermittent pneumatic compression device and chemoprophylaxis in discussion with the patient. They will need a enoxaparin low dose, 20 milligram, but look at the creatinine levels before you do that. Postoperative hypoxemia is extremely common in these patients, and hence a close watch is needed. Hyponatremia is the second thing which we saw in this patient, but encourage early mobilization, encourage early feeding, excellent psychological support, look at their bowel and bladder, make sure they are not constipated, use perioperative antibiotics whenever indicated. This is our 110-year-old patient walking on the 3rd postoperative day, and I'm extremely happy to say that age is not the criteria. The wisdom of what we use in this patient will make them live. Even at 110 years, he thinks he wants to live more. We are nobody to decide when they will and how long they will live. It's our duty to make them live as many years as possible. And we discharge them on the 4th postoperative day after good mobilization. And it's very important, as anesthesiologist, I think we should have a unified head, perioperative care taken care of by anesthesiologist, single command that is given to the patient, and the nurses are clear what they have to do, gives excellent outcome. Thank you so much for your patient hearing.
Thank you so much, Dr. Balavankar sir. Excellent presentation. So many practical tips. Absolutely excellent. Thank you so much.
We would next like to welcome Dr.
Tells us. Let's see how exactly it all proceeded, and then we are going to also see what stayed, what got relinquished, and what is anew. We will see what is happening in the horizon of teaching and training, and why study evolution, probably to look at what happened in, what shall happen in 2050, and can we be the makers of 2050? So let's come to the story of it. This is an excellent review article which actually tells you how it all evolved. Do you know that there were the surgeons, the Byers and the Tonets? These were the surgeons who actually introduced spinals in children and published it. Later on, around 100 more cases were published, and it occupied 14 pages of Lancet. But look at this. This is again very interesting. These kids, all these 100 kids, were comforted by a nurse who knew them. They ate, some even had cake while the operation went on. Needless to say, 21 of them vomited and 6 retched. In this era, surgeon dominated, supervised the administration of anesthesia, but they gave blocks. I guess, is this ancestral conditioning? Maybe yes, but then this is how it all happened. It was Gaston Labert, actually, who wrote the famous book on regional anesthesia, which we all know. In Mayo Clinic, that was this first anesthesiologist physician who headed the section of anesthesia. Physicians, anesthesiologists evolved, and they formed communities later on, and of course, after forming good departments. It was Campbell who presented a paper in ASRA in 1933 describing caudal epidural in extreme details. In 1955, many countries by then had proper anesthesiology and anesthesia societies, and we formed the World Federation of Society of Anesthesiologists. The world saw it in 1955. Indian Society of Anesthesiology was born on 30th of December, 1947. Aora took birth in 2011, and its pediatric anesthesia, so IAPA, took birth in 1998. We clap, shall we? Thank you. So in 1950s, there was a lull in pediatric regional anesthesia because GA improved. After a lull in Australia, Melbourne, caudal was introduced in children in 1968 by MacDonald and Watts in a very big way. Coincidentally, that's my birth year. Well, in Melbourne, again, the first study on blood levels of local anesthetic in children was done, and there is no looking back. Now, what is the atmosphere today? Today, we are worried about neuroapoptosis caused by general anesthesia to a developing brain. With this premise, in fact, regional anesthesia has a bigger role to play of sparing general anesthesia. And in fact, we have a lot of papers coming up by just sedation, a wee bit of sedation or no sedation, and regional anesthesia going on in a very methodical way, but there is a method to do it. So from no place of regional anesthesia and pediatric anesthesia, we are here now to see a total intertwining of both these specialties, so they are not separate at all. This was a themed issue published in 2012 by the International Journal of Pediatrics, open for all. It's not behind a credit card. So what made them dedicate an entire issue for this, and what made them make it free in the PDFs for everybody to read because of the importance of this subject. Pediatric regional anesthesia now really forms a special category, a special section from ASRA, ISRA to AORA. AORA, right from its inception, has always had a very special place for pediatric regional anesthesia. We even now have RAJNI SUNDER Symposium, which is dedicated to a pediatric anesthesiologist, and it is initiated by none other than her own surgeon, who was Professor Ravi Kumar. So is it that simple? Is it all started with landmarks, and then we went to PNS, and then we went to ultrasound? Yes, it did go that way, but there is lots to say in between. So yes, we understood anatomy. Yes, we did think of landmark. We did start going that way. Yes, PNS gave in more objectivity. We went to that specialty as such. Ultrasound came in. We went deeper into the subject so that the little birds could be taken care of even better. But the interconnectedness still stayed. No matter what we do, I don't think the anatomical tissue gives and the fields of it, while the needle, from its needle puncture through the trajectory towards the end point, could never be forgotten, and I guess should remain an integral part of absorbing regional anesthesia as such. So what got relinquished and what stayed and what's new? Well, spinals almost have remained the same. The caudal epidurals and the epidurals almost have remained the same. So this is what we did way back. This was a loss of resistance technique, and this is how we probably could do even today. So we could see the dural and the ligamentum flavum separation due to hydrodissection. This is a simple caudal epidural given, or a spinal, in fact, simply given by an LOR method and a loss of resistance, and we know what gives the resistance and the loss of it. Calculate the drug well and you really get a good spinal. This has almost stayed, but our understanding of dosages and our understanding of local anesthetics definitely has improved. Coming to the caudal epidural, yes, again, LOR does stay. In an experienced hand, the success rate and complications of LOR is almost the same as the ones who use ultrasound. It could be PNS-wise as well, and then we have the ultrasound showing us the dural sag, which indeed is a surrogate marker to tell us till what vertebral level the drug has actually ascended. And if it is in congruence with the surgical level, the block is sure to give its best to the patient. what we did was we really compared all the three modalities to answer our curious minds as to did the complications change and did the success rate change with all the three modalities. However, all the blocks, all the 300 blocks in this study were given by experienced anesthesiologists, and we did realize that nothing much changed. Having said that, let me share this with you, that we did not pick up anatomical anomalies. If you look at caudal epidural scans in preterm neonates, something that always held us with wonder, and then we scanned around 40 preterm neonates, and what we found was something very fascinating. We had a data, and we looked back, and we analyzed, we measured, and we did some regressions to understand that when ultrasound is not used, because there are going to be places where it won't be used, needle insertion less than 3 mm per kilogram beyond the puncture of the sacrococcygeal membrane, which is actually the field that we get, should prevent dural contact in 99.9% of neonates. So this is something important to keep in mind. Does ultrasound guidance add accuracy to continuous caudal epidural blocks, which is a fascinating portal through which you can give continuous analgesia for this most vulnerable population, at least for 48 hours, provided everybody is in your team, including the neonatologist. Yes, it does act accuracy, and the story told to us is the catheters do not behave the way you want them to behave. Well, coming to quintessential peripheral nerve example, she's a sciatic nerve, and it all went with loss of resistance way back. This is how we would give. This is the loss of resistance elicited, and then, yes, yesterday somebody spoke of the tsunami dose. We would give it in a bigger dose, of course, in lesser concentration, to give the block that we wanted. Then came the PNS, and now comes the ultrasound. We see the nerve, it is seen extremely well. So here is the sciatic nerve. Go there with your needle, go with a 2He needle, put in a catheter, go ahead with a simple needle and give a single shot block. So this is the evolution staring at you, and this is how we have progressed by a tsunami dose, by a ml per kilogram dose, and perhaps now a low dose. So this is how we have evolved, and we're getting better and better, perhaps for sure. Dual modalities, yes, does become a teaching aid. Yes, also becomes an aid in understanding whether the tissue that we think is neural tissue is indeed the neural tissue, because ultrasound is going to show us the anatomy, and PNS is going to show us the physiology of nerve for sure. So this is how dual modality can really be of help. If you're dealing with congenital anomalies such as arthrogryposis, and all the muscles are fibrous tissues, and in transverse sections they're going to fool you as nerves, then yes, this dual modality is going to really tell you what is what. Or sometimes you might just keep the probe aside, you might keep the PNS aside, and go to the good old landmark technique and give a good caudal with an additive and give a good analgesia in the postoperative period. So this is how thought processes actually evolve, because you never know what really fits in your patient. Every child is different, and every case is different. You have to have the wisdom of choosing the right block and the right modality. Well, now let's come to NORRA. I know we know NORA of sedation and anesthesia. Let's go to non-operating room regional anesthesia. If you can think of this, you really are extending it into the perioperative period, and not just perioperative period, in the PICUs and the wards as well. Here is a case of necrotizing fasciitis, pain, and repeated dressings, and an agonized child. So keep an epidural. Take into consideration the risk and benefit. Take the surgical team in your team. Take the PICU team in your team, and the parents need to understand. Then pick up the risk and benefit and go ahead. Keep an epidural, let the dressings go on, but see to it that the screen is placed, because children are going to be anxious, not just because of pain, but they are going to be anxious because of many other reasons, such as seeing that there are some people working on them, and have their moms sit by their bedside. Roll into NICUs, preterms. Well, social fabric is changing, prematurity is increasing, and care for them is increasing. Their veins are at a premium and arteries can be punctured, and we do come across ischemias, and here are blocks which are somatic as well as sympathetic, can really help into improving ischemic limbs. Do we have a role in cardiac caths? Yes, indeed, yes. If you see that there are these bizarre arrhythmias happening in even smaller age groups as 2 and 3 years of age, give them a good high thoracic epidural, show them this is a therapeutic and diagnostic test for their destination therapy, decrease their arrhythmic load, and so that the destination therapy of sympathectomy, which is a surgical, non-reversible stuff, is still going to work. And if it doesn't work with a well-placed epidural, it probably is not going to work with a surgical sympathectomy. They probably might have to think of some other thing. Coming to the power of reinvention, there is always a room for that. Well, coming to ultrasound-guided supraclavicular block or the subclavian perivascular has come back into vogue, a beautiful block, but we gave up because we thought that there is a high puncture of pleuras. The pleura is right in the neck, and children have a high respiratory rate. Even if you give general anesthesia and controlled ventilation, you need to keep that rate. Hence, we almost had given up, but then with ultrasound, this beautiful block which covers the entire extremity in one go is reinvented. So this is another literature paper that really tells you that, well, interscaling, the indications are few, but when they are there. Without touching the physiological deranged milieu of a septic neonate, if this case comes to you for drainage of the shoulder abscess, then we could go with a simple interscaling and don't touch the physiological milieu and give the kid back intact. Is a possibility. Now coming to the last scene, our understanding of systemic local anesthetic management has definitely improved. Our understanding of pharmacokinetics and pharmacodynamics have definitely improved. Our dosages are better. We understand how to fine-tune them. We understand that things need to be given in aliquots. We understand that monitoring is extremely important. Over and above that, now we have the wisdom of monitoring and looking at the patient holistic and not just looking at blocks while we give blocks, but also note that the airway and the monitoring is going on pristine. If there is nobody else assisting you at that time, train somebody to do so, or train your ears to hear the pulse oximeter going. We are better off with equipments for sure. Now, do we need long-term studies? Yes, we do need long-term studies to evolve better. This is one study which is showing us that regional anesthesia can improve cardiorespiratory monitoring, complications in preterm inguinal hernias. We've started avoiding instrumentation on artificial ventilation in 1,000 neonates almost. This is retrospective data that we can present from children's anesthesia services, and we've let go of most of the general anesthesia. Deformities, they can take you for a toss, and this is what we can let go if PNS, because PNS is not going to give you an end motor response, want to go peripheral, pick up 2 needles, pick up ultrasound probe, and get going with the continuous catheters. But how? You should know that there is a sensory motor separation that can happen in the wards. Don't give them a dead extremity. Neither the child nor the surgeon is going to like it. Give them an extremity which is pain-free enough to even permit movements. And if this child with a particular regime now becomes grumpy, is not interested in you, not interested in anything around, don't escalate the pain medications, but call the surgeon. You're going to help them take care of the compartment syndrome. Another example of a similar kind. Now, meningomyelocele and central neuroaxis. How have we evolved? We've picked up ultrasound probes, and we have seen if the osseous framework to some extent is okay, and if the okay and precise and just the way it should be, and if the blocks and the case really needs that kind of a block, go deal with the central neuroaxis. So this is what we have found, that it's pretty much safe if you have really pondered upon it deep. So either you create evidence or you follow evidence. It's up to you and how you look at your subject. Well, what's happening on Teaching Horizons? We have fellowships. There are fellowships all over the world. AORA has a postdoctoral fellowship of 1 year, and these are our examiners, and Children's Anesthesia Services has a fellowship with WFSA on regional anesthesia. I leave you with the testimonials of 2 of our fellows. One is from the WFSA, and this is what she says.
A pediatric anesthetist from Nigeria. I did a fellowship.
Cutting the whole story short, she is from Nigeria. She's learned here, and we had the privilege of giving her whatever we know, and she's gone back and started her teaching program and actually replicates what we did. So this is Nitya did with us in with AORA. What happens in the globe? What is happening about research and publications? This is caudal block in a couple of countries, and publications that happened in last couple of years. Look at India's share. We are definitely evolving. Sciatic nerve, look at India's share. We are there on the horizon. Intraclavicular blocks, look at India's share, one of my personal favorites. Who says we are not publishing? We are, but we probably have to answer long-term questions. And coming to 2050, it's promising. Who knows how many of us would be actually witnessing 2050, and who knows, probably somebody of you might remember this session and this talk and might give a smile. Thank you so much. And let me tell you one thing, we need to keep our blocks simple so that most of us can master them. Thank you.
Thank you very much, Dr. Ponde, for this wonderful, inspiring lecture and for having created and congratulations having created such a lot of evidence yourself. Thank you so much for everything. We would next like to invite Dr. Sancheti Senior on his lecture on innovation and strategies for management of transitional pain. Thank you so much.
So good morning, everybody. It's a pleasure to be here in Pune. I always look forward to coming to India, so it's been a great trip. Met a lot of colleagues, friends, made new friends, and also had the opportunity to visit my hometown as well as meet some of my relatives as well. And the food was excellent, so it's always a pleasure to be here. So today I'll be speaking on innovations and strategies for management of transitional pain. The objectives of this talk is to understand the episode of postoperative pain and to realize that there are limitations to the current acute pain management practice, and there's a need to develop transitional pain service. And we'll talk about techniques that can be utilized for controlling the entire episode of post-surgical pain. So an episode of surgical pain usually lasts for days to weeks, depending on the kind of surgery. In the initial period, in the first 48 hours or so, it is very acute, it is very intense, very severe, and is usually managed by nerve blocks that we learn here in these kind of settings. There could be an acute pain service that could be involved. Multimodal strategies are used. Multimodal medications are used to be able to control this pain. Once this acute phase resolves, the patient enters this transitional phase. And in this transitional phase, you can have episodes of breakthrough pain, you can have pain with movement, constipation if you're using a lot of opioids for pain management, you can have psychosocial disturbances, anxiety, sleeplessness, but the pain usually will resolve, as I said, within a few days to weeks, depending on the kind of surgery. Now, during this phase, the patients are usually at home and are usually taking narcotics or multimodal medications to manage their pain. If this pain is not well managed, then these patients go on to develop chronic post-surgical persistent pain, and then these patients are at a very high risk of developing opioid addiction and have very poor surgical outcomes. So the current pain management strategy revolves around multimodal medications and regional anesthesia to provide pain control. And by the way, we do an excellent job in controlling that early acute pain that lasts for 48 to 72 hours or so with our nerve blocks, our continuous techniques, continuous perineural techniques. This is just a slide on multimodal medications. I'm not going to go through it, but basically the concept is to use medications from different pharmacological classes to try to block the transmission of pain from the periphery to the central nervous system. And you're trying to use different pharmacologic classes so that you can minimize the side effects of each of these individual drugs, but maximize efficacy. And in terms of regional anesthesia, you can use single-shot nerve blocks that usually last about 18 to 24 hours or so, continuous nerve blocks for up to 48 to 72 hours. Long-acting local anesthetics are now available, not in India, but outside. And there's two examples. Exparel is one of them, which is liposomal bupivacaine, and Zinrelef is another one. But the effects, typically with all these techniques, you're able to provide pain for up to 72 hours. Now, despite doing this multimodal strategy using nerve blocks, there is a very high risk, or the risk of persistent pain after surgery is surprisingly sort of high. And here's a list of this is a cartoon by Terkavi. In his series, he sort of listed all the post-surgical persistent pain that develops in various regions of the body. Some of the most common ones, notorious ones, are obviously thoracotomies, mastectomy, so chest wall surgery, basically. Total hips was sort of surprisingly there in that list. I thought total hips wouldn't be there. And obviously total knee replacements, which in about 15 to 20% of the patients develop persistent pain after surgery. So this displays the risk the risk or the incidence of factors that are associated with the development of persistent pain after surgery. The size of these boxes or these rectangles correlate with the incidence or the prevalence of these factors, these risk factors, in this case series done by Terkavi. And obviously, one of the important ones is severe or poorly controlled acute postoperative pain. So it really is important that we provide excellent pain control in that first 48 hours or so of post-surgical pain. Preoperative anxiety, preoperative depression, they factor in very heavily in the development of persistent pain. And this is something that we have known for quite some time. So these psychological risk factors are very important and need to be sort of controlled to be able to provide better pain management and to mitigate the risk of persistent pain. And you can sort of take a look at multiple sort of risk factors or that were found in this series. Now, this is a study from France where they looked at 2,100 patients, retrospective analysis after various kinds of orthopedic procedures. About 1,292 patients finally they were able to collect the data from them. And what they found was that 48% of these patients reported persistent pain after surgery. So almost half of the patients who had orthopedic procedures developed postoperative pain, developed persistent pain. This is a study that was just published last month in Anesthesiology. They contacted about 3,500 patients, but were able to collect data from 680 patients. And what they found was that at 3 months post-surgery, persistent pain was present in 27% of the patients, and the opioid use was in 14% of these patients. This is a variety of procedures, orthopedic as well as soft tissue procedures. And so, and this is sort of another study where opioid use at 6 months after surgery in shoulder surgery was 16.7%, which is remarkably high. In total knee patients, 8.2%, total hip patients, 4.3%. In the United States, there are about 50 million surgeries that are performed. This is sort of a little dated number, but there are more than 50 million plus surgeries performed. Out of those, 2 million develop persistent pain and go on to become opioid use. So that's a remarkable burden on the society I'm sure it is present here in India as well, and that's something that we need to focus in on trying to reduce. So what I propose or what we feel the next evolution of acute pain management should involve transitional pain service to your regimen of multimodal medications and regional anesthesia. And what does that transitional pain service entail? So there's, as we sort of alluded to, psychological factors are important, and so there should be some kind of a psychological treatment that should be provided or support that should be provided to these patients. Pharmacology, of course, is important, and then there are these pain procedures. And in this talk, I'm just going to focus on some of the pain procedures that can be used in this transitional pain service. So here's an example of, in chronic pain clinics, radiofrequency ablation of the genicular nerves has been proven to be very effective in controlling osteoarthritic chronic pain. And so the thought was, why can't we use the same technique in patients having total knee replacement? And so these are two well-controlled, well-designed, randomized studies that were performed. I've combined the results. In this study, they followed almost a similar sort of clinical pathway. The superior medial, the superior lateral, and the inferior medial genicular nerves were ablated using either cool radiofrequency or thermal radiofrequency. And the primary outcomes in one of the studies was opioid consumption at 48 hours after surgery. Another study was the composite pain at rest and at 2 weeks and at 6 weeks after surgery. And as you can see, that even though radiofrequency ablation works well in the chronic pain setting, it really does not differentiate doesn't really provide any kind of analgesic efficacy in the acute post-surgical setting. There was no difference in the morphine equivalents used in one of the studies, as well as there was really no difference in the pain scores in the other study. Cryoneurolysis is another technique that's been proposed, and this is a prospective randomized trial that was performed with sham control. And the nerves that were targeted were the anterior femoral cutaneous nerve and the infrapatellar branch of the saphenous nerve in patients having total knee replacement surgery. These are sort of superficial cutaneous nerves, and the primary outcome was opioid consumption at 6 weeks post-discharge. And again, what they found was with the intention to treat analysis really didn't show any kind of difference with the use of cryoneurolysis in these patients having total knee replacement. When they did a sub-analysis with per protocol analysis, they were able to show some benefit at 72 hours and at 6 weeks and 12 weeks. But the number of patients was small. The sample size was small because they had to exclude a lot of patients who had protocol violations. So you have to sort of look at it with a little grain of salt because the results could be biased. So the third modality that I want to talk to you about, and this is the one we'll spend a little more time now, is neuromodulation. Neuromodulation was sort of understood in 47 CE in Mesopotamia, where patients having pain, they used to dip their hands or their legs in water tanks that had electric eel, and the electric eel would sort of provide a shock to those patients, and that would confer analgesia. And the exact sort of mechanism of why this worked was first reported by Melzack and Wall in the gate theory in 1965. The first spinal cord stimulation was used in 1967. And so there's been a long use of electrical stimulation of the spinal cord, and now recently there's a lot of interest in peripheral nerve stimulation for providing pain control. It has been used again in the chronic pain arena for quite some time, but the question is how well will it work in our acute pain post-surgical setting? So this is an architecture of a mixed nerve where the pain signal sort of travels through the trunk, goes to the spinal cord, and then goes to the higher centers. And what I've done is I have sort of devised that this, or what I feel is that sensory information travels through two gates. There are multiple gates, but for our practical purposes, we have defined it as two gates. The first is the sodium-potassium channel, the sodium channel gate, which can be manipulated or blocked with local anesthetic. And then the second gate is the synaptic gate, which is in the dorsal horn of the spinal cord. So, so here's a pain stimuli, and the pain stimuli would then sort of travel and then go up to the higher centers. Now these nerves, mixed nerves, are made of A beta fibers, A delta fibers, and C fibers. It is usually the A delta and the C fibers that transmit the painful stimuli. The A beta fibers are the fast, myelinated fibers, and you can electrically stimulate them and cause a block at the dorsal horn of the spinal cord, which is the concept, relies on the concept of gate theory. So if you place a device on a peripheral nerve and you inject local anesthetic through it, you will cause blockade of that molecular gate, which is the sodium channel. And if you are able to then deliver electricity through an electrode or a system, then that electricity is going to travel and create a blockade in the dorsal horn. So now, as the pain sort of starts to travel, the first gate that it has to cross is going to get blocked, which is your local anesthetic. And as the local anesthetic wears off, resolves, you are now still left with your electrical stimulation, and the pain signal will go through the molecular gate, but will then get blocked at the synaptic gate in the dorsal horn. And so this is the concept that I sort of designed to manipulate, to sort of design a catheter system that we'll talk about. But before I did that, I actually did some trials with devices that are designed for chronic pain patients of peripheral nerve stimulation. This is a product called StemWave that is designed for implantation in chronic pain patients in the peripheral nerve. I took 15 patients who are having total knee replacement, 15 patients having total knee replacement, and they had the PNS, the nerve stimulation, this device placed along the femoral nerve, and then they had their traditional nerve blocks, the adductor canal and IPAC and genicular nerve blocks. What I found was that of those 15 patients, there were 4 patients that required 0 narcotics. They didn't take any kind of opioid for their recovery. 5 patients took 1 pill, which is an oxycodone 5 milligram tablet is what was sort of prescribed. They took just 1 pill at night, and not because they were having pain, but because they couldn't sleep. They couldn't sort of find a comfortable position. So they're using it more as a sleeping pill. And there were 6 patients that took 2 tablets per day for the first 5 days, and then after that, they really didn't take any pain medications. I left these catheters in place for 21 days in patients having total knee replacement. And so with this proof of concept, I then designed a catheter that sort of looks like this. It has, it's a very small, lightweight catheter system that I've designed. And what it has is an external pulse generator that connects to the electrodes at the tip of the catheter. It's a catheter over needle system. You have the ability to inject local anesthetic through here to create that primary nerve block. And then when the nerve block wears off, the electrical stimulation can be, the integrated external pulse generator can be turned on to provide neuromodulation. And and you can use it up to 30 days for controlling pain after surgery. So how would the device be used? So here is a pain profile of a patient having rotator cuff surgery. So this is, as you can see, in the first 2 to 3 days, the pain is really, really severe. It then starts to taper down and kind of resolves by about day 30. I've drawn a line at a pain score of 4, below which we consider pain to be tolerable and easily controllable just with simple pain medications or non-opioid pain medications. And as you can see, it almost takes 15 days or so for the pain levels to come down to lower levels. to levels that is sort of tolerable or below a pain score of 4. And the other thing is here in the early phase, you have these intense pain, and you have these episodes of breakthrough pain. And you need local anesthetic, you need the sodium channel blockade or the molecular gate to be blocked to control that early, intense, severe pain. Neuromodulation does not have the power to be able to control that severe pain. And so you need both these modalities to be able to control that episode of pain, as well as the levels of pain, the severe pain, the intense breakthrough pain, and the moderate levels of pain that happens. So you have to use a device or a platform that can deliver both these modalities, either concurrently or in compartments in sequence. This is how we would sort of deploy it. So you would use this device to, for example, in a patient having shoulder surgery, to do your primary interscaling block. You would leave this taped, and when the primary nerve block wears off, the neuromodulation will continue and provide pain control for up to 30 days. You could use it for 7, 8, 10, 14 days, however long the patient requires it. The other thing that we have done is this device is now controlled by an app on your phone, and so we have created modules where you can do your rounds, e-rounds with this. I will just go down to a study that was done, a well-designed, prospective, randomized, placebo-controlled study with 60 patients having brachial plexus surgery and rotator cuff surgery and foot and ankle surgery. The primary endpoints were pain scores and opioid consumption. The leads were placed in the brachial plexus and the sciatic plexus. The patient on the day of surgery had single-shot nerve blocks at those 2 locations. And what they found was, by the way, the device was left in place for up to 14 days. And what they found was that the patients who had, the treatment group, the experimental group, had lower pain scores, average pain scores, as well as lower interference from their pain. This is the brief pain inventory in terms of their interference subscale was lower in patients who had neuromodulation as compared to the patients who just had a single-shot nerve block. Similarly, the opioid consumption was lower, and the pain sort of was as you can see, was lower right throughout in the treatment group in both those foot and ankle surgery patients as well as the shoulder surgery patients. So in summary, controlling the entire episode of post-surgical pain should be our goal, and it can be delivered through a transitional pain service. And the combination of a nerve block and neuromodulation, either in concurrence or in sequence, may help us achieve those goals. And this is an area of innovation that should be pursued. Thank you.
Thank you so much, Dr. Sinha. Excellent speech. There is no time to take any questions. You people can interact during the tea break. Already patients are on the table, so message has already come for the live workshop. Patients are there. So we'll close this session here only and move on to the next session. Organizers can move to the next session. Thank you so much.
Archana, good morning. Can you hear me? Can you see us? Thank you so much. So we have with our team Dr. Avinash, Dr. Nitin, Dr. Himanshu, Tanmay, Neha, Gayatri, Dr. Madhuri, and Dr. Ganesh. So they're all with us. And they have made all the things ready. OT5 and OT4 are ready. Dr. Bharati is going to demonstrate pain block first, followed by Dr. Ritesh, who is going to demonstrate sci-fi block, followed by there will be for the knee joint, the adductor canal block by Gopal and IPAC by Amjad. So they will be done by both of them. Okay. Just to have a word, Archana, Harshal is there with you?
Yes, sir, that's what I was just about to introduce the moderators for this session.
Please.
This is Dr. Harshal and Dr. Ujjwal Raj. They will be moderating this session.
So these both are very high-profile anesthetists from Mumbai. One works in Kokilaben and the other in Hiranandani. And a good news for all of us that Dr. Harshal was one who just anesthetized Mr. Dhoni a few days back. And we keep his lecture the next time in Aora, how to anesthetize celebrities because he gets a lot of them. So over to Dr. Bharati. You can start with the PEG.
Yeah. Good morning all. Am I audible?
Yes, you are.
Okay. So first, we are starting with the PEG block for this patient who is posted for THR, 34-year-old gentleman, and the patient is in supine position with the leg slightly extended, and I'm using a linear high frequency probe because the patient is not very fat. So I think we'll be able to see all the structures well with this. To start scanning, I will put my probe just next to the anterior superior iliac spine, and then I turn my probe so as to see the pubic ramus. I need a little more depth. Okay. Some more. The marker on the probe is on the lateral aspect of the patient, and the first thing I would like to see here is the anterior inferior iliac. This is anterior superior iliac spine. I go medially and look for the classical image for, now this comes the anterior inferior iliac spine, and when we go medially, we can see the iliopubic eminence. Can you appreciate that? Then we move on to identify the iliacus muscle, which can be beautifully seen, and the psoas tendon, just on the lower side, or rather inferior to the iliacus muscle. At the same time, you need to go a little medially and identify the femoral artery and femoral nerve, and below that, there is a pectineus muscle. So our area of interest is basically the area, the space below the psoas tendon and between the psoas tendon and the pubic ramus. So we'll be using a 21 gauge 100 mm needle, and the needle will be inserted in plane from lateral to medial. The patient is already given spinal anesthesia, so I don't have any, I don't have to inject any local anesthetic. So my needle will be inserted from the lateral end of the probe, and I will try to go just below the psoas tendon. I'll be almost reaching the pubic ramus. Since this is a deeper block, sometimes the visualization of the needle is a little difficult. I'm actually, my needle is on the pubic ramus. Can you please? Yes. Aspirate and inject.
Can you see the psoas fascia getting lifted up with each injection?
Can you appreciate the movement?
Yes.
Yes. So that lifting of the psoas fascia with each injection, that is the confirmatory sign that you have deposited the drug in the right plane. If you are depositing your drug in the muscle, if you are depositing the drug, then there are chances of femoral nerve getting blocked, okay? So we will be injecting around 20 ml of 0.2% ropivacaine. Basically the trick is, when you feel the resistance of the needle on the iliopubic eminence, slightly rotate your needle to pierce that fascia, and your drug injection should lift the psoas fascia up. Can you appreciate, Harshal?
Yes, we can. Very well.
And there is no drug inside the psoas muscle. It is all below the psoas fascia, and the drug will be running over the iliopubic eminence to block the articular branches of obturator, femoral and accessory obturator.
Yes. So
my injection is done. With each aspiration, I injected around 20 ml. And any questions, Harshal, you can ask ma'am.
Yeah.
No, very beautifully done, madam. No questions at all.
Thank you.
Just one comment, madam. The jelly that you have used, is that sterile jelly?
Yes. Yes. It's a sterile jelly.
It's a sterile jelly.
So you've used a lignocaine jelly. Any
Yes.
added advantage that it will numb the skin or something?
No,
No,
it's
no,
not
no, no.
about
Just the
numbing, it's
convenience.
Just a convenience. Okay, it's a sterile jelly.
Just one more question.
Yes.
How, are we supposed to inject it, the drug or the needle is supposed to be placed medial to the anterior inferior iliac spine, or it has to be bang between the anterior inferior iliac spine and the pubic ramus?
The needle should be just inferolateral to the psoas tendon. That is the point where your needle should be placed.
The target area is actually the iliopubic eminence and the lateral part of the psoas tendon. These two have become very important anatomical landmarks for the PENG block, which is supposed to block the articular nerves.
So I'll come from
Dr. Ritesh will now demonstrate the SAPHI
So
block.
I will demonstrate the suprainguinal fossa iliaca block. So basically first you have to feel the most medial, this is the anterior superior iliac spine. I will start palpating just the medial most part of the bone, iliac bone, just medial to it. I will put my probe in a parasagittal orientation. This alignment is most important. There is no concept of lateral 1/3 or medial 2/3. You get confused with that. Just start palpating just the medial most part of the iliac bone. Just put your probe in a parasagittal orientation. As I put, ma'am, just you come
Yes.
this way. As I put my probe in a parasagittal orientation, you can see, kindly reduce the depth slightly, Nathan. You can see a bow tie appearance. Can you appreciate the bow tie? Itna nahi, thoda sa.
Yeah, very well actually.
Yeah. So this is your iliac bone.
If you can just point out so that the
yeah.
audience
ABC,
knows. Yeah.
ABC. One more. Yeah. You can see the iliac bone. Come down. Yeah, this one. This one. Yeah. Can you see appreciate the iliac bone?
Yes.
Yeah. Just a minute.
Can you just label the medial and lateral as well, Ritesh, please?
Yes, just hold on. Just hold on. Just hold on. We are just tying here. So my marker is caudard. My marker is caudard, and the opposite end is cephalad. Okay? I am clear? My marker is at the caudard end. My probe is in a parasagittal orientation. Right? Parasagittal oblique. And this is the iliac bone. Just above that is your iliacus muscle. And caudard is your sartorius. Can you appreciate the sartorius?
Yes.
Yeah. As I go cephalad, this is your internal oblique muscle. Just below the internal oblique muscle, you can see the pulsation of deep circumflex iliac artery. Can you appreciate that?
Very well, very well.
That's a very important landmark, because if your drug is surrounding the deep circumflex iliac artery, it means you are above the fossa iliaca. Now, you can see two pulsations, right? And the artery has already divided. I will try to slide the probe medially to make the artery one. Can you appreciate now the artery has become one?
Right.
Can you appreciate that?
Yes.
Yeah. So the fossa covering the iliacus muscle is the fossa iliaca. The SIFI block is a suprainguinal approach where you deposit the drug between the fossa iliaca and the iliacus muscle. I will do a in-plane needling from cephalad to caudal, and I will try to unzip the plane between the iliacus, fossa iliaca and the iliacus muscle. I am coming in plane. You can see the needle coming from the cephalad end. Yeah. I felt a pop. Appreciation of the pop is important. Ma'am, inject, please.
Injecting.
Yeah, please inject. Please inject. Please inject. Yeah, please inject the drug. Yeah, with each injection. Can you see the plane getting unzipped?
Yes.
Ma'am, please. Yeah. Ma'am, inject the drug.
Injecting.
Yeah. Can you appreciate the plane getting unzipped? Harshal?
Yes, yes.
With each injection, I am going just below the fossa iliaca and advancing my needle with each injection. That's a trick. You want your maximum drug to go cephalad. Okay? You want your maximum drug to go cephalad. Yeah.
Inject.
Yeah, ma'am, please. Yeah.
Yeah, we can appreciate the unzippering of that fascia.
Yeah.
And the drug spread as well, very well.
Yeah. I am almost getting inside the peritoneum now. Yeah, drug is going inside the peritoneum. I am sliding my probe almost over the abdomen. Can you see?
Yeah.
Now the drug, my maximum drug has gone cephalad.
Done.
So I have injected around 40 ml of drug, and you will not see a single drug inside the muscle. You have to unzip that plane. That's a trick, and your maximum drug should go cephalad.
Just to complete that, 40 ml of what solution was?
Yeah, can you appreciate the drug
Yes,
almost inside
yes,
the peritoneal
Ritesh.
cavity?
Pelvis.
Yes, inside the pelvis. My maximum drug has gone here. Yeah, can you appreciate the drug?
Yes, yes, very well. What did you inject for?
0.2
ropivacaine, 40
ropivacaine.
ml
Right.
in the sci-fi plane and
20 ml
20 ml in
for
the
peng.
peng. So actually, he could have also scanned a bit in the actual
FL.
plane to exactly see how the local anesthetic
Yeah,
must
yeah.
have spread.
Yes, yeah.
So that would be important to scan in both the planes.
So right now I will just show you how the drug has. Can you appreciate the drug between the iliacus muscle and the fossa iliaca?
So close to the femoral nerve and come lateral.
Can you see this?
Yeah,
Yes, yes.
Yeah. Now I am
come
just
lateral.
scanning laterally. You can see the drug surrounding the lateral femoral cutaneous. I will just go down on the depth. I will try to scan up and down to show you the.
Yes.
Actually, we can see the
Yeah.
FFT.
Yeah.
We can see
Yes.
the
Can you
FFT.
see
Yeah.
the-
There is a slight spread on the most lateral aspect where the femoral nerve lies in the
Yes.
fat femoral triangle.
Yes.
But it really does not soak that. It soaks still more cephalad. It does not soak at this point. So you have to go
Yes,
still more
yes,
cephalad
I am
at which,
going up,
yes, here at
Can
this
you
point.
Can you see the lateral femoral cutaneous surrounded by the local anesthetic?
Yes, yes, just opposite,
medial
yes.
to the anterior superior iliac spine.
So Harshal, Ujjwal, this block, it soaks these nerves at different levels.
Right.
The
Right.
femoral may be at the femoral artery in the inguinal, and the lateral femoral may be still higher up. And the obturator nerve, it never gets soaked with even 60 ml. We have tried that.
Yeah, that was what I was about to ask.
Yes.
For both the blocks,
Yes.
whether they increasing the volume, they reach the obturator part.
No.
No,
Never.
Ujjwal. So we have seen that with 60 ml, they have done that in one of the studies, but not with
40 ml.
Yeah.
not with 40 ml. And there's never a chance for this drug to leave this space and go medial to the psoas major where the obturator nerve lies.
Right.
So very nicely demonstrated both by Dr. Bharati and Dr. Ritesh.
Yes,
We
thank
move on
you.
to the next block.
Yes, thank
If you
you.
have any questions meanwhile.
Thank you, Dr. Bharti and
Thank
Dr.
you,
Ritesh.
Archal.
Thank you very much.
Thank you all.
I think we can give them a round of applause. It's not easy to do the blocks when such a big audience is watching and doing them live.
Are we live?
Yeah, you're there, sir.
Yes, sir.
Morning, Harshal. Morning, Ujjwal. Morning
sir.
to everybody in the auditorium. We are here with a 53-year-old lady who's posted for a total knee arthroplasty. She's been given a spinal anesthetic. She's sedated. And there is a drape here, which is separating the lower part of the body from the upper part. And we are going to perform an IPAC and an adductor canal block for her. And for an IPAC, I'll be using a low-frequency curve transducer. With me here is Amjad. He'll be using a high-frequency linear transducer to perform the adductor canal block. And this will be for post-op analgesia following the total knee arthroplasty. And we do know that there was a time when continuous epidural was being performed for unilateral knee arthroplasties, and there came a time when even surgeons started saying, why are we giving complementary analgesia to the non-operated limb? And then we moved on to a spinal and a combination of femoral and sciatic nerve blocks for post-op analgesia. But then femoral has its own issues in that it causes quadriceps palsy, and following a sciatic nerve block, there is a foot drop. So in the immediate postoperative period, dynamizing the patient actively is an issue. And till the foot drop wears off, the surgeon is not too clear whether the foot drop is because of the local anesthetic or because they buggered the common peroneal nerve intraoperatively. And the incidence of common peroneal nerve injury during a knee arthroplasty is approximately 2.6%. In 2012, Sanjay Sinha came up with the IPAC, which is an acronym which stands for infiltration between popliteal artery and capsule of knee. For this block, we are targeting the genicular branches that arise preferentially from the tibial nerve. So there is analgesia to the posterior capsule, but there is no accompanying foot drop because we are not targeting the major vessels. So I'm just placing my probe overlying the medial condyle, just proximal to the patella. And what you see on the left is the curve, which is the shadow, and that is the medial condyle there, beneath which you have an acoustic shadow. And then you can see the popliteal artery pulsate in the vicinity. The muscle to the left would be the vastus medialis, through which the needle will enter. And on the right, you will have the sartorius, the semimembranosus, and semitendinosus. So as taught by, that is the popliteal artery and vein over there. And as taught by Sanjay Sinha, who was the mentor for this block and the originator, the idea would be to go between the condyle and the artery. And oftentimes, because this is a very steep block, you don't get to see the trajectory of the needle. You will be only able to deduce the needle I'm just trying to go past the artery there while staying close to the condyle. Yeah. Now I believe I am just posterior to the artery. It's just a feel. I am not able to actually see the needle there. I'll ask Amjad to just gently aspirate and inject.
Negative. Injecting.
The aspiration is negative. You see the local anesthetic now just spreading in between the condyle and the artery.
Yes, sir.
We'll inject about 6 ml here. Yeah, give some more on there.
Injecting.
And as the local anesthetic is injected, you will see that the artery is being slightly pushed away from the condyle.
10 ml done.
Yeah, yeah, that's the place. And now I'm
Yes, the arrow will
gradually
help, yeah.
withdrawing the needle as Amjad continues to make his injection, so that we disperse the local anesthetic along the condyle.
5 ml left.
Yes.
So there are 2 injection points here.
Yeah, one injection point would be 2 centimeters distal to the artery.
Last one.
And the other injection will be made as we gradually withdraw the needle.
Completed.
So we put in 20 mils of local anesthetic. Now, as you can see here, the artery has been pushed away from the condyle, and you will see that the drug has actually accumulated in between, along the condyle and in between the artery and the medial condyle. So this is infiltration between popliteal artery and capsule of knee. The problem with this block is the needle needs to go at a very steep angle, and picking up the needle as it enters is very, very difficult. The other approach would be to do it out of plane. Even then, picking up the needle would not be so easy. But then the idea is not to injure the artery by putting the needle through the artery or the vein. So once the local anesthetic is done, you can see the hypoechoic shadow cast by the local anesthetic along the edge of the condyle. So that is what we typically expect.
PV sir, can you just highlight the knee position and the probe position once again for the delegates?
Yes. Yeah. So the knee is actually straight. I have placed a sandbag so as to flex the knee slightly, and I have slightly internally rotated it. And this is the patella here. I have placed the probe in this manner, just proximal to the patella, to identify the medial condyle and then the artery, so that we will place the drug in between the condyle and the artery.
So with the needle trajectory being so acute here, would there be an option to do it with the probe placed in the popliteal fossa and then come with the needle parallel? Would that make any
It is
easier?
possible. You can also, there is also a posterior approach that has been described, but that could be a little cumbersome for patients. There has been a comparison between the anterior and posterior approaches.
Right.
So the other approach would be to do it out of plane.
Right.
So, but even then, visualizing the tip of the needle would be a problem.
Right, sir.
Okay. So with this, we'll just move on to the adductor canal block, which Amjad will demonstrate to you.
Just shift over the probe.
We'll switch the probe for that.
Nerve, yeah. Just press nerve here. Nerve, yeah.
I'll just change my...
Scan. Hi, Harshal, am I audible?
Yes,
okay.
very loud.
I'll be here.
Yeah.
And clear.
Yeah, okay. So Harshal, the same patient in the same position, we're going to do a single shot adductor canal block. Okay, I'm just setting up the machine so that we can get started. All right, so we haven't changed the position much. The medial thigh has been exposed, and I'm just pressing my hand onto where her ASIS would be, and this is the knee. I think this is quite clearly seen. Now in the old days, what we would do is look for a landmark, which would be a midpoint between these two areas, and somewhere in the mid-thigh scan for the femoral artery and assume that was the mid-adductor canal. But with all this talk going on about femoral triangle blocks, proximal, distal, and different techniques, the mindset has changed, and we know now that the nerve to vastus medialis is an important component of the analgesia that we provide for total knee replacement. So if I start at the mid-thigh, I'm just going to adjust my machine. Can you go up on the depth? Depth. Yeah, increase the gain. Okay, so you can see the femoral artery there at the center of your screen. Is it visible, Harshal?
Yes.
Okay. The probe pointer is towards the anterior thigh. So as I go shift the probe to anteriorly or laterally, what you see, the bulk muscle is the vastus medialis over here. The sartorius is on top. It's a little bit brighter than the other muscles. And if I go much more medially or posterior-medially, we see a larger muscle here. But when we are looking at trying to identify the start of the femoral triangle, we need to look at a point where we see the adductor longus and the adductor magnus on the medial side. So I'm just going to scan a little higher and look over to the medial side. So now distinctly you can see two muscles. The one where the arrow is being pointed is the adductor longus.
Yes.
And as we scan down, you see that it kind of becomes a lot flatter, thinner, and the adductor magnus occupies bulk of that territory. So if we want to define what the proximal adductor canal is, we need to look at a point where we see both the adductor longus and the magnus on the medial side. And since we have identified it here, I'm going to swing back over and see what lies on top just at about 11 o'clock to the artery. You see the sartorius,
Yes.
you see the femur, and you see the vastus medialis. Now keep your eye on where the arrow is. Can you just move that up? Yeah. You see some sort of hyperechoic structures there. In fact, there are two. Could you just move the arrow out? Just keep your eye over there. Yeah.
Yeah.
So I'm just going to trace distally, and you see that it's kind of, there are two distinct structures at this point. There's one right over there where the arrow is, and there's one more medial close to the
eye
artery.
appearance,
Yeah.
the two eyes.
So here we can see and distinctly make out that the one closer to the artery is the saphenous nerve, and the other one a little more lateral is the nerve to the vastus medialis. And as we scan lower down, we see that the nerve to vastus medialis will actually move farther and farther away. So a nice point where you could do this block and you want to catch both these nerves would be somewhere around here where they are close together. This would also be an ideal point to place the catheter. Alright, so now that we're done with all that talk, we'll just go out to doing the block. So I'm using a 10 centimeter needle. Ritesh has been kind enough to hang on. Can you remove that arrow, please? Yeah. So the probe position is seen clearly, Harshal?
Yes, yes.
Alright, so let's just do this block.
Would you say that the probe position is a little bit lower to the midline, midpoint of the thigh, or?
She's got a fairly short thigh. So what we're looking at, it's pretty much a little above the midpoint.
Right.
Okay. So let me just get my needle in view, and there you see the needle tip seen.
Yes, seen.
Okay, so let's just track this guy down. Okay, so we are kind of between the plane where the sartorius ends there, and we'll just follow the needle tip. Okay, so I'm just beside where the nerve to vastus medialis is. Could you inject a small bit there, Ritesh? Okay, so now that we have that, yeah. Yeah, okay, so I'm just going a little past that. All right, okay, so now we can inject. So you see now the nerve is being delineated quite nicely.
Quite well.
Yeah, so that's the needle tip. Okay, and I can move this a little bit forward, and then we can look to target the saphenous on the other side.
So Amjad, how important it is to identify the separation of the vastus nerve before you proceed with the needle ahead?
Not really, just as I'm assured that I'm in the right plane, I do not want to be inside the sartorius. That's going to render my injection ineffective. So I have been able to identify both the nerves.
Yeah.
So it's pretty much just ensuring that the local engulfs the nerves in both. Yes, just a little bit more here. So now that we've identified both these nerves, you don't really need to use very high volumes. Okay. So I'm just going to scan a little. So you can see, yeah, Himanshu, could you just put the arrow here? Yeah, rightward. Yeah, that's the nerve to vastus medialis. You see that it has been engulfed. There's a nice little donut of local around it. And much closer to the, yeah, that's where the saphenous nerve is. Can you see it at about 9 to 12 o'clock?
Yes.
The shadow, it's just capping the artery. So that's the saphenous nerve. And you can distinctly see two nerves have been engulfed by the local anesthetic in this block.
How much volume you have injected so far?
We have injected just 10 ml. So you don't need to do very high volumes here. I know traditionally some people use 20 mils, but here we have taken the targets down with about 10 ml. We can put a catheter in here and just one.
If you can't see the nerve to vastus medialis, is there a case to use the nerve stimulator along the way? Or?
Well, if you can see it, do you really need to use it?
Can you just demonstrate in a longitudinal view the rest
Okay.
10 ml injection if it's
Okay.
possible?
So Dr. Sandeep wants me to turn the probe longitudinally and see if we can have a look at what has happened.
You can also
yeah.
inject in the longitudinal.
Yeah, we can
so
probably
we can see the
inject
separation
also once we...
of the nerve from the artery as well.
Yeah, let me just refocus where my needle is. The needle's there. Okay, I'm just going to pull it back a bit and we'll just... Yeah, so that's the nerve that you see there. That's clearly neural tissue there.
You can appreciate that.
Yes, yes,
The longitudinal view. Now, when he injects, you can see that if he injects, how it separates.
Yes, we can see that unzippering, yes.
See that. Look at that spread. Yeah. You can gauge the volume now. What he said was low volumes are quite enough. You can easily now see the separation and you can see the extent of the spread distally as well as proximally, both.
Yes, quite well appreciated.
And won't this view be good view to put a catheter right in this plane now?
I know some people like to do it, but I would just go back to the usual view, put in a 2He there and ensure that, the cath is sitting on top of the saphenous as well as the nerve to VM. Okay, so that is the adductor canal block.
And in this view, what are the chances of, if you go continuously without identifying the nerves, what are the chances of injuring the nerve to vastus medialis? Like
well, yeah, I think we are in a facial plane and you saw that we pre-dissected before we approached the nerve.
Right.
We are not aggressively needling here. We're not looking at breaking through any paraneural sheath. So again, gentle needling, I think you should be all right. Of course, there are other reasons why we can create a neuropraxia or something there, again with the local, with your volumes and things like that. But with the needling, I think we should be all right with this. Ritesh wants to say something.
Yeah, Harshal.
Yes, Dr. Ritesh.
The identification of nerve to vastus medialis is required. If you see the trajectory of Amjad needling, he has come almost flat.
Yep.
Maximum of us, we don't come so flat. So in his single injection, nerve to vastus and saphenous both were blocked. But if you come in a steep angle, which maximum of us do that, usually the nerve to vastus medialis will not get soaked.
Right.
Yeah. So you have to identify the nerve to vastus medialis if you want to have a very good analgesia post-op, and it's not a wrong idea of using a PNS, because if you injure that nerve, you had a good block, but the patient will have a atrophy of the vastus medialis muscle.
Right, thank you.
Yeah.
Thank you, TVS sir and Dr. Amjad.
Thank
Nice
you.
depiction of the block. And I must appreciate, most importantly, the nicely sleeved probe.
Thank you.
Any questions from the audience?
We are switching on.
There's a question. What drug did we use total for the IPAC and as well as the adductor canal?
0.2 ropivacaine, 20 ml at each of these places.
Right, sir.
So we are moving on to the next block. We have fracture ulna on the left side, and Dr. Gopal is going to demonstrate a lateral infraclavicular block. So lateral infraclavicular block with ultrasound. We might use a peripheral nerve stimulator. It's ready. We'll be injecting 20 ml of 0.5% bupivacaine and 2% of xalocaine. We use adjuvant sometimes. If it's a daycare, we don't. If it's if the patient is admitted, yes, we do that. And if it's for the study purposes, so we use clonidine 30 mics or 1 mic per kg. We don't use dexamethasone. We don't use dexmedetomidine. The rest of the questions for the adjuvants can be directed to Philippe Luc separately. Gopal, are you ready?
Can we keep betadine?
So meanwhile, when they are getting ready, small corrections for the audience. In the first block, there was a slip of tongue by Dr. Ritesh, and it was supposed to be, not supposed to be intra-abdominal drug spread. It was supposed to be cephalic spread, what he meant. That is one. And in the second block, the knee is externally rotated. So that is the small correction.
What is it, Ujjwal? Can you update us?
No, one thing in the first SIFI block, which Ritesh later on corrected, he mentioned it twice that the drug is intraperitoneal. So
no, he corrected it later on.
Yeah, later on corrected, but that the full volume was not reached till here, so I corrected it.
Yeah. So yes. So that's okay.
Yeah. And for the second one,
yes.
the knee was supposed to be externally rotated, slip of tongue. So it was, sir mentioned internally rotated.
Yeah, a lot of slips of tongue today.
Yeah.
That's
fine,
that's the yesterday's effect.
Drumming effect.
More than that.
Can I just keep this here? Yeah.
I think we must appreciate all the efforts taken by the entire team of the Sancheti Hospital as well.
Sandeep, why did we not add an adjuvant for both this block for the TKA?
Which ones?
The adductor canal block. So
no, we do add adjuvants. Maybe it might not have been added today, but 30 mics are routinely added, Bala, for all these blocks.
Yeah. So
except for the daycares.
So I think if we add just 4 milligram or 8 milligram of dexamethasone to the adductor canal, I think the duration of analgesia is close to 18 to 22 hours. So
yeah, I agree. So you're ready?
Increase the depth a little more, Amjad.
So if you can just have what the patient's position and arm extent, please.
Yeah.
So the patient is supine.
Morning, Harshal.
Morning, sir.
We have a 34-year-old patient with a fracture of the left ulna. He is ASA1, fasting. He's got an IV line and all the monitors attached. He's lying supine, and the operated arm is now extended. He has a bit of pain, so he's not been able to extend totally. I've placed the probe just distal to the clavicle, and this is called the parasagittal placement of the probe. And as you can see there, you have the skin and subcut tissue on the top. I'll request Amjad to just point out. And the big muscle beneath that would be the pectoralis major. And then you have the pectoralis minor below that.
Yes.
And you would see the pulsatile vessel there, which is the axillary artery. The subclavian artery becomes the axillary artery at the angle of the first rib. And medial to that, you will see the axillary vein, which you can actually compress by pressing down with the probe.
Yes, I appreciate it.
Now, you will see that you have the lateral cord, which is clearly standing out there. The posterior cord is not so easy to pick up, but in this case, it could be at the 7 o'clock position. That could be the posterior cord somewhere around there. And the medial cord, when you just move the probe a bit, you will see it lie in between the artery and the vein. So we'll start the injection by giving him a bit of local anesthetic. Have you given? No, he is quite a tense chap. I assured him that he will not have any pain. You see an accessory artery there, which is just in the vicinity of the
exactly.
Lateral cord. So we must take care to identify these vessels and ensure that they are not injured. We will do a double injection technique to begin with, and if the U-shaped spread of local anesthetic is also spreading to affect the median, we'll just leave it there, the medial cord. Otherwise, we will just try and do a triple injection technique. एक injection दे रहा हूँ छोटी सी. I'm just giving a bit of local there. बस हो गया. So that is actually going into the muscle there. I will use a 100 mm needle. एक और छोटा सा इंजेक्शन मैं आपको बताया था ना, बस बिल्कुल छोटी सी. I'm going in plane. The needle will go in plane. You will see the needle actually go down there. I'll try and image the needle better for you there.
So needle trajectory is cephalocaudat, sir?
Yes. Yeah. Now I'm at the lateral cord. We'll just turn on the nerve stimulator to just see if okay, we see the stimulation there. Oh, we'll turn down the, and I'll request Dr. Nitin to gently aspirate and give the local anesthetic.
How much was the current given, sir?
Sandeep, so that's my needle there. You can see the lateral cord now. It's beautifully
Yeah, yes, we can
delineated.
see that. Yes, sir.
Okay. How much have you given? Just 3 mils of local anesthetic has been given there. And now I'm just going to advance to go just posterior to the artery there. Yes, I got that little bit of a pop. I'm just posterior to the artery. You see that twitch? Sandeep has just turned on the nerve stimulator.
Yes, sir, we can see that.
Okay, now we'll tone it down and we will go ahead and I'll request Nitin to inject. Please inject Nitin. Aspiration is negative. You can see the local anesthetic going just posterior to the artery now.
Yes, sir.
As well as some sipping on the medial side.
Yeah. Now you can see that spread is actually going to the medial side also. It's lifting the artery now. We'll give around total of 10 ml here. Yeah. So we've given 3 at the lateral cord and a total of 6 mils here. And now, for the purpose of demonstration, what I'll do is, you can see the medial cord also now.
We can see the medial cord, yes,
It's
sir.
very well delineated. You can see the posterior cord, you can see the lateral cord, and I'll just go across to the medial cord for the sake of demonstration. That's my needle there. Yeah. I'm at the medial cord. I'll ask Nitin to just gently aspirate and then inject. I'll just go in a little more. Yes. Please inject. That's the medial cord now. You can see it being pushed down.
Yes, sir. Below the tip, yes.
Yeah. Another 2 ml. 2 ml.
And the vein also getting compressed.
Yeah. Okay. Now you can see, I'm just bringing the needle out under vision. We'll do the scan now. You can see the lateral cord and the medial cord extremely clearly, surrounded on all sides by the local anesthetic.
Yes, sir.
And picking up the posterior cord that is where the posterior cord is. it is not just posterior to the artery. It is probably around the 7 o'clock position. All right?
Yes, sir.
Yes.
Okay. So with that, we've concluded the lateral sagittal approach to the infraclavicular brachial plexus block. Thank you, Harshal.
Thank you,
Any
sir.
questions?
So just one question is when you went in with the needle, you started the nerve stimulator after you reached there.
Yes.
But for someone like me who's handling, would you recommend me starting the nerve stimulator as I go along rather than? I know in your hands it's great, but
No, preferably not, because multiple twitches that you get as your needle advances tends to distract you, and it also displaces the probe.
right.
So it is always better to view the cord with ultrasound, and once you believe it to be in the correct perineural position, the tip of the needle, it is best to turn on the nerve stimulator then.
Right.
And the moment we observe the desired twitch, we turn off the nerve stimulator and go ahead to inject the local anesthetic. So total volume that we've injected is 14 mils in this patient.
Right, sir. So Bala sir has a question.
Dr. EVS, it was excellent demonstration. Just want to ask for the benefit of all the delegates. Would you also prefer a costoclavicular approach to this block, or just for demonstration purpose you decided to go for this?
No, we imaged this patient outside in the pre-op holding area. He has a lot of pain because of the fracture, and he is not able to extend his hand totally. So if you can see, the hand is extended and again flexed at the elbow.
Okay.
So for me to place the needle would not be, I would not get a very good window.
Okay.
And the upward displacement of the clavicle also that you would expect when the hand is totally extended outwards is not possible in this patient.
So that was a good take-home message on when to choose costoclavicular versus infraclavicular. And number two, I also wanted you to tell the delegates what machine that you're using, because you saw the excellent cords.
Yes.
So it's not always possible. I just want them to show this is the Sonosite PX, the high-end model.
This is the Sonosite PX. It's been unveiled actually in the Aora Astra meeting in Mumbai last year. And they have begun commercial production. My colleague Ritesh, who works in Care Bhubaneswar, will be getting it shortly. And I will be following him. In the next 2 months, I should be having one with me also.
So the point I wanted to mention is, don't expect to see these cords all the time when you are using an M-turbo, and where you may have to go more in terms of placing it like a U in relationship to the artery.
Yes.
So one more question to you, TVS.
Yes.
An extension of what is just discussed about the visibility. In that case, would you really go to the medial cord, or would you be satisfied creating a bubble below the artery, assuming that all entire neurovascular bundle would be bathed in any case, in a lesser experienced hand?
Yes, ideal would be to target the lateral cord first, because that's the first cause that the needle would encounter as it makes its way towards the artery. And the next would be to place the tip of the needle just posterior to the axillary artery and perform an injection so that there is a U-shaped spread. Medial cord, actually you don't need to target individually. I mean, for the purpose of demonstration at workshops, we do it, but ideally there is no real need to do that.
Vrushali, there's a septum there between the lateral cord and the posterior cord. You could see Gopal say that there was a pop. It means that he penetrated that particular septum. Now, when you inject just below the artery, single point of injection, it seeps through this septa, and it also covers the lateral as well as the medial cord. So single point injection, it helps in soaking all the cords. Only thing is you need to scan lateral and medial to the axillary artery and see both these cords are soaked or not. Based on that, then you can decide upon further injections.
Sir, I have a question.
Yes, sir, one more question, sir.
Yeah. As Bala sir said, ki costoclavicular was not given in this patient, but can we see the drug spread after giving the lateral infra, while scanning the medially, can we see the drug spread, the costoclavicular?
Let me try.
Thank you.
Can we have the scan picture, please?
See, that's the... Oh, you're not seeing the picture yet?
Yeah. Now we are seeing. Now it's
Okay.
visible. Yes.
Now you see the artery there. I'll ask Amjad to point out skin, subcut tissue, pec major, which is the clavicular head of the pec major, and the muscle beneath that is the subclavius. And you can see that the cephalic vein is crossing over the artery to join the axillary vein. And when I release the pressure of the probe, you can see that. When I press the probe downwards, you can see only the artery, even the vein is being compressed. Now the hypoechoic structure beneath where Amjad will just go a little below, that would be the serratus anterior. That is the serratus anterior. You can see the pleura move, and just lateral to the artery would be your costoclavicular space. And in that costoclavicular space, you will have all the three cords. You will have the lateral cord, which I'll request Amjad to point out. Then the medial cord, that's the medial cord, just above, yes. And the posterior cord is just a little lateral to that. But then you can see more than one hypoechoic structure there, which is what Sandeep tried to tell the other day. That could be the posterior cord, that could be the posterior cord as well. So I'm not really too sure which of the two is the posterior cord. But here you can see the lateral, the medial, and the posterior cords quite clearly in the costoclavicular space.
So
is that appreciable?
Yes, sir.
So the costoclavicular space, it doesn't necessarily mean that you see only three cords. You see several hypoechoic elements. This could be a part of divisions which are really coming down, or it could be some variants. You have to go through the literature. We have recently uploaded this in a case, retrospective study case series. We have got several questions which keep on coming. We have to answer the last series, and then let's see how it. So we have the next case ready.
Thank you.
Harshal?
Yes, sir.
Yes, sir.
Nice depiction, sir. I think no
next
more questions from here.
No, please don't ask any questions. Thank you so much. The next case is a continuous thoracic spinal. Is Ophelia there? Ophelia, is she there in the crowd? If she is there, can you please ask her to come to the dais? Harshal?
No, I don't think.
Okay, that's fine. So we start with the next case. Dr. Praveen Talwar is going to start the continuous thoracic spinal catheter technique, and Dr. Avinash is going to assist him. So that would be the last case. So based on that, you just ask Sandeep Mota and Sachin Arbi whether we should continue with the didactics, and then at 11 we take a break for the function. You can just ask. So he is going to come at 11. So we can have at least 2 lectures, and then we can have the PRAC function, and then we can have the didactics, the rest 2 lectures later on, the last ones. And with the spine demonstration by Sunil Pandya. Ask him to be ready with that, because we have given him a small counter where he can prepare.
I think he's already ready, sir.
Oh, that's good. Thank you so much.
बस झुक के बैठना है। इसके ऊपर डाल, हाँ। तो उसके ऊपर कवर कर दे, कोई दिक्कत नहीं।
So just to ask, what level is that the procedure is being performed at?
Can you hear us? Sandeep sir? Dr. Avinash?
I don't think they can hear us.
Peter?
Hello, can you hear?
Sandeep sir,
Sandeep
what
sir, are you-
level is that being performed at?
So this is around T12 L1. Praveen will take over from here.
Good morning everyone. I'm Dr. Praveen Talwar. I would like to thank Dr. Sandeep Diwan and organizing team for giving me this opportunity. He's a 17-year-old male patient. He had a crash injury around 2 months back. After that, he underwent a groin flap cover for the left upper limb. And now he's posted for flap division. That the site of surgery is around T11, T12 area. For the sake of demonstration, I'm using thoracic continuous spinal anesthesia in this patient. I would like to show the equipments first. I'm doing the thoracic spinal at the T12 L1 area, that is lower thoracic area, that was originally demonstrated by Professor Thomas Janescu in the first 2 dorsal punctures. The set usually comes with a stillet, but I lost the stillet. I'm using the some blade here. After that, this is a 21 gauge. This is a pine set. That is a 21 gauge needle. This has a special sprotty tip needle with a traumatic needle, and it is a 25. It comes with a 25 gauge catheter. It is reinforced with a guide wire. And after that, we have a connector and the filter. I have loaded 2 drugs. One is an adjuvant, that is fentanyl, and local anesthetic, that is heavy bupivacaine. Now I'll proceed with the procedure. I've already marked the T12 L1 area. आगे झुकना है. So in the recovery area, I've done pre-procedural ultrasound. In the midline, it is the depth of posterior complex is coming around 4 centimeter here. Usually the ideal technique is to insert the needle similar to the spinal, lumbar spinal, but for the extra precaution, we have to, every 1 mm, we have to remove the stillet and look for the CSF flow. But since I've already done pre-procedural ultrasound, the depth is around 4 centimeter, the posterior dural complex is around 4 centimeter. I can free, and this is a 9 centimeter needle. Okay, आराम से. I'm using the midline technique. Every 2 mm, you have to remove the stillet and look for a CSF flow. गहरी गहरी सांस लेते रहिए. So I got the CSF now. I got around, this is 1, 2 centimeter is outside. So the depth is around 6.5 centimeter. So 6.5 plus, I would like to place 3 centimeter inside. So and the threading the catheter like. Usually 15 to 20, like epidural. Around 15, 15 or 20, maximum 20, sir. Sir, I'm using this for a major abdominal surgery. So I have 20 centimeter pass. I'm just removing the needle.
So how much did the catheter go in? What is the length you put in?
Sir, I got around 6.5 centimeter.
Right.
So here it is around 15 centimeter. So I'll keep around 11 centimeter, 6.5 plus 3. That is around 10 centimeter I'll keep. So 15, 14, 13 is outside. So 12, 11, and this is the 10 centimeter.
So 3.5 centimeters inside.
Around 3 centimeter I'm keeping it inside, sir. 3.5 centimeters inside the intrathecal space. Yes, sir. So where would be the catheter tip now like? Like around, I introduce around T12, L1. This catheter must be around T9, T10.
Is that level the same every time, or do you change the
Sir,
level?
according to the indication here, the surgical site is in the lower abdominal area, so I chose a lower thoracic. I usually use for a major abdominal surgery, where I usually enter the needle at T11, T10, T11, and keep the needle around 5 centimeter, around at T7, the tip I usually keep it around 5 centimeter. I am removing the guide wire. I doubt CSF is not coming. Should look for a CSF flow.
It should come, since the guide wire has been just removed, and you keep the catheter a little dependent, it might come a little. It takes weight, the needle gauge might be too low. What is the catheter gauge, sir? The 21 needle?
25 gauge catheter.
And would it be a good idea to attach the connectors and try gentle aspiration with maybe tuberculin syringe or something?
1 ml syringe also. I'm sorry, I'm not getting.
So you would want to manipulate a catheter a little bit, maybe half a centimeter or something?
1 minute. थोड़ा खांसी करिए लक्ष्मण जी खांसी करो थोड़ा
So what are your troubleshooting if this, I mean, this can happen to any one of us. So is there something that we can do or?
Like we have to place the catheter again, sir.
So but with the guide wire out, is it possible to use the same again?
No, it is not possible. Like we have to use the other set.
Right.
So we'll go with the single shot in this case, single shot spinal.
Right.
I'm very sorry for the.
No problem, sir.
Okay, sir. Thank you.
So just continuing with the discussion, in the earlier preparation, you used a stab knife.
Yes, sir. Yes, sir.
To make some path for the needle after giving local.
Yes, sir.
And this set comes with a
Lancet. I lost it while.
Yeah, small kind of a knife or something,
yes,
blade.
Sir. Yes, sir.
But would you choose, if that is not there, would you choose a large bore needle to make a track time?
I usually use that large bore needle that comes with a BT set for the needle through needle technique. Like use a bigger needle as an introducer.
So what is your what drug would you give if for this procedure, and what additives? You said you have an additive there.
Sir, I usually give a fentanyl additive first, when followed by hyperbaric bupivacaine or isobaric bupivacaine also be used. Usually for continuous spinal, after making supine, the graded doses of 2.5 milligram aliquots are given. And every 3 minutes, the levels are checked. Once the desired levels are achieved, you can stop the giving this loading induction dose.
Right.
So that induction dose can be, if the surgery is prolonged, that every hour you can supplement either intermittent bolus, or you can give continuous infusion of the same. Suppose if I get for abdominal surgery T4 to L1, if I suppose achieved T4 L1 by 2 ml, that 2 ml per hour infusion, or you can use every 1 hour you have to repeat that 2 ml plus adjuvant dose.
If you have to give it single shot, what is your dose? Would you?
This is for I'm talking about continuous, sir.
Yeah, no. If you have to do it single shot.
Since this case, like around 3 dermatomes, so 1 to 1.5 ml would be enough for this case. 1 to 1.5 ml total dose.
Same for both hyperbaric or isobaric?
Actually, for isobaric, that 1 ml covers like 2 segments above and 2 segments below. In the hyperbaric, it usually goes along the gravity and along the curvature of the spine. It depends like how the patient is positioned on the table.
And do you keep the patient in a specific position after the drug is injected, or just like any normal routine spinal?
Sir, I usually use it for abdominal surgery. So I was using a hyperbaric bupivacaine. So I was giving the drugs in the supine position.
Right.
So till T4 L1 is achieved in the that level, we have stopped and patient is operated in the supine only.
Hello.
Yeah, one doubt.
Can I have a question?
Yeah, one doubt, sir.
Yes,
so
we have a
you
question.
have kept the catheter at 10 centimeter. The audience had a doubt that what's the needle length?
It was a 9 centimeter.
And the posterior complex on USG was 4 centimeter. So how come the spinal space is at 6 centimeter? That was the doubt.
Did you get the question?
Yes,
I think.
Naresh sir was asking some questions.
Hello. Dr. Paliwal here. Hello, Praveen. Can you hear me?
Yeah. Dr. Paliwal?
Yeah. Why did you insert the catheter 15 centimeter inside when you knew that it is just 4-5 centimeters, and you want to keep only 3 centimeters inside. There are chances that it may entangle a nerve root. It's not an epidural catheter, it's intrathecal catheter.
So did you get both the questions or?
And the other question is, what is the dead space of this connector and the catheter you are inserting?
This is around 0.7 ml, sir.
Pardon?
0.7 ml.
The total dead space is around 0.9 ml. 0.35 ml of the adapter and
with the adapter and everything is around 0.9 ml.
0.9 ml, that should be taken into account when you inject the drug.
Yes, sir. Yes.
And what do you do when you inject the next dose? Do you take into account the dead space?
The level at which I am achieved around the dead space, I'll not be counting. So every hour I'll be checking the dermatomes.
No, my question is, when you inject the next dose,
yes, sir,
do you take into account the drug remaining inside the dead space? It is around 0.9 ml.
So next time also it is also going to remain, sir. So I'm not going to.
Do you flush it with normal saline?
No, no, sir. No, sir.
So how long do you keep the catheters?
Sir, in my study I kept for 3 days, sir.
I have a question.
There's a question from the audience here.
Yeah, my question is very conceptual, sir. I would like to really know, I can see clearly there are a lot of complications which can come with this. And in this era, when we are trying to move away from centroneurexal block to peripheral nerve blocks, I mean, I really want to know what is the major indication when we should do this. Second, what are the safety measures you take? Because I can see it's a blind procedure.
Okay.
So, cord is so close,
So-
I'll be very worried.
So since this procedure is not much studied, so previously this continuous thoracic spinal has been used for patients with impaired pulmonary function and geriatric patients with multiple comorbidities. So to avoid any legal hassles, we should usually, where it is indicated, where GA, when other alternative anesthesia techniques are existed, you should go for it. But when standard techniques like general anesthesia or other technique poses a high risk, then only you should consider this patient. And regarding the safety, like we can use, since ultrasound is available, ultrasound spine can be done. For depth, you can use ultrasound assist by marking the, like you can measure the depth of skin to posterior dural complex.
So, sir, if, because I'm sure all of us are seeing and they are postgraduates here, they're all learning from this technique. When will you say what should be the learning curve? When should they do? Or if somebody who is not so experienced, at what level they should try this out?
Like the first, everyone should know the lumbar spinal and thoracic epidural. The third year residency, you can allow the person to do this perform under the supervision of consultant.
This can be a technique
you,
when
sir.
you get accidental dural puncture during thoracic epidurals or during lumbar epidurals, especially for labor analgesia, or in case you have a very morbid ill patients, then you can use this as a rescue technique.
Okay, sir.
And one question, Dr. Praveen.
Yes, sir.
Whenever we reach the space,
Yes, sir.
and you remove the stillet,
Yes, sir.
and by the time you introduce the catheter, there is a lot of CSF trickling down.
So we should keep that stillet till we get the catheter near the stillet. Then only you should remove the catheter stillet. So by that we can reduce the CSF leakage.
Would it be a good idea that once you enter a good amount of space, you remove the stillet, introduce the catheter, keep it halfway between, and then proceed further, and when you get the giveaway, it would be a good idea. I'm just questioning.
No, sir.
Reduce the...
like stillet should be in place.
Like we do in epidural with loss of resistance syringe.
Mhm.
So, can we have this?
I have no experience, sir,
Okay.
regarding this. I can't comment.
Okay, okay.
Would it be a good idea to first get a thoracic epidural in this patient before and get the LOR and get the epidural space and then introduce your needle a little ahead and get the intrathecal space?
We can do that.
Because
ma'am.
that would make it much safer.
We can do that. I have done, but after practicing many like 60, 70 continuous thoracic spinal,
because that would tell you the depth, the trajectory.
Okay, that you can do that, but it is an additional safety measure.
Because I think in the yesterday's lecture also where they demonstrated the continuous spinal, she first got the thoracic and then she introduced the needle a little inside and then she guided the catheter in.
For you want to make for 100% sure, then you can localize the epidural needle, then followed by the spinal. Yeah. That is a good idea. But
especially because you're going in the thoracic space, because you know that the next thing you would hit is the spinal cord if you are just a little more in.
So with this, we conclude the live session. May I, one question for Dr. Gopal?
No, I was exactly going to do what you're doing. And thank you. That was a great demonstration.
Thank you, Dr. Praveen.
Audience.
Thank you. And sorry for the failure of this.
No problem at all. It's a good learning lesson for all the audience that they don't jump to it.
Yes,
that's
sir.
all. So may I please invite Dr. Bala Venkat sir, Dr. Vrushali madam and Dr. Sinha sir on the dais, please.
Well, just special thanks to the team of the Sancheti for giving us this lovely live demonstration, and to all those people who helped us do it. So round of applause to everybody.
And round of applause to the AV guys. Peter Anand, nice show.
No, just we have 15 minutes for the tea. The first session, we didn't have the question answer session. So if there are any questions for the blocks that were done so far, or the first session on pediatric and orthogeriatrics, there are any questions, we can take it.
Sir, regarding the orthogeriatric session, most of the patients will be on clopidogrel or some other antiplatelet. So how do you optimize the early surgery?
Yeah, that's a very, very good question. Because we had a session for 45 minutes yesterday on antiplatelet therapy and the neuraxial block, and I think it's very pertinent when you deal with a geriatric patient. Because if you see, the studies clearly indicate when in proximal femur fractures, especially in geriatrics, if the fixation is done within the first 24 hours, the outcomes are excellent, the morbidity is less, and the mortality also increases the more you prolong. So now the question comes in, if your patient was on clopidogrel, he fell down, he came to you, is it okay to wait for 5 days, or do you have other mechanism? That's an excellent question, very practical. And after the 45 minutes discussion that we had yesterday, so it's now clear that initially it was believed that 5 days of stopping clopidogrel is very crucial, but now the current studies indicate that the rate of platelet production after the dose of clopidogrel, within 3 days, there is adequacy of platelets that are produced to form a platelet plug. So now the studies clearly indicate that it need not be 5 days and 3 days. Now the next question is whether you can do this case earlier with a general anesthetic, avoiding a neuraxial. So it has to be case-based and it has to be individualized. So what I'm going to confess what I do in my institution, even if they are on clopidogrel. And also very important to know, you have that study, Siva, can you project it on the effect of 1 tablet of clopidogrel on the platelets? Does it affect the entire platelet community on only one small percentage, like 50 to 60% of platelets are affected? Still 40% of platelets are available in spite of patient on clopidogrel. So which clearly indicates that the total amount of platelets that are needed to produce a clot is only 40%. Do you have that study?
I don't have that data, but the children who were suffering from congenital clotting factor deficiencies, they found that if we give 40% of the clotting factors, that is adequate enough to achieve the surgical hemostasis. So these informations comes from those studies. If you have 40% of the platelets and the clotting mechanisms are in place, we can have a satisfactory surgical hemostasis. So similarly, when you discontinue the clopidogrel, our platelet production comes up, considering the turnaround time of platelet of 4 to 5 days, at the end of 48 to 72 hours, we have at least 50% of effective platelets to achieve our surgical hemostasis. So that is the concept behind it. So the studies are now appearing. Even at the end of 3rd day, you have a satisfactory platelet load in the patients to have a effective hemostasis. But the guideline says still 5 days to stop. It comes from the drug manufacturer label because they couldn't able to violate it. That is why the guidelines are come from that end. But now the studies are coming up to say this. Now initially how the aspirin has to be stopped, but now they have taken out from the guidelines is because the evidence has accumulated that the patients on aspirin, it is not dangerous to produce a hematoma. So that is how now the clopidogrel also in place. As the more and more the studies have come out, the guidelines might change in future.
So a few take-home points as far as antiplatelets are concerned. Aspirin, continue it. No, please do not stop aspirin, number one. Whether it's 75, 150, and even up to 325 milligram, perioperatively continue aspirin. If the indication was aspirin was a cerebrovascular accident or a cardiovascular accident before, number one. Number two, if you stop clopidogrel on any of this patient, please start aspirin immediately because the patient may land up with another cerebrovascular accident. That's number two. Number three, if you think the patient is not, you are working in a setup which it doesn't allow you to give general anesthesia, or patients have multiple comorbid that general anesthesia will be detrimental, I think considering the fact that clopidogrel adequacy is present and early surgery is fine, and recommendations are on case basis in consensus with the surgeon and the attenders, do with the neuraxial block with a written informed consent about the possibility of epidural hematoma. But the point now is because the guideline says, and you don't want to have a legal issue, get a written informed consent, but wanted to tell you that adequate platelets, functioning platelets are available, and probably in another few years you will see a new guideline coming in relation to clopidogrel. So this is the take-home message. Do not allow the patient to die for waiting for 5 days because they develop multiple other comorbid problems. Only thing is they have to go home. So, and for this, but very important, if there are postgraduates, do not tell this in the exam and you may get failed by the examiner. So this is for the practicing people, and I think you need to do it on a case basis.
So now another important regarding the hematoma formation, can I have the slides, please? For all the residents, and then now if you look at, this is from the ASTRA guidelines which has been before published. If you look at the estimated incidence of spinal hematoma and neural anesthesia, if you look at, if the patient is on heparin, the risk is 3. But if you do a traumatic puncture, the risk is increased to 112%. So now who is the culprit? Is the heparin or the performer?
This is an excellent point actually. So it has to be done by a senior most anesthesiologist, provided he's a person not into administration and clinically working.
So I mean, this is in the guideline. This is how they have calculated the estimated risk. You just imagine the estimated risk is 100 times more from a traumatic puncture. So more than the drug, we need a competence assessment of the performer. That is what exactly Bala sir said. Now, as the evidence accumulates, the senior most person has to do the lowest gauge needle, atraumatic puncture. Still, we can provide the benefit of regional anesthesia. Of course, you have to take all other measures. Informed consent. Clearly, the entire team will agree why you are trying to do so.
And just one more point, that when you go in detail about how aspirin works and how clopidogrel works, aspirin on primary platelet plug, clopidogrel on the secondary platelet plug. And the vessels that are present in the epidural space are very small. Actually, a primary platelet plug formation is enough to stop a bleeding. And if you see 1+1, I think clopidogrel has got absolutely no role. This is just to provoke your thoughts. And I want you to read more on this. And this is an absolute gray area, which I'm sure more lights will be thrown in the days to come.
Shiva, in that case, would it be apt to say that if you get one puncture, if you don't get a spinal in one puncture, then may as well wait? Would it be apt to say that? Because you said it shouldn't be multiple punctures.
Yeah, I mean, that is how the motto with which we have to do. And for
Might
doing
still happen in a very experienced hand.
So now,
actually, one point I would wanted to tell you was all these hip fractures also have a degenerative spine. So definitely it's going to be a problem. And many times they have a associated kyphoscoliosis. The take-home point I would like to give is, if you have a case like that, go to L4, L5 or L5S1. They do not participate in the scoliosis that happens, and your success rate in the first pass is very high.
So 2 questions. Shailesh, you wanted to ask a question. Meanwhile, Sandeep, could you please put your comment?
About stopping aspirin and clopidogrel. 4 surgeries, 4 type of surgeries, you stop both. That is intracranial, intraocular, spinal, and TURP. And you can take them on a bridging therapy. Rest of the things, aspirin can continue whatever amount it is. So, but only for these 4 surgeries, if it is there, ideally you should stop both, and that is recommended in the recommendations.
yeah, I mean, towards the atraumatic puncture, now the ultrasound assessment of the spine is coming up in a big way, because so far ultrasound has established its place in the peripheral nerve blocks. But as we do more and more ultrasound to locate the spinous process, interlaminar space, the difficulty with which we handle these patients has tremendously changed. So we have coming up with a lot of new surface landmarks with an ultrasound, so that if you use those points, our ability to access the intrathecal space in a first attempt is definitely enhanced. So ultrasound is a great help in dealing these sort of a difficult scoliotic, elderly, all calcified spines like L5S1 space. All these windows you can see clearly, and your atraumatic attempt should be very grateful in that.
Okay. So
any other questions in terms of nerve block? Yeah.
Hospitals have the facility to do a TEG to assess platelet function, and if there is a patient who is on clopidogrel, you can do a TEG pre-operatively, maybe not just then, and then go ahead with this.
yeah, so I mean, TEG is an option, but we all talk about India in general, and theoretically yes, but practically for a private practitioner and the rest of the country where there is no TEG, I think we need to rely more on.
Thank you.
Yeah, thank you so much. We'll go for a cup of tea. No? No cup of tea? Okay.
I request everybody to be seated, because we will have a PRAC inauguration and convocation just now. So I would request everybody to be seated. Our Chief Guest, Dr. Parag Sancheti, has just arrived.
Yeah, I think that's a request. Sorry for that. And welcome, Parag Sancheti, sir. May a round of applause to Dr. Parag for giving us the opportunity, opening up his operating theatre, giving his entire anesthesia team to conduct the Academy of Regional Anesthesia meeting. So we are indebted to you for all that you contribute. If every surgeon is like you in this country, anesthesia will grow profoundly. Thank you so much. And I think to make sure that we give back our kind gesture to him, I would like all of you to stay back and not go for tea now. And we will request all of you to listen to Sir on what he has to tell us. Thank you so much. And over to Dr. Sandeep Mutta to take over.
Sir told Bala sir. Yesterday also. start the PRAC inauguration. I request Dr. Sadre to audit the session.
Good morning, everybody. I welcome you all for the Lifetime Achievement Award function. We have to wait for 5 minutes because our Lifetime Achiever is just going to come after finishing our live demonstration. So please bear with us. I'll just begin with the Ganpati Vandana. Sir will start. Sorry. I will just recite Ganpati Vandana first. Vakratunda Mahakaya Suryakoti Samaprada Nirvignam Kurme Deva Sarvakaryeshu Sarvada. I request Parag sir to start with his lecture. Thank you.
laptop கொண்டு வர சொல்லணும். ஆனே ஆகல. அதான் வெயிட் பண்ணு. கொடுத்துங்க.
I request Dr. Chaitrali to take over this mic and please follow.
Good afternoon, everyone. It gives me immense pleasure to welcome you all for the most awaited event of the entire ceremony, and that is the Lifetime Achievement Award. It is indeed an immense moment of pride to invite you all and see you all here. To begin with, let me just tell you that I have always been very fascinated by all these people, you people, because I consider you as fairy tale spinners. You are the people who make the patient believe in the fact that hospital stay can be pain-free. So thanks to you all for doing a great job and making the patient feel at home even at hospital. Thank you and kudos to you all. Now to begin with the day, let me please invite on stage Dr. Satish Kulkarni and Dr. Parag Sancheti. Please welcome on stage. May I request our team to please felicitate them. A round of applause, please. Thank you so much. Before embarking on this journey for the lifetime achievement, I request both our dignitaries to kindly proceed towards lamp lighting. Thank you, everyone. I would now request Dr. Sandeep Diwan to please take hold of the reins here for the further program. Dr. Diwan, please.
Thank you, Dr. Chaitali, for that comprehensive session. We welcome Dr. Parag Sancheti. He is the Chairman, Dean, and Director of Sancheti Institute, Orthopedic Center and Rehabilitation. I've been working here for last 8-9 years from 2015, and I've seen change in myself. We are coming up with a big second hospital, very close to that, and it's almost 14 floors, and we might move in very soon. We offer lifetime achievement awards to those anesthesiologists in regional anesthesia who have performed excellence in their careers for last 15 to 20 years. Not only that, but we have also offered these excellence awards to people, anesthetists who have been involved apart from regional anesthesia. We are fortunate today to have Dr. Parag Sancheti, who will bestow upon the achievers and the recipients. And these recipients are none other than my very close friends. The last time we had offered this to Bala Venkat in PRAC. And this time it's Dr. TVS Gopal, the chairman, of Aora, and Dr. Vrushali Ponde, who's also the chairman, and it's like she owns the Aora. So thank you very much for being here with us. I would now like to introduce you Dr. Vrushali Ponde. Dr. Vrushali and myself have been in clinical practice in regional anesthesia, and I call her upon the dais. Vrushali, please. And we started our clinical practice very long back, 25, 30 years back, and we have been together performing workshops together everywhere throughout India as well outside. So we four of us, in fact, Bala, myself, Gopal, and Vrushali have been doing that for the last couple of years. So she is she was the president till last year, and now she has been offered the secretarial post. It has come back to her. I'm very sorry for that, but we cannot help. She heads the program of WFSA, and this is the Children's Services and the Paediatric Regional Anesthesia Fellowship in Mumbai. She has got fellows from all over the world, and that really matters a lot to us. She has been in the education committee in the Aora and the CAS Paediatric Regional Anesthesia 6 months fellowship. The ASPA education chair and executive, the Asian Society of Pediatric Anesthesiologists. She has taken a very active part in this. She has been in this for last several years, and it's because of her that I was introduced to pediatric, this particular group, ASPA, where I was invited in Turkey, and I thank her also for that. She not only works in pediatrics, she also works in also offers adult services in regional anesthesia. We have seen her a couple of times performing block, and we have seen how excellent the pediatric block works. She has got book to her credit, 3 editions on illustrated manual Usgra anesthesia in adults and children. It has been translated in Japanese language, so that really sounds good to us as well. Not only that, it has been forwarded by Dr. Vincent Chan, I suppose. Yes, and he is one of the godfathers of regional anesthesia. That's what we say so. She has international and national research publications, and till today, she tops, what is that? She tops as the doctor in Mumbai, 2018, 19, 20, and 2021. She is a recipient of Bharat Jyoti Award 2020, and she regularly plays sitar. So that's wonderful, and she finds calmness in playing sitar as well. So thank you very much. Thank you very much, Vrushali, for joining us here. Dr. Gopal is coming in. So we now go ahead with the with felicitation of Dr. Vrushali Ponde at the hands of Dr. Parag Sancheti. We now request We now request Dr. Vrushali to provide her acceptance speech.
Well, we all work, don't we? Let me first begin with a very heartfelt thanks to Dr. Parag, Dr. Diwan. I guess we hardly can differentiate each other from each other here in Academy of Regional Anesthesia. We've just grown together, worked together. Selfless probably is the correct word to describe, because we just had such fun working with regional anesthesia, learning it first of all, teaching it to everybody who would want to learn, and researching and innovating it, because the more we did, the more clinically relevant questions we asked, and the more we worked, and the more answers came out of it. So I guess it's such a seamless journey, and sometimes I wonder, oh gosh, I'm getting a lifetime award, so am I at the end of the stick out here? But it doesn't seem so, because you never work, number one, for awards, but however they do matter. I'll tell you how they do matter. They do matter because somewhere something is going right in your thought process. Somewhere something is going right in your words and your deeds. I guess that's more of an endorsement of what you have thought and what you wish to do and what you are doing. And it's an endorsement for all those people who have worked with you. And I'm sure some good must have been done somewhere so that somebody thought of you as a person to give something like a lifetime award. So this is all what I could humbly say, because I am so sure none of us worked towards getting it, but when it comes, it simply humbles us. Let me tell you a bit more about Sandeep. This was his brainchild to think about lifetime awards. Frankly, I never thought he will think of me. I never thought, first of all, at all, that he would think of something like this, because he always is very nonchalant about all that he does. And if there is anybody who deserves it, as much as me and Gopal and Bala does, is Sandeep himself. But he would never be right there receiving even a compliment, forget about an award. That's what Sandeep is all about to me, Gopal, Kulkarni sir, and Bala, and entire Aora. So, well, this is what I would say. And Dr. Parag, I know you are busy. I know that you are a very well sought after doctor in Pune, and you are here. Thank you so much. And you have supported Academy of Regional Anesthesia, which is personified in your hospital by Dr. Diwan to such a magnanimous extent. I know the research that goes on. I know the support you give him. So I am humbled. Thank you so much.
Our next recipient is Dr. TVS Gopal. Now, TVS Gopal and myself, we just spoke when we were driving to the theater for these blocks. It was in 2006 that we started these ultrasound-guided blocks. And we first met in AFMC for the live workshop. And I just had have returned from one of the workshops from outside India, and I had bought my own ultrasound machine, and I started my blocks then. And when we met, then we were discussing how to go about it. So way back, 2006, long time back, and from then since onwards, then we met each other in all the conferences. Then we have come to this level, taking Aora to the remotest area possible. It may be northeast, it may be south, it may be west or east, everywhere. So he has a company of his own where he has around 200 plus anesthetists in Hyderabad, and who fly to different areas in the country to anesthetize different kind of situations. He's in the Department of Anesthesia in the Care Hospitals, Banjara, Hyderabad, and he has got a DNB program, he has got Aora fellowships, he has got several things under his belt. what I found about Gopal was he's very strict, and he gets angered easily. So many of them, they fear going very close to him in Aora. It's not like what you go, yes. No, not me. So apart from that, he has a couple of articles in press as well. We just spoke about the bariatric anesthesia. It's not only regional anesthesia that he does. He caters for so many anesthetic procedures. Publications to his under his belt, as well as he has been invited by the national, state, the city branch, and of course the international branches. Yesterday you said me to be humble, but I think you are the most humblest to me. He also has anesthesia for orthopedic surgery and trauma, cardiac patients, non-cardiac surgery, and vascular surgeries. Walking on the streets of Mumbai after one of the workshops in your place, the old place where she used to invite me, Bala, Ashit, and Gopal, we formed this Aora. You must have heard that from Bala yesterday. It was just a thought, and with the 6 of us, now we have grown to 2,000 plus. So that's how it grows, and we want to grow it more and more. And we want you to spread this message to each one of us, to the periphery, to the remotest area, so that we can percolate into the remotest area. Dr. Gopal, with these words, I invite you to the dais. A big round of applause. Thank you very much for being here. We move towards the felicitation, and I request Dr. Parag Sancheti to felicitate along with Aora team. Dr. Bala, please. I request Dr. Gopal to deliver his acceptance speech.
I apologize for being late to this ceremony. Just got back from Sancheti after performing blocks. Respected Dr. Parag, dears Satish, Sandeep, Vrushali, friends amongst the faculty, and delegates. When my children got to know that I was being bestowed this Lifetime Achievement Award, the first thing they asked is, "Daddy, are you retiring and coming to stay with us in Australia?" So I told them no. God willing, there are many more seasons to go before I even consider retirement. I thank you very much for this honor, sir. This honor is testament to the individual contributions of each and every executive member of Aora India. It is a tribute to each and every life member of Aora India. It is a vindication of our collective faith when we took this step forward to start this organization, and hopefully will be a beacon for younger generations to take this vibrant organization to greater and newer heights. I remain eternally grateful. Thank you. Thank you so much.
I now request Dr. Bharati to give the vote of thanks.
Good morning, ladies and gentlemen. On behalf of the Pune Regional Anesthesia Course and Sancheti Hospital, I stand here proud and grateful to express my thanks to all those who made this event possible. I would like to first thank our chairman, Dr. Parag Sancheti, for giving us this platform and always be supportive and encouraging to excel in everything, whatever we do. I would like to extend special thanks to our stars of today's program, Dr. Vrushali and Dr. TVS Gopal. You have always been a guiding light and imparting knowledge and wisdom to the fullest. We are truly honored at your acceptance of this award. I take this opportunity to express my gratitude to all our faculties who have traveled from all over the country and even the foreign faculties who have shared their time and wisdom in this to make this August meeting a successful venture. Thanks. Am I audible like can I be seen? My sincere thanks to our audiovisual team. They have been working flawlessly and absolute no glitches in the AV management. Thanks to you, Mr. Peter Anand. You have been an angel. I thank all our sponsors and our event management, the VAMA team, for making this conference a grand success. A heartfelt thanks to all of you, all the delegates, for participating actively in this conference and taking it ahead. Lastly, but not the least, let me thank all the Aora team and the Sancheti team and the organizing team of this Aora 23. All the hospitals from the Pune had been here and taking part in the proceedings of all these 4 days, which is academic extravaganza. Thank you all.
I now request Dr. Chaitali to introduce Dr. Parag Sancheti and then the most awaited talk from Dr. Parag Sancheti.
Again, a very big good afternoon, everyone. It was indeed such an enlightening program to see such talent on the stage at one go. So thanks to everyone. Heartfelt congratulations to all the award recipients. A big round of applause for everyone, please. So, when in Pune, be like Punekars. Thank you so much. I would now like to invite on stage the one and only Dr. Parag Sancheti. But before I invite Dr. Parag Sancheti to the screen, to the dais for his next presentation, let me just introduce him. I don't think he needs any introduction, but just let me talk a few words about him. I know I'm going to fall short of words to cover his accomplishments. He is a man of few words, a mentor, a guide, a philosopher, excellent academician, and most important, a basic support system for all of us sitting here in the room. I think it's not only for us or for the anesthesia team or anybody at Sancheti, he has been a role model for a lot of other youngsters and people of us who have seen him in a definite position. We can call him nothing short of a living legend of sorts. With the hospital, with the Sancheti group of hospitals that he's already heading as the chairman, he's also the professor and dean at the Sancheti Institute for Orthopedics and Rehabilitation. He is a very renowned knee consultant, a knee surgeon, who has been operating and taking care of making people walk, which includes very eminent sports persons of national fame and also a lot of other celebrities. He is a visiting faculty for the MCH course at the prestigious University of Dundee. He is a visiting professor at McMaster University, Hamilton, Canada. He is the Secretary General at the Bone Joint Disorder. He is the President of Asia Pacific Knee Society. Besides having a comprehensive long list of academic accomplishments of FRCS, MCH, MS, DNB, he also owns a PhD, again from the renowned Dundee University. Besides this, he also has an honorary FRCS degree, which is conferred upon him by the Royal College of Surgery, Edinburgh. He has got to his name multiple orations at various different national and international conferences. He is the person who has operated almost more than thousands of people, made them walk, bear their weight on their knees, and much more to come. Besides his academic accomplishments, his accomplishments in starting the MS course, we are also looking up at a new project which is coming up along with the existing Sancheti Institute of Ortho and Rehabilitation. We are expanding our wings. We are now going to begin with a new hospital, which is a glorious 14-floored big hospital, which is going to specialize in ortho and the allied branches. Besides all these accomplishments, he also has a lot of awards. I think I'll again fall short of time and words to mention all his accomplishments here. But he has been conferred upon by the Rashtriya Seva Puraskar, the Award of Excellence by the Governor of Maharashtra. He has received the Mitcon Achievers Award. He has also been awarded the Icon of Pune, along with Inspiring Orthopedician of India by the Economic Times. Besides this, a number of other social awards being honored to him. He's also been on the Hall of Fame. He has got, again, the list is again extensive if I keep on mentioning, but a lot of books published, besides a number of chapters mentioned in various textbooks. Well, his accomplishments don't just stop here. He has played a very big role even in serving patients outside, overseas. He is an ortho consultant to the Ministry of Health, Oman. With all this introduction, I would now request Dr. Parag to please start his presentation. Thank you so much.
Thank you so much, Dr. Chaitali, for the kind introduction. I don't know whether I deserve it, but all the same, it feels good sitting there and listening and getting pats on the back. But today I'm here to talk to an elite group of anesthetists. And when I was talking to Sandeep on what topic I should choose, and then we thought it should be something related to the anesthetists who are always behind the screen. And this is an evolving paradigm, and by the time I finish, I think you will know why I say so. This talk is going to bring out the surgeon-anesthetist relationship, and that is why I have chosen this talk. Before I begin, let me first thank all the executive committee members of Aora, our president, Dr. Satish, secretary, Dr. Vrushali, and all the founder members, executive members for bringing Aora to Pune. I think it's a big pride moment for Pune and all the anesthesiologists in Pune to organize this meeting, and I can see since last 2 days the academic extravaganza which is going on. I want to thank the local organizing committee, for last 6 months, and I've attended a few of their meetings, day and night. They are working, they are talking, they are working on, how to make this conference better. And hopefully, by the time we finish today and tomorrow the workshops, all of you will go back enriched with some new aspects of regional anesthesia, which will bring a better outcome for your patients. I want to thank the international faculty who've come a long way and helped us to, improve on what things probably we don't do in India rather than what we don't know. But when I was talking to Bala Venkat, I think there is everything we do, and probably they'll go back learning from us. This is a plethora of the national faculty. I did not have, 125 photographs. Sandeep didn't give it to me, so I put the names. But it's all the Indian faculty, really, who make all the difference. Yesterday, I was amazed to hear Dr. Bala Venkat, the way he spoke, the Dr. Bhatt oration. It was amazing, and so many ideas, so many, points which he made, which touched all of us, including me. And I think if we are a better person, we will be a better surgeon, we'll be a better anesthetist, and our country will be a better country. So that's the message which was very loud and clear, and we have got to make small baby steps every day in accomplishing that. Congratulations, Dr. Gopal, and thank you for accepting the award, and Dr. Vrushali. So we really thank you for having this. We've started this award now for last 7 years, and we are happy that, you are accepting this award. All the inspiration to us comes from our founder. He was here yesterday, 88-year-old gentleman, still going strong, continues to inspire us. Started with 10-bedded hospital, made it 50, 150, and now it's going to be 300 with the advanced orthocare hospital starting soon. So that's his vision, and every day he's monitoring the progress. And this morning he had called the logo team to decide on the logo because he felt this logo which I chose is not really so good. So as we speak, he's changing this logo. So that's KHS for you. Our orthopedic surgeons who are our pillars, they are all full-time orthopedic surgeons who work with us. And the main pillars, our anesthesia team. And today is the PRAC oration which I'm giving. I would say thanks to them, thanks to Sandeep, who actually is the brainchild of the Pune Regional Anesthesia course and one of the key members of Aora. And he's the one who made the difference. For anything, you need a catalyst, any reaction to start. Once the reaction starts, then even the catalyst cannot stop it. So that's what Sandeep has done to PRAC. So we appreciate your efforts and really keep the good work going. And it's just a point to show that once a person who comes, so many things change. As Dr. Vrushali said, the research work going on, the opportunities, the collaborations is phenomenal. So really appreciate our pillars, the anesthesia team. So now starting with my talk, behind the screen, an evolving paradigm. So what is this evolving paradigm about? I think amongst all fraternities, branches of the medical, what we do, the orthopedic surgeons, the surgeons per se, and the anesthetists share a very unique relationship. The anesthetists are very close to the surgeons and vice versa. And this unique relationship has to remain unique and has to remain pristine so as to make a good impact on the patient. It is like two different galaxies meeting. Both are strong personalities, both are, in their own way doing great work. I always have the highest respect for anesthetists because, they are the ones who make the patients sleep nearly close to death and then bring them back. And that's the kind of thing, it's a very difficult job. The surgeons, on the other hand, are there working, and there has to be a big synchrony between the two. In the silent dance of surgery, two galaxies meet, each contributing its unique melody to the symphony of healing. And this has to be a symphony. This has to be very synchronous. At times, when it is not synchronous, sometimes there are issues. Sometimes the anesthetists and surgeons do have issues. They fall out. But then it's important to get up and start the symphony again. That's the importance of the unique relationship a surgeon and an anesthetist has. If you see, there are so many anesthetists sitting here, and all of you have various options. Some of you might be in government practice, some in private. Some are practicing in peripheral rural areas. Some are freelancers. Some of you are doing group practice. I would say each one has its own challenges, advantages, disadvantages, and I cannot point and put one finger that, okay, private practice is better than freelancing, or government practice is better than practicing in periphery. It depends on what you like, what your choices are, because each one is a little different. If you see government hospitals, they have their admin issues. The start and finish times are dictated by, the hours, and at times it can be difficult to do many cases. Of course, there's an academic environment because you have residents working for you, and this resident support can be a huge task force for doing the anesthesia work. Private institution definitely has its own merits. The responsibility is shared. There are good support systems, can do complex cases because of a good ICU backup. But again, then, you have to work as per the institutional rules and regulations. In periphery, sometimes the resources are limited, and I really hats off to those practicing in periphery. I was discussing with some of the anesthetists yesterday, it's very difficult to do complex cases. So I think in periphery, when you're practicing, you have to be a little choosy on which cases you can do or you cannot do. At times, academics and research abilities, opportunities are restricted, and I'll touch about it a little later. I think the freelancer concept, probably you can work at your own pace. You're not answerable to anyone. You can just switch off your mobile, and then nobody is going to trouble you. But then, again, the research opportunities may be limited because you're in a different environment. And again, this is something which somebody might want to do. The new concept which is evolving is the group practice, is something which, I feel is a good concept. The work gets divided, the responsibility is shared. So these are various ways which you can practice, and each one of you could probably relate to one of these 5 slides which I showed you. Just on a lighter vein, what I would like to say is, whatever you practice, you may be government, institutional, freelancing, I have seen there are 3 common traits seen in almost all anesthetists. And what are these 3 common traits? The first one, you will always look for an opportunity to make a patient unfit. That is what I have seen, 2 sips of water, and then Dr. Diwan says, no, you cannot take the patient. Little cough, finished. The case is cancelled. So this is something, of course, is changing with regional anesthesia, and now our patients are more fit, and they are not looking at the cough and cold because regional anesthesia has made anesthesia so much safer. Whenever anesthetist cancels a case, this is the orthopedic surgeon. He gets so angry, he gets so irritated. He takes things in his own hand and doesn't sometimes listen. He doesn't even want to know what the patient's condition is. Is there a pulse or no pulse? And then he will try to anesthetize himself and then go ahead and do the case. Sometimes these surgeons can be quite ruthless, and I might say this standing in front of you as a surgeon, because all we see is the knife and all we see is the surgery which has to get done, and we don't see your perspective, which I think is important. Coffee breaks. When the patient is induced, I really don't know why, Dr. Bala Venkat, everybody wants to run to the coffee room. Is this true in Ganga Hospital? I don't know. But this is something, once the patient is induced and, they will go, then some technician will sit, the another anesthetist will come, they will signal something, go there, some snacks are there, something is there. And this is, I still don't know the answer. And the last trait which is common, I don't know why anesthetists don't wear mask on the nose, and this is yesterday. This is Dr. Diwan yesterday when he was demonstrating. So I think I still have to understand from you people. Maybe after the talk you can, tell me what is the secret. I would also like to keep my mask down. And I always used to have a fight with the anesthetists, and some of them do listen. Some of them still don't listen. This is yesterday, Dr. Diwan. Anyway, this is something which is in lighter vein, but as anesthetists and as surgeons, there will always be some conflicts. It's like a marriage. It's not going to be rosy and red all the time. There have to be some differences. There have to be some issues. And one thing which now, let me give you a different perspective. A surgeon always underestimates. He will tell you just 5 minutes more and I'm done, and the case will go on for 1 more hour. That's a normal surgeon's trait, and that's where the anesthetists sometimes get angry. They tell you the patient skin to skin 1 hour, don't worry. And the case will take 3 hours. So the anesthetists tell you, why don't you tell me from day 1, on the beginning of the case, it will take 3 hours. I will give a little different anesthesia. So these are certain things, there are always conflicts. The surgeon always, overestimates his skills and overestimates his surgical skills, and he thinks he can finish faster. No bleeding. No surgeon can cause any bleeding. No. This is just a shaft femur. Don't worry, a small incision. TKR doesn't require blood. Totally, it's a bloodless surgery. But then, once the patient is going out, the BP is dropping, and then the anesthetists are the ones who will really do all that is required to stabilize the patient. Sometimes the anesthetists are helpful, sometimes they are not. And, when the OT assistant goes out for his cup of coffee, and then I need something, a pair of gloves, or I need something which needs to open, the anesthetist sometimes open, or sometimes the light has to be adjusted, and some of them are very smart. No, I cannot reach it, and this time they feel they cannot leave the patient. They have to be standing or sitting next to the patient. So they won't go there and adjust the light. And this is something which goes on all the time. But this is, again, as I said, it's like a marriage. We have to, move on with this. At times, the atmosphere in the OR can get a little stressful. The surgeons may say certain harsh words, maybe not to the anesthetist, but to the assistant, to the sister who's assisting, to the resident who's assisting. And then these words can actually make the atmosphere, a little bit stressful. So if I'm a patient, what do I want? If I've undergone 2 surgeries myself, so when I was lying there, I want to know that whatever is being done, is it safe? And I don't want anesthetists or surgeons to argue in front of my presence. And this has happened. I can give you examples. People talk. And when people talk, the patient is listening, and they don't like it. They would say, just whatever your problems are, sort them out before. Why in the OR? Why are you doing this? I think that is important. And with regional anesthesia, with Dr. Bala Venkat, Dr. Sandeep, and the whole team promoting, they are more awake, and that is why they are hearing more what you do. And this can be really, really stressful at times. Sometimes the surgeons, when the anesthetist goes out, they say, oh, this anesthetist is slow. She'll take so much time. The block will take 2 hours to give. And this patient is hearing this. This is not good. We have to maintain a very high level of professionalism while we are in the OR. Sometimes the surgeon himself or the anesthetist may say, this surgeon is trying this technique for the first time, and then the patient is getting jittery and nervous. And believe me, this has happened in my hands. Once I had come back from a conference, and patient was under spinal anesthesia, and we were doing a new cartilage procedure. And I just said that this is the first time I'm doing it. And the patient very promptly asked the anesthetist, I hope the surgeon knows what he's doing. It makes him jittery. So don't talk these things, or then tell your anesthetist to sedate the patient. Because this has happened to me, and when I went for rounds, the patient actually asked me, Doctor, I believe you did this for the first time. And then I said, how do you know? I said, I was hearing you, the patient said. And so sometimes it can be good, sometimes you can get away, but sometimes when we talk, those talk need not be heard by the patients. Sometimes the anesthetist is in a hurry, and they say that, oh, this guy is going to take so much time, he's such a slow surgeon, and then, I have to leave early. The patient is hearing all this. So what I would like to recommend, always a cordial, a very, serene atmosphere has to be mentioned. We should always avoid criticizing each other, avoid shouting at each other, and any kind of loose talk in the OR. I think that's very, very important for us. How do we improve our relationship, the surgeon and the anesthetist? Today I'm standing here and giving you a perspective, which is a surgeon's a perspective. Of course, you have your own perspective. There has to be respect for each other. There has to be trust for each other. There has to be good communication. And I think, if you ask me, communication is at the core, and it need not be always verbal. In the anesthesia, in the room when we are there, small expressions, what is going on, your facial expressions can make a lot of difference. This was something, which shows you that the expressions made in the OR, I'm just giving you this particular movie clip, can say a lot. You don't have to speak all the time, but if you can just make some nice gestures, if the anesthesia is good, and you can just say, oh, wonderful, very good anesthesia, then the things are good. So there are so many of these nuances which are there, and at times the atmosphere is stressful. One has to understand what is going on, and the surgeon and the anesthetist have to work in tandem, because at times the surgeons are stuck. They have difficult situations to, tide over with, and once they do that, then you can both go out and have a cup of coffee and enjoy celebrate the nice surgery. Because it is the trust between you and me which holds us together. I think that is something which is very critical. We should have the flexibility amongst us, because that flexibility is important. Each one has to give the other the room, the space. We can't dictate, okay, don't give a block. Many a times, I know that I'm pressed for time, and I say, no, please, Bharti ma'am, today don't give a block, I have to leave early. But no, that you have to give them that time. That flexibility has to be there, and then only you are going to get good outcomes. We should always work as a team. And we do that, but at times what happens is, the surgeon comes, the anesthetist comes, does the anesthesia bit and is sitting, on the mobile, looking at the share market or scrolling something and not interested in what is going on. So I think it should be a team. As I said, okay, if difficult surgery is there and when the surgeon removes the glove, if the anesthetist can just say, well done. The surgeon will be so elated. Small gestures, work as a team. And even when it's a difficult anesthesia, difficult intubation, or, some difficult, very complex case, and everything goes well. So before going, lovely, you gave a fantastic anesthesia, made my life so easy. These small things can really be very good, and ultimately this teamwork is, as Dr. Bala Venkat said yesterday, it is for the welfare of the patients. It is not for each other. It is not for each other. As I said, a small witty remark, a light-hearted comment, or just a smile can alleviate tension and foster a positive atmosphere. Now, this was a scene from a movie where, they are at the hotel desk and they are trying to check in, and there is some fight going on between the two people who want to check in. And each one says, this is my room. And there's just one smile from the one person and the whole atmosphere becomes so light. I think that is what we need. When there is so much of stress in the OR, I think a good sense of humor is a major defense against these stressful situations. I think that helps. One smile and the whole thing is diffused. And I have seen that in my own OR and in my own practice. One thing I would like to say very emphatically, keep your anesthetist happy. That is very important from a surgeon's perspective. And I'll tell you one secret, because I have seen, suppose somebody wants to find out how good a knee replacement surgeon Dr. Parag is, they will call my anesthetist. They will say, oh, how good he is, because she is the one who knows actually what I do in the OR. So if you want a good reference, make sure your anesthetist is happy. Otherwise, they will not give you a good reference. And that is what I've seen, especially the doctor fraternity. If they are getting operated, they will do a reference check from the anesthetist because they are going to give you the first-hand information. So as a doctor, as a surgeon, as an orthopedic surgeon, this slide is more for me rather than for you. As Dr. Bala Venkat said yesterday, it has to be a shared responsibility. It is not your or mine. It is our responsibility. There has to be no blame game. That is very, very important. Very important. There has to be no ego. We have to face complications together. Complications will happen, and we cannot really actually blame each other. And let me tell you a true story here. One of my friends from BJ Medical College, he started his anesthesia practice. I started my orthopedic practice. And one of the cases he did was a hysterectomy, and the patient passed away after the hysterectomy. The surgeon then completely put the blame to the anesthetist, and then it was a very big political issue. I got involved, and there was a compromise, and ultimately it did get resolved, but then at the cost of my friend really going into depression, and then he decided not to practice in India, and he actually went to another country. As we speak, he's doing very well, but that, 6 months, 1 year, took a big toll because the surgeon completely blamed it on the anesthetist. So let's face complications together. Why not? We are a team. If we cannot say, okay, this is the surgeon's fault, the surgeon cut the artery and that's why the patient bled to death, that may be the cause, or whatever it may be, but in front of the patient, we have to be one. We have to leave that ego aside, because ego is the only thing that can trip you up faster than your shoelaces. So don't think it's your fault or my fault. In front of the patient, we are one and remain one. So friends, as I come to the last part of my talk, what I said behind the screen is an evolving paradigm, and it's now becoming in front of the screen. And let me explain to you my perspective, why I feel so. From behind the screen, you people are now becoming the frontline people in so many ways. Now you people are coming into pain management, and I've seen the regional anesthesia consultants doing a lot of pain management, and they're directly dealing with the patients. So that's a fantastic thing. A lot of you people are into critical care. I think that's, again, a very important thing. You people are getting into research. You have to collaborate. You've got to publish. I think that's one thing. I don't have much time now, but all I can say is collaborate with each other. Talk to your peers, your seniors. Do some collection of data. Collaborate, publish. You can also make use of Anesthesia TV. They have a booth right outside, and they can help you with collaboration and also give you a platform to present your work. May you be from the periphery or from the government hospital or anywhere. Dr. Ashok Sham is here, who runs the Anesthesia TV, and he has given a very big platform to the Ortho TV. There is something called as an orthopedic TV where 35,000 orthopedic surgeons are members, and anybody who wants to make a presentation can contact Dr. Ashok and do that. So similarly, I will urge you, it just boosts your confidence, because when you do something on the virtual platform like Anesthesia TV, there may be one person watching you, or there may be 100 people hearing you. You don't know. So you're there on the other side where you're alone in your house on Zoom. So that gives you a lot of confidence. So I feel, platforms like Anesthesia TV, Ortho TV, you should use them. There's a booth right outside, and you can meet Dr. Ashok Sham, who's the founder of this. What you need to do to come to the front line, to change the paradigm, is the pre-op evaluation by yourself. And I would say that the person who's going to give the anesthesia should do the pre-op evaluation, not a different anesthetist. So when that patient has met you the previous day in the OPD or in the room, and that patient sees you in the OR, they suddenly feel so better. They feel so confident. Okay, now, and that person has explained, that anesthetist has explained everything. Develop that bond with the patient. It's not just that you give the anesthesia, go off, and you'll never see the patient in the rest of your life. Don't do that. Once the surgery is over, go talk to the patient, the relatives. See the patient the next day. And I have seen some anesthetists do that. Dr. Sandeep does that many times. And then develop that bond. And here I can tell you there was one patient who came for a follow-up after 1 month to my OPD. And he wanted to go and meet Dr. Sadre because he said, she's the one who gave me the anesthesia, can I go and see her? So I sent the patient up to the recovery room, and then the patient was so happy. So that's what is important. You guys have to move away from the behind the screen and come to front of the screen, because it is important. We have to really, both of us, be in the front. That is something which is important, because I feel if you and me are together, we can really deliver the best outcomes to the patient in terms of pre-op evaluation, counseling, giving a very good, clean, safe surgery, pain management, early discharge. All these things will make the patient return to work early. And I feel all you sitting here in this hall, all the anesthetists, the regional anesthetists, have a big role to send the patients back home early and make them return to work early. It is an honor to work alongside each other, knowing that together we can make a profound difference in the lives of our patients. The power of teamwork is immense, and you heard Dr. Bala Venkat elaborate that so much yesterday. So let us work together. It's important. Our founder is the one who told us that the OT is like a temple. The patient is like a god. The anesthetist and the surgeons are there to help the patient to get better. So OT is our temple, my friends. Patient is our god. And at Sancheti Hospital, we have this dictum, serving patients is serving God. Rugna Seva, His Ishwar Seva. And we really try to follow this as much as we can. And let me tell you, it's making a big difference in the outcome of the patients. So there is a huge paradigm shift, friends, now. What is the paradigm shift? Today, I say Dr. Sandeep, Dr. Bharti is my anesthetist. But friends, the day is not far, or it's already there, when Dr. Sandeep will say, Parag is my surgeon. That is going to happen very, very, very soon. And on that note, ultimately, the surgeon-anesthetic relationship is essential for patient safety and a successful surgical outcome. Friends, together we can do a lot. So let's be together and improve our patients' outcome. I thank you very much for your kind attention. Thank you.
Thank you so much, sir, for the wonderful presentation. It must have been a deja vu for most of us present here for the ER rooms. But But thank you so much, sir. The takeaway, I guess, for all of us would be the 3 key points: trust, respect, and communication. Thank you once again, sir. May I now request our team of anesthesia from Sancheti Institute of Orthopedics and Rehabilitation to please felicitate Dr. Parag Sancheti.
Dr. Parag Sancheti, sir.
So thank you very much for this kind felicitation, and believe me, and I say it with utmost sincerity and from the bottom of my heart, I really want all of you to be in the front line, and I want to be known as a surgeon, and first the anesthetist's name should come, and the patient should ask me, okay, if this particular anesthetist is coming, then only I'm getting operated from you. And that day is not far. Thank you very much.
I would request Dr. Parag Sancheti to stay on desk to give off prizes. Dr. Nita, please.
A lovely talk, sir. We all enjoyed. Thank you so much for that inspiring talk. Coming to the quiz prizes, there was extreme enthusiastic participation and a showcase of knowledge. We were really happy to have to give the first prize to Thomas Francis and Nidhi Sultania. The first prize of the quiz competition. The prizes are sponsored by Paras Publishers as well as B. Braun. A big round of applause. The second prize goes to Dr. Aparna Jairaj and Dr. Shushmita K. Big round of applause for them as well. Coming to the poster section, we definitely encourage and celebrate research. The judges had a tough time declaring the results. The first prize in the poster section in consultants, the first goes to Dr. Ronak Parida. Dr. Ronak Parida is here. Second prize goes to Dr. Lina Paulos. Dr. Lina Paulos in the consultant section. Round of applause. The poster section, the PGs and fellows, the first prize goes to Smriti Warrior. Smriti Warrior. She here. And the second prize to Dr. Shruti Shrey. Dr. Shruti Shrey. In the paper section, consultants, the first prize goes to Dr. Amrita Rath. The second prize goes to Dr. Devangi Parikh. Hearty congratulations. In the PGs and Fellows paper section, the first prize to Dr. Revati Nair. Dr. Revati Nair. And Dr. Varsha P. Sarva. P. Sava. All these 12 winners will be getting free registration for the conference next year. This is thanks to courtesy Dr. TVS Gopal sir. Thank you, sir. Thank you very much, sir. Parag, sir.
We are immensely thankful to Dr. Chaitali for comparing this session. Thank you so much. We move on to the next session. This will be didactics, and I request Gopal to be on the chair if you're not tired of sitting. And we do not have Rafael, but I may request Dr. Bala to be on the dais. Ophelia, is she here? Karen Boretsky? Yeah, she's.
Can we have the pleasure of inviting Karen Boretsky on stage, please? She will be talking on eras in pediatrics.
Thank you, Dr. Karen, for being with us. And it's been great to see you contribute phenomenally to pediatric anesthesia and in pediatric regional especially. And I think the minute we call, you're willing to come and share. And we look forward to seeing you again and again. Over to you, Dr. Karen.
Thank you.
Look at that. I knew there's a reason I came to India. They give me a little box to stand on here. Oh, and this is something I learned from Dr. Bala. Wait a minute. What's that? As he brings the 2 microphones in, poised, ready to go. Anyway, I'm Dr. Karen Boretsky, and I am honored to be here. I'm going to speak about ERAS in children, and my biggest challenge, I hope, is going to be to get the slides moving. Okay, everyone always asks for disclosures, and I have no financial disclosures to make. I will disclose that I love Indian food, which is one of the reasons why I'm so quick to come to India. Secondly, I learned so much when I am here to take back myself, so it's mutual. And I always enjoy spending time. This first picture on the top is me and Dr. Ponde heading off to a Red Sox game when she visited me in Boston. And here are just some pictures of me in India with these are my friends over the years, the long friendships that I've developed here in this wonderful country. But anyway, let's get on to what you guys have come here for, not my reminiscing. But let's talk about what is my goal this morning. Why am I here? My goal is to be here to help you to improve pediatric care using the different principles of ERAS that have come up over the past few years. And the objectives are pretty simple. Let's identify some of the key features of the ERAS protocols that we're going to use. We'll identify some of the differences between children and adults. We'll look to assess the benefits of ERAS for clinical practice and set the foundation for preparing your own ERAS protocols, whether formally or informally. So what is ERAS? ERAS isn't just fast tracking. It isn't just getting the patients out of the hospital faster. It's enhanced recovery. And the goal is really it's designed to deliver standardized care, evidence-based care, and collaborative care throughout the surgical journey. And the problem with surgical care, past and even present, is that often each unit, the patient has to make too many solo journeys through too many different parts of the hospital alone. And so each unit has its own focus, its own personnel, its own specialists and specialities. But each unit then affects the next unit taking care of the patient. So it's like a good pass in football, as you call it. I call it soccer. But a bad pass affects the whole game and whether you win or lose. And so few stakeholders see the journey's patient as a continuum, and few of the practitioners see the patient and hold the patient's hand throughout the entire journey. And I was just inspired this morning by Dr. Bala's talk when he showed the difference that he makes in the care of the octogenarians, the geriatric patients, by putting together such a well-focused, evidence-based package. And he didn't call it ERAS, but in all of the essence, it was an ERAS package where he was one of the team players of this team sport. And no single element can improve the patient outcomes. It's just all of that hand-holding. It's the multidisciplinary. And it's not just multidisciplinary. One of the key, these are the key factors of a good ERAS protocol. Multidisciplinary. You have to resolve those issues that have been a problem in the past and that cause problems for recovery and recuperation. It needs to be evidence-based. It can't be, well, I think this or this is my experience. It is evidence-based. And everybody has to have the versatility to change. So when you put something into practice, if you see that it isn't quite achieving the effects you want it to, you have to be able to say, This isn't working. What's next? What can we do better? How can we make this better? And every day you should walk into life saying, how can today be better for me, for my patients, than yesterday was? There are 17 core ERAS elements. I'm not going to go through this because we've seen all of this ad nauseum, but bear in mind that there are 17 components that have been put together by the ERAS Society that were essential. The ERAS, these particular elements have been documented in adults to reduce the complications, reduce the costs, reduce the length of stay, reduce the number of readmissions that we see, and improve overall patient satisfaction and staff satisfaction. So these are all very, very worthwhile goals for us to achieve. Okay, so let's talk about ERAS in children. The last time I did a comprehensive literature search on the page for the ERAS Society, it's at eras.com, at erassociety.com. There was one ERAS guideline put together for use in children. So we have some work to do, but what can we learn from the adults, and where can we set our path forward? This was the single, I just wanted to call out compliments to the authors of this one single ERAS protocol looking at neonates. Neonates are very, very different beasts, very, very different animals, very, very different patients. And so their care is very unique in the same way that the octogenarians and the older patients are. And so this paper focused a lot on the neonates as a population. So the pediatric surgeons and collaborators all got together and decided, they took at the adult ERAS elements, and they said, which ones are important to us? What should we adopt and what should we not adopt? And in fact, you can take your recipe for your adult ERAS protocol and pretty much duplicate it for kids, with the exception of two votes. One is that for the children, the need for mechanical bowel prep is still preserved. They haven't done away with that. And the insulin for the treatment of hyperglycemia is less critical in children for wound healing. And so these are the two elements that have been taken out of the adult ERAS when it's applied to pediatrics. So we're all anesthesiologists here. I was led to believe that the target audience is anesthesiologists. So what is our role? What are we, the quarterbacks? Are we the guards of the goals? What is our role on our team? And so the areas that we have control over that have come out as key to ERAS success is to relax the NPO restrictions to facilitate better nutrition. We will, and I'll talk about each of these in turn as I can, given my timeline. It is our charge to avoid opiates, maintain fluid balance, do good post-op nausea and vomiting prophylaxis, and maintain the patient's temperature intra-op. So let's start with one of the easier ones. Let's talk about normothermia. If the patient gets cold, it makes the patient susceptible to wound infections. So by keeping them warm, we preserve the immune function, we improve the coagulation status, we improve shivering, so we improve oxygen utilization, and we also improve comfort. The pain scores are lower when your patients are comfortable. So number one, maintain normothermia by active means in the operating room. Let's move on quickly to NPO guidelines. And it's not just about hydration. So we're seeing that we're relaxing the NPO guidelines on our patients. And for the children, we say, well, we don't want them crying in the holding area. It gets noisy. They wake up the other children. They're hungry. They're thirsty. So let's let them drink. It's not just about hydration. If those children fast, and adults fast more than 6 hours, that it inhibits the insulin secretion, and it promotes the release of catabolic hormones. So what we see is that preoperative oral carbohydrates within 2 to 3 hours before the induction, it reduces the catabolic state of fasting and the catabolic state of surgery. So what we see is in the post-op period, we see less insulin resistance. We maintain the glycogen reserves, which the kids need for healing. We see decreased protein breakdown, and we see preserved muscle strength. And so these are all things that are very important to rehabilitation and getting up and moving. And by the way, with the use of ultrasound, we now see evidence that gastric emptying after clear fluids it's complete after 90 minutes. 90 minutes and the stomach is empty. So there's really no reason for prolonged preoperative fasting periods anymore. So what about opiates? Let's move on. Opiates, ad nauseum, we've been talking about why we want to avoid opiates, and yet 89 to 93% of patients in the perioperative period continue to receive opiates. This is an area that we've been talking about, again, ad nauseum, and we're just not really making the progress that we need to make. So let me just remind everybody about the respiratory depression, nausea and vomiting, constipation, pruritus, urinary retention. Opiates are immunosuppressants. So in your cancer patients and your patients who are prone to infections, this is a bad thing. And a topic that's I like to speak about is opiate-induced hyperalgesia, which I'm not going to have time to talk about today. So, and this is the reason I talk about ERAS, is because we need a non-opiate or opiate-sparing multimodal protocol for analgesia for our patients in pain. And the number one way that we can do this is providing regional anesthesia in addition to or in substitution for general anesthesia. Since it's children, we really just provide the regional anesthesia as an adjuvant because the children very, very rarely will lie still for the surgeries and for the block. We need to use routine, not as requested, but routine scheduled around-the-clock non-steroidals and paracetamol. These all minimize the ileus, make for faster awakenings, extend the opiate sparing into the post-op period, and facilitates early oral intake of fluids and nutrition. And the importance of nutrition in patient rehab cannot be understated or overstated. Yes, cannot be overstated, sorry. If you have an opiate-related adverse event, if you look up here, if you look at mortality, discharge to another facility, length of stay, cost of hospitalization, 30-day readmission, it all favors the use of non-opiate modalities. There's a 3%, 3 times increase in mortality for those patients who experience opiate-related adverse events. We see an increase in cost of $8,000 US for every opiate-related adverse event. The 30-day admission rate is twice as high, et cetera, et cetera. Here we see in infants, those patients who are on PCAs and opiate-related, opiate-based strategies, we see that on days 1 and 2, 30% of those patients still have oxygen requirements, and 1/5 of them still have oxygen requirements on post-op day 3. They have nausea, they have vomiting, they have pruritus, and this makes for extended lengths of stay. And not to even mention the 1% of patients who develop significant respiratory depression. This is particularly important in our youngest patients. You're in trouble with opiates if your patients have a history of prematurity, if they're less than 12 months of age, or if they're in a post-anesthesia state. In these patients, opiate sensitivity is increased for a variety of reasons. If you look at emergency arrests, respiratory arrests, if you look at the use of Narcan in the post-op period, it is predominantly in this patient population. And the reason for that is that the children, we see their metabolism changing so much over the first year of life. As the children grow, their enzymatic hepatic systems mature, which has a lot to do with the metabolism of the different medications that we use. And so we see decreased clearances of opiates in these youngest kids. And so it makes the pharmacokinetics, pharmacodynamics very, very unpredictable. And so there's a very, very high, strong recommendation from all of the ERAS advocates that regional anesthesia and paracetamol be used in the post-operative period. This is very high level of evidence with a very strong recommendation. Can we do this? I'm just going to take an extra 30 seconds. There was a pediatric, so people say, well, I'd like to do this, but I really can't. I still need the opiates. And if you look, there's a surgery center attached to Seattle Children's Hospital. They do 40,000 surgeries a year. There was an opiate shortage. And what they found was they couldn't get opiates, so they couldn't give them. And their opiate use, their intraoperative, so they developed standardized protocols that relied on regional anesthesia, took away the opiates, and they found that they went from using opiates on 84% of the patients intraoperatively, that dropped to 4 to 8%. And post-operative opiates in the recovery room dropped from 11% of the patients to just 6% of the patients. And they had no increase in the PACU times, discharge times, and what they did see was that the costs were improved and there was a decrease in post-op nausea and vomiting. There is strong evidence in the adult and pediatric literature that opiate inclusive anesthesia does not reduce post-operative pain, and all it does is increase PONV. If you look at, this is a meta-analysis that was done, very ambitious, looked at patients that got opiates, patients that didn't, no difference in post-op pain scores, only differences in post-op nausea and vomiting. One of the last recommendations I'll talk about is we should be feeding our children earlier. We should be feeding them within 24 to 48 hours. And there's nothing more satisfying than watching a child tuck into a good plate of food. I love watching kids eat. And it really, it improves their muscle mass, their ability to rehab, and their ability to learn, which is what kids do. No ERAS talk would be complete without talking about the importance of not transfusing unless transfusions are indicated. We like to keep the neonates above 10 or above 11, and the other children above 9, but below that, above that, there's no reason to transfuse. With that, I want to conclude and thank everyone for listening, and I want to urge you to be flexible and to think about changing some of your practices. And I believe the most dangerous phase in the human language is that we've just always done it this way. Thank you.
Yeah. Thank you, Karen, for that lucid lecture. We now invite Dr. Ophelia to grace the stage and give her lecture, Do I Require an IFPB in Clinical Practice? Request all speakers to kindly stick to allotted time.
Hello again. I'm still very honored to be here and to speak to you about my daily practice and about interfacial plain blocks. And I will answer you this question, do I require interfacial plain blocks in my own practice? So my own practice my personal anesthesia practice is the practice of neuraxial blocks in abdominal surgery, obstetrics, orthopedics, pediatrics, and I use it extensively for awake surgery with minimal sedation and early hospital discharge. I like combined spinal epidural, but also continuous spinal for major abdominal surgery. And as you see, my patients are happy, and their outcome is absolutely excellent, on one condition, to have good surgeons, of course. So talking about regional anesthesia, then in its evolution, we since 200 years, we first had topical anesthesia, then skin infiltration, then we picked up with nerve-targeted blocks and spinal epidural neuraxial blocks. And then fascial plane blocks have been developed. And my friend, Dr. Robert Rowe, made a research and tried to establish a merit score according to the advantages and the disadvantages of all 5 types of blocks. And you have the traits of this block according to the advantages. So you can see here, when you have the plane line, it's the 2 first on the top. They are the traits for positive merits, full anesthesia and reliability. I think you agree with him and with me. And then the second ones with the interrupted line are the drug wastage risks and the skill needed. And as you can see, the best merit is for the nerve-targeted block and neuraxial blocks, and fascial plane blocks have lower merits. The same on this table. You can see if you addition the economy in matter of volume, reliability, speed of onset, safety, you may see that the best are the nerve-targeted nerve blocks, then the neuraxial, and the last generation of ultrasound-guided interfacial plane blocks have lower score. Yes. So what are fascial plane blocks? So they are ultrasound-guided, there is a type of regional anesthesia technique using ultrasound-guided needles with large volumes that is injected far from the target nerves and need aponeurotic fascia sheets in order to force the liquid drug closer to the target nerves. Their analgesia is better than having no nerve block, and it's inferior to nerve-targeted and neuraxial blocks. Their results are inaccurate and variable between individuals. This is only a part of some example of interfacial plane blocks used for thoracic surgery. Some of them have 5 different approach variants, and each one can be done in a different way. They have different names in different countries, in different way of spelling. And it is impossible to give a group final opinion on interfacial plane blocks. They are very different, they are unique, each one is unique and depends on the way it has been perceived by the anesthetist. And this is just to show the complexity of the interfacial plane blocks. They are mostly substitutes for thoracic paravertebral blocks and neuraxial blocks. So you can do that, but it's quite difficult, I think, and only specialists can understand something on all this anatomy. So which are their limitations? So we start with a very real problem. If bilateral, there is a risk of local anesthetic toxicity. I think you agree with me because they need a massive total volume of drug injected. In order to be less toxic, you have to dilute the drug solution. So we use 0.2% bupivacaine, which minimizes the total dose that doubles the failure rate. There is another dilution due to the interstitial fluid that will push the drug to the nerves, to the target nerves. The problem with interfacial plane blocks is that their efficacy is inconsistent. Up to 30% of the patients experience no pain relief. Their duration is very short, and it's quite impossible to perform sedated awake surgery with interfacial plane blocks alone. There is another problem that because in the studies, they have been compared only to placebo. So we cannot really compare interfacial plane blocks alone with neuraxial blocks or nerve-targeted nerve blocks. What are the best indications for torso interfacial plane blocks? Well, it's not very complicated to conclude. It's when epidural and spinal anesthesia is contraindicated by anticoagulation therapy, or when the anesthesiologist has weak knowledge, skills, and experience with neuraxial blocks or with thoracic paravertebral blocks. But the best nerve block is not the best one in a book, it's the best one you know and you can do well. So let us take the example of a patient who is under anticoagulant therapy, who has an opiate addiction and a severe emphysema, and we had to, and he had to have an open heart mitral valve replacement. So, if you consider that the major pain will be the sternotomy pain, you should be tempted to perform a bilateral parasternal intercostal block with ultrasound guidance, of course, using 0.3% bupivacaine, which will last about 7 hours for the procedure. But you should do that only if you know how to do it. If not, better do general anesthesia or refer the patient to a medical center where other colleague anesthesiologist can do this, technique very well. So another example of interfacial plane blocks option for chest wall or intrathoracic surgery are these three nerves, the retrolumbar block here, which is injected under the erector spina muscle. Then you can also proceed to an erector spina plane block, also injected under the erector spina muscle, above the vertebral transversus process, also here. And the third block, which could help, which could be used for this kind of surgery, is the intertransverse plane block, here and here, injected superficially to the superior costovertebral ligament. But compared to paravertebral block, they are poor substitutes, because you have to consider the drug spread injected with this technique of interfacial plane blocks, and you will never have a better efficacy and constant success compared to the paravertebral blocks. So, in conclusion, no clinician can be competent and knowledgeable and experienced with all nerve blocks. The gold standard of regional anesthesia for the best and most reliable regional anesthesia remain the neuraxial blocks and the nerve-targeted nerve blocks. When you use interfacial place block, you have to know perfectly well specific anatomy and to be well trained. But the best block that you can offer to one patient one day is the block you know better to do. You know you do the best. And in my practice, my neuraxial nerve blocks achieve maximum patient's benefits and safety outcomes that interfacial plane blocks could never match. But I still use them. In pediatrics, I use TAP blocks associated with general anesthesia for appendicectomy or for inguinal or umbilical hernia repair or for ectopic testis. So I do them as an adjuvant for general anesthesia, but really only in pediatrics. For adults, I always use neuraxial blocks or nerve-targeted nerve blocks. So thank you for your attention, and I hope you appreciated the merit score invented by Robert Rowe. Together we have a website of educational regional anesthesia. So thank you very much.
Thank you so much, Dr. Philly, for sharing your thoughts on the interfacial plane blocks. Next, we move on to the next talk, the regional anesthesia and analgesia techniques in diabetic patients, to be delivered by Dr. Philip Lerk. I think India being the diabetic capital of the world, this talk would mean a lot to us. Over to Dr. Philip.
Thank you, sir. Thank you for the kind introduction and for being allowed to be here and talk about a subject that I really has been me since the first time I had a needle in my hand during residency. So when I was little, you still are little, when I was even littler and did my first blocks, I had two types of attendings. One type of an attending would always say, this patient has diabetic neuropathy, we will not do the block. He may get worse, he may have new onset neurological deficits, you will get sued, and let's just not do it. The next day I would come in and we had a different attending who said, get the stimulator out, this is the best block you'll do in a long time. You get your local anesthetic anywhere near the nerve, it's gonna give him a block of 2 days. The patient will be super happy, let's go. So it's been with me, this conflict, all this time. And it's not made up. This is a survey of European colleagues. If you pose them the question, do you think regional anesthesia has a risk to diabetic neuropathic patients? Almost exactly 35% say yes, 35% no, and the rest is in the middle. But we as a specialty should make up our mind because the number of diabetics is increasing exponentially. And we know that most of them, or many of them, over time will develop diabetic neuropathy. And we know these patients need surgery twice as often as their healthy, age-matched controls. So what I would like to talk to you about is why regional anesthesia and diabetics, and how does diabetic neuropathy influence the parameters that we often use to describe the block, how we stimulate success rate, duration, neurotoxicity, and the risk of infection when continuous techniques are considered. I have no conflicts of interest other than a keen interest in primary sensory neurons under attack. The first point I would like to make is that diabetic neuropathy is a continuum as it evolves. It starts with a patient who has a metabolic alteration, so that would a patient that just started on insulin, but then over time, as a slow process, it becomes worse and worse, and it becomes structural, and that's when we talk of a real diabetic neuropathy. This is when all functional capacity of the nerve is influenced, even down to the level how the quantity of the sodium channels is expressed in the neuron membrane, and even how they act. Most of what we consider in neuropathy, diabetic neuropathy, is when the people are really far ahead in this journey. And so some of the studies you will see did not always test all the patients for neuropathy, but when we talk about regional anesthesia and neuropathy, we really talk about this end stage where there is a structural, as yet irreversible damage to the patient's nerve. Why would we want to do surgery indications in diabetic neuropathic patients? Regional anesthesia indications, we have 3 patient groups. The first point I would like to make is that there are patients who have a good indication for regional nerve blocks. We just heard about perivertebral patient nerve blocks for thoracotomy, an ankle fracture patient that deserves a nerve block, and my sincere opinion is that a diabetic neuropathy should not be a reason to withhold any of those techniques. Their evidence is so good and so well-founded that any theoretical considerations could never weigh against that. Then there is diabetic neuropathic patients that come to you where you want to avoid general anesthesia. And you all know these patients where say, I just don't want to give this patient multimorbid general anesthesia. Regional anesthesia is safer, but the patient has a neuropathy. Still, you do a risk-benefit analysis, and 99% of the time, the nerve block will come out in favor. And then there are specific indications relative to diabetic patients. There are some surgeries that are performed very often in these patients that are extremely amenable to regional anesthesia. One example I would like to give you is AV fistula creation. There is an accumulating body of evidence that fistulas work better if they were done under a regional block. This was the initial study in The Lancet 7 years ago by Aitken and McFarlane. You see here that what surgeons always come before and use the ultrasound to look at the veins and to look at the blood vessels, which ones they could take to get the best fistula. You see the diameter of these blood vessels increases. And when they actually do these surgeries and they do them under nerve block versus no nerve block, you see that the primary patency after 3 months and immediate patency is higher, significantly higher in those patients that receive the nerve block. So when we bring a patient back for a fistula creation these days and we did not do a block, the surgeon looks at us with a look of disbelief, like, what's going on? So there are some surgeries where we actually actively should do regional anesthesia. So now we have this neuropathic patient coming to us for one of those indications and we do regional anesthesia. What should we be aware of? How does it influence these following parameters? About nerve stimulation, this is a little insight into the structural damage that the nerve actually incurs. This is a study on double stimulation by Paul Biegeleisen. He used brachial plexus, ultrasound-guided nerve blocks, had a nerve stimulator there, and he found that unpredictably but statistically significant, the stimulation threshold in people with long-standing diabetes and neuropathy was higher than in control patients. This was confirmed by Kyle for sciatic nerves. These were patients that were coming for gangrene surgery, so you might infer they've had a long diabetic suffering career and they are very far down the road of diabetic neuropathy. There was a big difference, again, a very big spread, impossible to predict for the individual patient, but there was a significant difference. Heschel actually tested the patients for diabetic neuropathy and found similar results, increased nerve blocks, stimulation thresholds, double guidance in diabetics versus non-diabetics. But when they tried to see is there any correlation between the nerve block testing and what actually the stimulation threshold is, they found that it isn't the case. So the first take-home message is nerve stimulation may be more difficult in patients with advanced neuropathy, but it's unpredictably so. So let's assume then you found the nerve anyway, you give the local anesthetic. What happens then? The success rate is actually higher. This is one of the retrospective studies I would like to show you. Diabetes actually and diabetic neuropathy increase your success rate of a nerve block when you get the needle at the right spot. 3 reasons could be responsible for this. The nerve may already be damaged, so you are adding insult to injury. You're anesthetizing a nerve that's already half gone. Microangiopathy could preclude the local anesthetic from being taken up into the systemic circulation when you deposit it. So it remains there for a longer time, and the nerve block is more intense that way, or the nerve would be more sensitive, a true pharmacodynamic experience. We did a study on this on sucradiabetic fatty rats with neuropathy, and then they were tested electrophysiologically to really have this neuropathy. We took out DRG neurons, and if you patch clamp them and you add increasing doses of lidocaine and you see how the action potential goes down, you see that the white circles, diabetic, are much more sensitive. This is a logarithmic scale, so it's actually pretty impressive that the inhibitory concentration is much lower in diabetic than in control neurons. This is far advanced, very severe diabetic neuropathy. So that's just one cell, you might say. What happens to animals? The same animals, if we do a percutaneous nerve block and an up and down dose finding study, for motor block, we found that we need 1.2% of lidocaine for the control animals and 0.8% for the diabetic animals, so a starkly reduced dose. That, combined with the clinical evidence, would suggest that diabetic neuropathic nerves are more sensitive to local anesthetics. Okay, so you've deposited your local anesthetic, the block sets on. How long will it last? Likely much, much longer if the patient is true diabetic neuropathic. We start again with the animal experience. This is early neuropathy in diabetes type 2 models, sciatic nerve block. But even here, you see that this block onset, block offset takes much longer in the diabetic animals for both motor and sensory parameters than the control animals. What about patients? This is a study by Sertos where they had popliteal sciatic nerve block, and they grouped the patients according to HbA1c, inferring that those with a long-standing bad diabetes would be more neuropathic. So let's remove the middle group. So we could think this is the good one, this is the neuropathic one. And if you look at the motor sensory regression time, it's far prolonged. And the postoperative time to first analgesic is also prolonged. Similar results by Cuvillon, with the difference that here the patients were actually tested for neuropathy, and again, a longer block duration in diabetic neuropathic patients. The reason for this likely is that the nerve of diabetic neuropathic patients is less well perfused. This is animal data, but there is corresponding human data. The endoneurial nutritive blood flow in the severe neuropathy is decreased by 30 to 50%. And this blood flow is what takes away the local anesthetic out of the nerve and into the systemic circulation, actually interrupts the circle that we talked about yesterday, this fluid dynamic of association and dissociation between local anesthetic and the binding site on the sodium channel. So should we even be giving epinephrine in these patients? So we did a pharmacokinetic study, again, same model, sucradiabetic fatty rats, neuropathy, percutaneous sciatic nerve block, and we used radio-labeled C14 lidocaine. And what you see here is the whites are the control. So you see this is the initial C14 lidocaine concentration in the nerve, and then it drops, and it takes longer to drop over time in the diabetic nerves, and the result is a nerve block that's twice as long. So nerve blocks in neuropathic patients would last longer, unpredictably so, but they will last longer. So the question about the epinephrine in the block, you shouldn't even need it because the block will last up to twice as long anyway. And now the big thing that some people may be worried about is the neurotoxicity. And I would like to introduce you to two concepts that I found very enlightening. The first one was coined by this gentleman here, Dag Zeelander, the late Dag Zeelander, who was one of the big names in European regional anesthesia 20, 30 years ago. Here getting the Lifetime Award from Dr. Ivani. His concept was that every peripheral nerve block is a calculated potential injury to the nerve. But because we know the technique, because we are safe, and because we can tailor the drug to the patient, we make it an acceptable risk. So that was one concept. The other concept is that of the double crush hypothesis by Hebel and Hörlocker, who said that if you have a healthy nerve, you injure it, it'll bounce back. But if you have a damaged nerve, like diabetic neuropathy, you add a second injury, you may actually push the nerve over the edge. Let's start again with the animal data. So this is neuropathy in a diabetic model, sciatic nerve block, and when these wonderful colleagues 30 years ago did this study, injected saline, nothing much happened. Lidocaine, you get a little bit more difference, but no difference between diabetic and control. But once you get into real neurotoxic territory, then the diabetic nerves seem to be at a little more risk of incurring nerve damage. Of all the experimental and clinical evidence, I would just like to summarize it here because otherwise it's too much if we go through all the slides. So the summary of all the things is that if you use high local anesthetic concentrations, just like you saw in the previous slide, they may have a more deleterious effect in diabetic neuropathic nerves. But here you're pushing it and you're looking very carefully. All the studies that used low local anesthetic concentrations that are clinically relevant showed little, if no difference in neurotoxicity. So low local anesthetic concentrations, as we use them now, to the best of our knowledge, are safe. The natural evolution of our specialty is that we have been decreasing the local anesthetic concentrations anyway. We use low concentrations, lower volume, we use ultrasound, and what we give now as a dose to our patients for any given nerve block as compared to the good old times with the nerve stimulator is sometimes half. So we are on the right, more safe way anyway. The clinical evidence is very limited, mostly limited to case reports and retrospective studies on epidurals, and it doesn't really tell us too much. It's limited and inconclusive. And I would put to you that if you want to do regional anesthesia in neuropathic patients, this limited, inconclusive evidence now needs to be weighed against the massive body that tells you that regional anesthesia can provide a host of amazing benefits to your patients. So just one study to show you. So this is a study where they showed a little bit of a difference in neurotoxicity here, and they really had to go deep. They had to start counting axons to even find a little bit of a difference. And you contrast that with all the wonderful benefits that regional anesthesia is proven, absolutely proven, to confer. So maybe there is a slightly increased theoretical risk of new onset neurological injury. In my opinion, not enough to withhold regional anesthesia. Dr. Balavenkat yesterday in the discussion on anticoagulation and regional anesthesia said all these decisions need to be a balanced risk-benefit assessment, and I strongly believe regional anesthesia will come out on top in virtually all of your assessments. Lastly, one last factor that we actually know a little bit about, the infection risk. Yes, unfortunately, if you have a diabetic patient, you do a nerve catheter, they have an odds ratio of 2.32, significantly higher to develop a risk of infection in the course. Doesn't mean you should preclude them, just means you should monitor, monitor, monitor. So the summary. On nerve stimulation, we learned it's more difficult, but unpredictably so in severe neuropathy. What about the success rate? Good news, the success rate is higher because neuropathic nerves will be more sensitive to your local anesthetic. Block duration will be prolonged because the nerve blood flow is lower. And so if you're thinking about epinephrine, maybe just omit it. It would make sense. You don't really need it. The block will last longer anyway. About toxicity, the evidence is inconclusive, and clinically used doses are likely safe. Infection risk, yes, unfortunately. My take-home messages are that diabetic neuropathy is not a valid reason to withhold regional anesthesia in patients with a solid indication, but you should be aware of some peculiarities. These include a more difficult nerve stimulation in some patients, potentially theoretically increased risk of new onset neurological deficit, which in the risk-benefit analysis will need to weigh against the massive body of evidence supporting regional anesthesia. A higher infection risk with continuous techniques, so monitor, monitor, monitor. Avoiding epinephrine as adjuvant makes sense because the block will last longer anyway. The number of diabetic patients we see and diabetic neuropathic patients we will see will rise substantially over the coming years and decades, and they too deserve the best anesthesia, and by that I mean the best regional anesthesia. Thank you very much for your attention.
Excellent, Dr. Philip, for that very, very precise take-home messages. And I think it's emphatically you said that don't avoid regional anesthesia just because the patient was having a neuropathy. Thank you so much for that. We move on to the next talk on shoulder surgery. And may I request Dr. Sandeep Diwan to share his thoughts on shoulder surgery. I think he's going to speak on behalf of Dr. Ease Yamak. Thank you, Sandeep.
So she's not well, so we pray for her health. This is just could be the shortest of the talks in this conference. By the time Sunil Pandya gets his table and gets everything arranged, the talk would be over. If you trace these nerves to shoulder, which supplies the shoulder joint, suprascapular, axillary, lateral pectoral, the subscapularis plexus, all these nerves, they usually relay in the superior trunk, which is formed by C5 and C6. They did a topographical anatomic arrangement. When they saw this, they found that these nerves, they lie like this, but they may not be the same arrangement in all the individuals. They may vary different even in the individual areas. So what does this mean is that you need to block in the region of the interscalene area where the C5, C6, it lies. If you see this particular arrangement, you will find that the C5 and the phrenic nerve, they are engulfed in one single sheath. We have seen it often. So it means that if you are going to give your blocks very high up, interscalene blocks with 20 ml, it's really going to cause 100% phrenic nerve block, which would be detrimental in patients having grade 2, grade 3 respiratory disorders. This is the reason why we are forced to go even lower down, as we say that we can go at the level of the superior trunk. If you don't have ultrasound, anatomical landmarks, C5, C6, and then you go at least 1 to 1.5 centimeters caudal, and then you try to elicit the response and inject local anesthetic. Nevertheless, we are unsure about the extent of the cephalad spread and block of the phrenic nerve. So we did one study where we had a case series of severe chest injuries, and we offered the patient continuous catheters which were introduced via ultrasound inside the interscalene area, and we injected 3 ml. You can see the contrast spread in the interscalene groove. And with the 6 ml, you could see the contrast spread over the middle scalene muscle at this point. And with 9 ml, you could see it flowing over the anterior scalene muscle. We monitored the respiratory parameters, the diaphragm with ultrasound, SpO2, and the tachypnea. So these were the things that were monitored. And we found that 3 ml, it offers a better proposition, but would give you inadequate analgesia. 6 to 9 ml, yes, it could, definitely. So we went on to perform a cadaveric dissection with methylene blue dye, which was injected. Now, in our practice, a methylene blue dye spread would be equivalent to local anesthetic. It can go along the pathway, the neural pathway. The latex does not. It will stick to one single place. We have seen that, Abhijit, we have recently published this. When you inject methylene blue dye at this point in the infra-omohyoid region, where you see this is the extent of the stain, that's the dense stain, and then this is the anterior and posterior division and middle trunk, and you can see the entire thing being engulfed with methylene blue dye, lateralizing the brachial plexus going right up to the level of C5. Not staining the phrenic nerve though, which could be on the anterior scalene muscle. And this could be the nerve to subclavius, which is a branch from C5 or can be from the superior trunk, which innervates the clavicle. So this could be one of the reasons why the superior trunk block or the isolated supraclavicular block, it helps in providing analgesia to the shoulder joint. We did a cross-section at the level of T1 where we injected in the pec plane, and you can see the pectoral nerves getting engulfed in this. And in the subscapularis plane, here at this point, you can see the subscapularis sheath. Below the subscapularis sheath, this is the dye, where the subscapularis plexus and the axillary nerve would be positioned at this point. On this side, you can see the spine of the scapula, that's the subscapularis infraspinatus. This would be the site of the suprascapular nerve, which is approached posteriorly. So if you can go more distal for analgesic purposes, you can block at the level of infraomohyoid, you can block the lateral pectoral in the pec, and you can block the subscapularis and the axillary. We have been doing these techniques and we are trying to randomize these patients. We know that the cadaveric studies cannot be extrapolated to clinical. They are totally different aspects. You need some contrast studies to justify your answers when you try to do more of these studies. When we had a cadaveric coronal section, which was we did elsewhere, we found that the methylene blue dye, when we injected at the level of the capsule, it almost is inside the capsule, but these are the muscles that PREVENT has got maximum nociceptors, the biceps and the deltoid, and which would be required for analgesic purpose. This is what we call as the shoulder anterior capsular block. The last slide would be the costoclavicular block, which we proposed as one of the, which can be used for shoulder surgery analgesia. We inserted the stimulating catheter and we tried to negotiate it until we elicited biceps and deltoid response. We thought we are at the level of superior trunk. We injected local and found that it provides equivalent analgesia to interscaling, though we did not randomize these studies. The drug also seeped into the costoclavicular area and would block the lateral pectoral and the subscapularis and the axillary in these areas. All the 4 components blocked. It means that this is a possibility of the costoclavicular block, which is now has been studied in cadavers, which could also block in these cases. So these are some of the distal blocks and the proximal blocks which are being used for the shoulder surgeries. Sunil, are you ready? So thank you very much for your kind attention. So prior to me coming off the stage, I would immensely thank all the delegates here because we would be departing into 3 and then the master classes. All the international delegates, thank you very much for coming to the most the most what you can say crowded area in the world. We have top-notched and we have thrown everybody back in this particular area, and we congratulate everybody of them for getting us this. But now we have to be cautious about in the future as well. So thank you very much, George, Karen, Ophelia, and Philip for coming over here. I also thank the Aora faculties for making this a point, the Aora fellows and all the junior consultants in Aora who have helped us a lot. Apart from that, Dr. Sarita Swami, Shalini Sar Deshpande, Kalyani, and we have Bhagyashri. We have so many of them who have helped us throughout, Dr. Neeta, Dr. Pallavi Patil, and Sachin, and Sandeep, he's always behind the screen. So thank you everybody for coming over and enjoying this. Thanks a lot.
Before, as Dr. Sunil said, probably we will not all of us to be together. May I request all those who were involved in the organization of the Aora national meeting, all the executive members of this conference committee, may I request all of them to stand up for a minute? Sandeep Mutta, can you come forward? Sachin, just come forward, and all those involved. And may I request a big round of applause for all the entire organizing committee for the phenomenal work they have done to impart the academics and knowledge for all of us. And thank you so much, Sandeep, for doing this wonderful academic meet. I also take this opportunity to thank the audiovisual Anand, Peter and team. Fantastic it was, and I think we thoroughly enjoyed the live workshops.
Many happy returns of the day, Sachin.
Yeah, many happy returns of the day. Can we all sing once for Sachin, the scientific chair of this Congress? Happy birthday to you. Happy birthday to you.
birthday, dear Sachin. Happy birthday to you.
And thank you so much for the excellent event team, Vama Events, for making us all so comfortable. Thank you so much, Vama team.
So when somebody asked me how this Aora goes, I told them that it all revolves around Anand. And thank you, Vama, especially Rucha and Akanksha and Poonam, who were with us all the time. Thank you very much.
Yeah. It is my pleasure inviting my old friend from college days, the highly accomplished and hugely popular Sunil Pandya, to elucidate on spinal distribution in a glass model.
Am I audible? Hello. Yeah. Thank you, Dr. Gopal, for the kind words. And I thank Dr. Sandeep Diwan and the entire Aora team 2023 for this privilege to demonstrate the glass spine model. And I'm very privileged to have two most renowned anesthesiologists, Dr. Javed and Dr. Azam, who will be helping me. Thanks, Dr. Azam and Javed. And I also thank my fellow, Dr. Varsha, who made a humongous effort of carrying this spine from Hyderabad to Pune. Yeah.
Sunil Pandya said, this looks like a magician doing something.
So basically, again, a disclaimer. Glass spine is not my invention. I had been to UK as an observer in 1999 and happened to visit this department of Nuffield at Oxford. And I was impressed by Carey's model of spine. And again, Carey is not the inventor. The inventor is Dr. Arthur Barker. Way back in 1907, he invented this spine model as a teaching aid to demonstrate the spread of local anesthetic inside the spine, and it is very, very useful. You need to understand certain differences between the spine model and the human spine. Because this is a rigid chamber, there are no paravertebral foramina, and of course, you don't have a skull that demonstrates that accommodates the CSF. So we have used this as a skull where it accommodates the CSF and the injection port. And what we all know that the spread of the anesthetic in the subarachnoid space depends on several factors: the age, gender, the baricity, the temperature, the speed at which you inject, the volume of drug you inject, the mass of the drug you inject, and the barbotage. We know that barbotage also doesn't have much, but I'll be demonstrating those things. But importantly, the specific gravity and the baricity are the ones which are important determinant factors. And importantly, the position of the patient when you're giving a subarachnoid block also important. And we know the baricity and the spinal specific gravity of CSF. So I have demonstrated I've put about 8 models here. I'll be demonstrating a hyperbaric BPVCN, which we routinely use. Spinal is the simplest technique and the best technique and the most proven and the most successful technique. We'll be injecting in lateral position, and subsequently we'll put the patient supine, most commonly done. And then I'll be telling about other things as when we proceed. So may I request Dr. Azam to inject hyperbaric bupivacaine in the subarachnoid space. Patient has been draped. The resuscitation cart is ready. We presume that the surgical site checklist and everything has been done, and the time in and sign out, time out also is being done. So he's injecting local anesthetic hyperbaric bupivacaine in the lateral position. We have just about 10 milligrams of bupivacaine. We have just added a hinge of methylene blue just to see the spread. You can inject. That should be fine. So you injected 10 milligrams of bupivacaine and subsequently in the lateral position, and now I'm putting the patient supine. That is what most of us do. And importantly, if we are doing a pregnant patient, then we put the patient little right up or left lateral tail so that we avoid aortocaval compression. So if you see the conventional spread of the anesthetic hyperbaric drug, it goes caudate and it goes capillate. And generally, the capillate spread, depending on the volume, generally we give 10 milligrams to 12 milligrams. The capillate spread or rostral spread stops at D4 vertebrae. There is a peak kyphotic curve, the D4 vertebra. Beyond that, it doesn't happen. How many of you have encountered a low block when you're given spinal? Low level block. So if you want to extend the level of the block, what do you do? What is the procedure you do? Head tilt. So this is what exactly I want to demonstrate. If you're giving a head tilt of say 10 degrees, 15 degrees, the spread is not much because of the kyphotic element, unless the volume is very large. So if at all you want to give a rostral spread, put the patient lateral position, and then the kyphotic element is lost, and the drug goes up rostrally or cephaloid presentation. Again, how many of you are doing combined spinal epidural routinely? Most of you, glad to know that. So one other thing that you have to remember that if you are giving combined spinal epidural in lateral position, and subarachnoid puncture is uneventful single pass, but you have troubleshooting during insertion or threading the epidural catheter. So what you do, sometimes you have a bloody tap, you remove the catheter, then you flush the catheter. In the same time, the patient is lateral position. So the conventional low-dose spinal can become a high-dose spinal because patient is still lateral. So one point of thing, the take-home message is if you are doing CSC in lateral position, and if there is any troubleshooting, always put the patient 10 degrees head up so that you allow or minimize rostral spread. A very, very important point. Otherwise, the rostral cephaloid spread stops at D4. So giving the patient tunnel bug, you may not achieve significant cephaloid spread, but if you want to really achieve it, then you can just turn the patient laterally. The second demonstration is the most, again, frequently performed saddle block, subarachnoid spinal block in the sitting position. Especially, this is one of the beautiful block in patients with low EF, ejection fraction of 20%, 25%, rock stable hemodynamics, because there's absolutely no cephaloid spread, the drug fixes. The thing of, can I request Azam to give this? So this is, as I said, this is a skull which accompanies the CSF. You inject it, enter volume. So he's injecting hyperbaric drug in sitting position. And when you're giving saddle block, you maintain the patient in sitting position at least till the fixation time of bupivacaine is over. Like generally, the fixation time of bupivacaine is about 3 minutes to 20 minutes, the complete fixation. And we don't want the patient to develop high block. We just want a saddle block. So especially perineal surgeries, rectal surgeries, hemorrhoidectomies with low EF, geriatric age group, this is a very, very useful block. The thing is, make the patient sitting at least for 7 to 10 minutes. Do not make the patient supine because the unfixed drug can ascend up and you may end up with a higher block. So that is one thing. Many a times, especially geriatric age group, prolonged NPO status, generally we keep NPO for about 4 to 6 hours, but sometimes for some reason the patient is last on the list. With prolonged sitting position, sometimes they develop syncope. So you need to see that the hydration and support adequately, those things are taken care of. If you see this, you can see predominantly the local anesthetic is acted in the saddle perineal region. Hardly there is any rostral spread. And believe me, even EF of 20-25%, you don't have any hemodynamic perturbations provided they are well controlled preoperatively. So this was demonstration of saddle block in a sitting position. And then if you turn the patient supine, if you see hardly any minimal spread is there because the drug has fixed caudally. So if at all fixes only the minute amount of drug ascends up. So saddle block is a very useful block in perineal surgeries. And so next, yeah. So I've demonstrated, okay. So this is over, this is over. Now the third demonstration is, we also demonstrated this. Isobaric in lateral position. So how many of you use isobaric local anesthetic routinely in your practice? Quite a few. So the beauty of this is you have a segmental spinal block. Dr. Naresh Paliwal is here. He's very fond of segmental spinals. I don't use routinely in my practice because sometimes the surgeries, especially GI surgery and obstetric surgeries, the plan A is something and surgical plan changes and the block, the surgeon may extend the incision up. So you need to understand the surgeon and the surgery very well before you give isobaric. Otherwise, you may have an incomplete block. Can I have can you inject? So he's injecting isobaric bupivacaine into the subarachnoid space. Can you focus on the spine, please? Yeah, you're focusing. Just enough. So the beauty of isobaric is, depending on the volume you inject, the drug spreads the subarachnoid space, and gravity does not have any influence. See, there's a deep tendon buck tilt I'm giving, and there is no rostral spread or capillate spread. So again, you have a block with reasonably good, stable hemodynamics. The only thing caveat is you need to know the type of surgery and the levels or the dermatomes, osteotomes, myotomes that you need to block, and it works very well in the volume of the drug that you inject. Otherwise, the gravity does not have much of effect. So it's a thing, isobaric has its own charm, and that is what you need to remember. So next is, again, isobaric thoracic spinals. Very fond of, actually, I don't give thoracic isobaric spinals, but I think now the evidence is more and more evidence coming up where you're giving isobaric thoracic spinals so that you can do upper abdominal surgeries and lower, I mean, even mastectomy and other things. Can I? So, yeah, segmental spinal. You can do a little bit of barbotage also. Yeah, so he's introducing or injecting thoracic, like if you see the insertion site is the D11, D12 or D9, D10?
Yes, sir.
Yeah. So, yeah, so he's injecting isobaric bupivacaine. You're injecting air, Azam. Be careful.
Yes.
Enough. Sure. So again, this is what the beauty of, even though you are given thoracic spinal, the corded spread and the rostral spread is not there. So if you want to do mastectomies or any of those upper abdominal surgeries, laparoscopic, I mean, I won't say laparoscopic, open cholecystectomies, other things, you can easily do it. Again, as I said, the glass model mimics human model, but not, there are certain caveats that you have to remember. But importantly, you need to know the volume, generally about 10 milligrams, 2 ml suffices. Sometimes you may have to give just 1.5 or 1 ml also, depending on the myotom, dermatom, the involvement. So you need to remember those things, and you can have. So again, as I said, the gravity does not have much of effect when you're injecting isobaric solution, be at the lumbar level or at the thoracic spinal level. See, the bottom line is, so at the end of the surgery, the patient can flex her knees or hips, and then she can move herself. We have seen that in many of those workshops and personal practice also. Hey, hypobaric, how many of you are using hypobaric routinely in your practice? I don't use, but Dr. Sandeep Divan is very fond of using hypobaric, and he told me specifically to demonstrate this also. So I have made hypobaric solution by diluting the local anesthetic distilled water. So may I request first, generally hypobaric solution, the beauty of hypobaric local anesthetic is, especially when you have patients with acute femur fractures with requiring heavy arthroplasties or total hip arthroplasties, and the patient cannot give a good position because patient is on the, we cannot put the patient on a dependent side. Of course, now with the evolution of FICBs and other things, you can always keep the patient comfortable under blocks. But if you want to avoid block and straight away go for spinal, you can put the patient on the unaffected side laterally and inject hypobaric drug. If you can focus on this part, and yes, yeah, please inject. The beauty of hypobaric is, again, because the baricity is low, the drug stays at the site of injection. Yeah. I don't know if you can see. The bottom portion of the spine is, the drug is not fixed, right? Because this is the surgical site, the operating site is on the non-dependent site, and dependent site is the normal site, and you see hardly any drug fixation happening. Can you notice this? Is it clear? Yeah. So predominantly because of hypobaricity, the drug has ascended up and has blocked effectively the site of surgery. And because it's like a hemispinal, you see very, very minimal hemodynamic perturbation, and hemodynamic stability is very good. And if you are putting this, if you're giving, even if you're giving mild Trendelenburg tilt, the drug is going to only to go corded. It will not go scaphoid. So even for some reason, if your technician gives a Trendelenburg tilt, you don't have to bother about the spread, high spread of drug, unlike hyperbaric drug, because the drug is only to go, if you can see, the drug has got corded, but it has not come scaphoid. So that's the beauty of hypobaric drug. Now, some of the surgeons are very fond of doing surgeries, especially VVF, vesicovaginal fistulas or rectovesical fistulas in prone position or jackknife position. And, yeah, sorry. Anyway, it doesn't. Sorry. Supine and prone, so same, sorry. So basically, jackknife position, what the surgeon, you get a best position when the patient is not blocked, not anesthetized, and you want to give injection, spinal injection in prone position. Okay, so we are going to give spinal in prone position. Can I request Dr. Azam to give spinal in prone position? So if the patient is prone, he is going vertically towards the floor. So hypobaric drug, fine. Yeah. So if you see, generally the hyperbaric solution, the patient again with jackknife position, the patient also is slightly prone. And this is the beauty. Even if you're putting the prone by 10 degrees or 15 degrees Trendelenburg tilt and prone position, the rostral spread or the capillary spread of drug is very, very minimal and beautiful, very stable hemodynamics. So the only thing is you need to see that the drug which you make is hyperbaric, and we know that temperature is the one which can dictate the baricity. Like at normal 37 degrees temperature, even hyperbaric drug can become isobaric or the baricity is reduced. So you need to keep that in mind. So again, hyperbaric drug, even in steep Trendelenburg tilt, the drug only goes corded. You don't see capillary spread. And suppose if I'm putting, let us say, anti-Trendelenburg tilt, generally the drug ascends up. You see, drug coming up. So that's the beauty of the hypobaric anesthesia. So we have, just a quick recap, we have demonstrated hyperbaric in lateral position, then made supine. Or if you keep the patient in lateral position and you're giving CSE, how the drug spreads rostrally. Then we have done saddle block. Then we have, I've explained you isobaric in lateral position, isobaric in segmental spinal, segmental lumbar spinal, segmental thoracic spinal. Now lastly, continuous spinal anesthesia. Like conventionally, we give continuous spinal anesthesia using Wiley's needle or any of the CSA kit. But many a times, I don't say many times, but not infrequently, we get a morbidly super obese patient where we do intentional intrathecal placement of epidural catheter and give continuous spinal, so that and PDPH incidence fortunately with CS, with indwelling catheter intrathecally is less. So may I inject, one of the things that when you're injecting spinal is always start with low dose aliquot. So generally we thread the catheter about 3 centimeters intrathecally, probably I think Azam has put a little 3.54, 1 centimeter extra. So we just thread the catheter intrathecally just about 2.5 to 3 centimeters. And we put the patient supine, thread the catheter, put the patient supine, and then start giving drug, give 0.5 ml aliquots. little more. This is a hyperbaric BP again. And if you see the drug spreads, that should be fine. You give 0.5 ml aliquots every 40 minutes and watch for dermatome regression.
Yes, sir.
Okay. So the beauty of CSE is you can give small aliquots as and when required every 25 to 30 minutes, depending on the duration of initial dose, and dermatome, myotome, osteotome, you need to take care of those things. But most of them, again, pelvic surgeries, so prostatectomies, radical prostatectomies, or perineal surgeries. So when you're giving this, you get a good dense block. I can remove the catheter on the first POD so that you can minimize the incidence of PDPH also. But unfortunately, this technique was introduced in 1990s, and it went out of work within 5 years because the incidence of Cauda equina syndrome humongously increased, and they attributed it to the microcatheter placement. I'll take 1 minute, it should be over. So with the microcatheter placement, and they said it's because of this thing, but actually then we came to know that it was not because of microcatheter, it was because of the baricity of the drug that you inject, and the patient in lithotomy position for a longer time, the osmotic gradients between the local anesthetic, the neuronal cells changes, and then that's what's led to...
So 0.5. I have given 3. I think you said 3, sir?
I told you to give 0.5 ml.
I'm so sorry.
It has become total spinal. So the one other thing that we did this mock just to this. So if you are giving spinal intrathecal, see that you give only small aliquots. He has given almost 3 ml, and you can see going very high. We don't want a high block with CSE. With the beauty of CSE is you can achieve a low-level block and a dense block at the required surgical site. So Cauda equina syndrome can be minimized. We know it's not the baricity. It's the baricity, the dextrose containing local anesthetic, not the catheter per se. And the resurgence took place sometime in 2007, 2008 with Abelush et al. And Arkush et al. They introduced again CSA kits, and now it's, I would say, not freely available, but reasonably the kits are available. Payung is there, nil conflict of interest, but we have Bebron, CSA kits, and even Wiley's spinal, CSA spinal. It's beautiful, wonderful technique, indicated cases. So with that, I conclude my talk. I once again thank Dr. Sandeep Diwan for giving me this opportunity for the demonstration. Thank you very much, Sandeep.
Thank you, Sunil, for that masterly demonstration. Thank you, Azam, for that wonderful injection. And thank you, Javed Bhai, for holding the patient from moving.
Yes, sir.
Before anybody leaves the auditorium, can I please request all of you to be seated for just 5 more minutes? The organizing committee wishes to honor the medical industry, without whose valuable support we could not have organized this conference. Can you please stay back for a few more minutes?
Yes, sir. With Bala sirs and your permission, I would like to say a few words about Sunil. Sir, Sunil sir, I think Dr. Varsha carried for everyone to know, it was just though it was so flawless. Morning, Sunil sir called and said he would like to do all this and create CSF kind of a feature in the glass model. I said, yes, why not? So when he came in, if you see his shirt and other things are totally, totally soaked. So it is hats off to Sunil sir, where, where he has taken a lot of pain to do all this, and he needs a round of applause. And yeah, he spent morning almost 1.5 to 2 hours. Then there were a lot of air bubbles, and you all know that CSF does not have air bubbles. He made sure that the air bubbles were out. Suhail sir, hats off to you for your dedication. Thank you so much.
And thank you for, I think you don't have any more sincere students like these two, Javed Bhai and Azam Bhai. Thank you so much. I take this opportunity to call the trade people. Can you please come in front, all of you, please. On the stage, please. On the stage. A bit faster. They are all hungry and they have to leave.
As you can see on the screen, and everybody who has contributed for this immense work which has to be done for organizing the conference, financing the conference, and also displaying the new and innovative things which they have come out with. Mainly, I would to thank all the pharma people, the equipment people like Neon, B-Bron, Fuji Film, that is Sonosite, Payung and GE, who were the main sponsors for this conference. I would also like to thank Fresenius Kabi and Amneal, who graciously helped us in making this conference a success. Rest all, I won't take all the names, sorry. So rest all the companies helped us in making this conference a success. Thank you all. Thank you.
Thank you, everybody. You can disperse for lunch. But be sure you'll be back at 2. Just wait.
I don't have any disclosures, except I do love speaking about better ways to take care of children. Today, I like to just have some crisp objectives so you know what you're getting into. I want to review some of the applications of bedside ultrasound in children. I want to identify some of the clinical trends, things that we're seeing. And then to give you some ideas of how to make this applicable to you and how to make it so that you can incorporate this into your practice. So the first question is to just answer, what is point-of-care ultrasound? And point-of-care ultrasound is what we've been doing with IJ cannulation, with the ultrasound. It's what we've been doing with regional anesthesia. And that's basically where you, the anesthesiologist, wheel the ultrasound machine into the room, you do the exam, and you interpret the results right there without the help of a radiologist. What I'm going to focus on today, there's a lot of different applications, current and emerging, and what I'm going to focus on today are cardiac, airway and lung, and gastric. So to start with the cardiac, just as a basic review, we talk about positions, we talk about views, and we talk about windows. And when you talk about the windows with cardiac, there's three basic windows that we talk about. There's the subcostal window, there is the apical window, and then there is the parasternal window. And through these windows, we then have different views. And just like when you look through the window of a women's store, if you look to the left, you may see the shoes, and when you look to the right, you may see the jewelry, and that's what we do looking through the different windows. So when we look at the subcostal window, we can see both the IVC. Let me see if I can get this to work. You can see the IV. Okay, that's going to make people sick right after lunch. Never mind. The yellow dot is, you're going to be able to look at the IVC and the four-chamber subcostal view. From the green dot, you're going to be able to see the parasternal short and long axis views. And from the red, you get to see the apical four-chamber. And for those of you who might do adults and worry more about ischemia, you can also do an apical two-chamber from the red dot view. So this, is this the pointer? Okay, good. Okay, so here is the, if you're doing a subcostal four-chamber view, the transducer is placed just in the subcostal area. The indicator is pointed over into the left axilla, and the right ventricle is on top, the right atrium's here. You see the left ventricle, and you see the left atrium, and here's what it is in real time. And so you get a lot of information right here about the functionality of the heart. And we'll talk about what we're going to be looking for as soon as we look at some of the different views. And so here, this is the parasternal short axis view. This is one of my favorite views because it's one of the views that's widely available to the anesthetist and the anesthesiologist when the patients are prepped and draped for surgery and limiting the access that we have to their chest wall. The transducer is put in the second, third, or fourth intercostal space just to the left of the sternum and angled a bit out towards the left shoulder, and in that view, you see the left ventricle with the right ventricle sitting on top of it. And you rarely see a full right ventricle here. You usually only see just a partial right ventricle. You really get a good crisp look at the left ventricular function. You can see your filling. So you can see whether this is a sluggish ventricle, whether it's a crisp ventricle. You can see whether it's filled or whether it's empty. This is the parasternal long axis view. So again, from that same window at the second intercostal space at the left of the sternum. You can see the view that you're looking for here. Here is the left ventricle down here. Here is the right ventricle up here. And this is the best place to take a look at the valves. In pediatrics, we aren't so concerned about valvular dysfunction, but just to know that if valves are an issue for us, this is where you're going to see it. And please note, in the case of endocarditis, please note that these valves are on a continuum. We think of them as separate valves, but it's really really one giant soft tissue plane with the two valves attached. And here is the subcostal four-chamber view. This is the best way of looking at all four chambers. And the position is at the point of maximal impulse, or the apical pulse on the patient's chest, just a little bit inferior to the nipple in about the 5th or 6th intercostal space. And the view that you can see here, it's one of the more difficult of the views and images that we look for, but it's very gratifying because here you can see the full right ventricle, the left ventricle, the ventricular septum, the valves, and the ratio of the right and left atria to each other. When we're talking about the very, very young babies, we sometimes aren't able to use the existing technology. We talk about doing point of care. We talk about using the phased array probe. Now, those of you that do regional, you know the linear probe, you know the curvilinear probe. The phased array is the one where the footprint looks more like a cube of sugar that you would be putting into your tea. And this is a transducer that's specialized to make it so that it can look through very small windows and get a very, very wide angle of view. The problem is that it's very poor at visualizing superficial structures, and so when you're trying to look at a small baby, it's a little granular when you're looking with the sugar cube probe or the phased array, and sometimes if you pick up a small curvilinear transducer, you get a better view. And so for those of you that do the smaller babies and get into trouble, say with an 800-gram infant, you're going to have trouble using the classic phased array transducer, and I urge you to just pick up whatever transducers you have available and start trialing them. So I've shown you all these wonderful pictures, and now you're wondering, well, how do I interpret these pictures? What am I looking for? What is the system? And it's very easy. Yesterday I attended one of the lectures, and they were talking about getting credentialed, and radiologists and cardiologists saying, well, you guys don't know what you're doing, and you can't possibly do my job. We're not doing the job of the radiologist. We're not doing the job of the cardiologist. When the cardiologist comes in, it takes him 45 minutes to do an exam. When I do this, it should take me no more than 40 seconds, or if I'm learning, maybe 4 minutes. I only have to answer 4 yes-no questions. This is not qualitative, it is quantitative. My first question might be, is there enough volume in the heart? Yes or no? Is the heart filling? Second, is the heart contracting well? Is the myocardial contractility adequate, or is the heart sluggish? The third question is there fluid around the heart, such as a pericardial effusion restricting the heart? And the fourth question is, what is the ratio of the right ventricle to the left ventricle? The right ventricle is always smaller than the left ventricle unless you are looking at a brand new wet baby fresh from the womb, and then it may be the same size. But the right ventricle is never in a non-pathologic condition larger. And so if you go and look at some of these images, we'll look at some of the pathology. So when do you need to answer these 4 questions? So when you have cardiac arrest, and you need to know there are some reversible causes of cardiac arrest. So if you have a pericardial tamponade, you can drain it. If you have a patient who is very hypovolemic, you can give them volume. If they're in complete asystole, you want to get them on ECMO quickly, and that's life-saving. And if you have undifferentiated hypotension, so you have that baby that was doing great, there's no reason to be in trouble, and all of a sudden the baby becomes hypotensive, and you don't have a good reason. The baby's not bleeding, the endotracheal tube hasn't come out, and this is when you want to think about using your point-of-care ultrasound and taking a look at some of these kids. So when we did look at our results, we instituted the point-of-care program maybe 6 years ago at the Boston Children's, and what we found is, well, first of all, just a little bit of background. Infants have the highest incidence of cardiac arrest of any patient population out there. So if you have a child who's less than 6 months of age, you already have what we would call a high-risk population. Infants also, due to their size, have the highest rate of local anesthetic systemic toxicity. In children, hypotension is a late sign of hypovolemia because children are very well made and are refractory to hypotension. So whereas an adult will become hypotensive when 25% of their blood volume is lost, we don't see children becoming hypotensive until they've lost maybe 40%, and you're already in trouble by the time they become hypotensive. And because, again, of the size of children, we have a much higher incidence of air emboli than the adult population. When we looked at our results to see did we actually differ from the adults, we were shocked. Because in the adults, what they were finding is they were using their point-of-care ultrasound and their cardiac ultrasonography on their sickest patients, and we found out that in our first year, 71% of the patients for whom we drastically changed their patient management, they were ASA 1s or 2s. And this was a very humbling sort of fact. One was a 16-month-old girl. She was an ASA 1. She had congenital hip dysplasia, and she was intubated. She was induced, intubated, an IV placed, a caudal put into place, a second IV started, and the surgeon was prepping when the patient went into near cardiac arrest, and nobody knew what was going on. What we found on her, this is an air embolus, and let me tell you what you're looking at. This is the right ventricle completely filled with air, and here's a very underfilled left ventricle. You can appreciate the ventricular wall snapping crisply with nothing to push out. Another case that we had was a 7-year-old ASA1 who went into an atrial bigeminy on the induction of anesthesia. We took a look at the heart just to try, because atrial arrhythmias and any kind of arrhythmia, now that we're no longer using halothane, they're very, very atypical in non-cardiac patients. And so when we saw a prolonged arrhythmia, we pulled out our ultrasound transducer. We thought we were just going to be practicing and looking at a normal heart. And what we found was a patient with severe right ventricular dilation, a little bit of hypokinesis, not too bad, but what's most notable here is the impingement of the interventricular septum of the right ventricle onto the left ventricle. And further workup on this child, we canceled the case, sent the kid to the cardiologist. Further workup revealed severe pulmonary hypertension that was of idiopathic etiology. Just to complete some images for you, this is what a pericardial effusion would look like. Let's move quickly on to the airway and lung. You can confirm your tracheal intubation, you can exclude main stem intubations, you can confirm lung ventilation, and you can diagnose some of the pathologies and pneumothorax using your point of care for the lung. Here is a basic home view of a lung. You can look anterior, you can look mid-axillary, and you can look posterior. Anterior is where you're going to look for pneumothoraces. Mid-axillary is where you're going to look for lung sliding, and posterior is where you look for consolidation and pathology. So here is a mid-axillary view here. Here's a rib, here's the sliding lung, and here's the lung parenchyma down below. Here's your overlying thoracic wall. And you can see that this is an aerated lung. It's moving nicely with each breath that the child takes. What these are B lines. These are indicative of pathology. So this lung is being aerated, so it's being ventilated, but with these B lines, what you see is you see consolidation. And with healthy lungs, you have air in the lungs, and air doesn't really transmit ultrasound beams very well. And so it just stops. But when you have fluid, pus, and tissue down there, it transfers the ultrasound waves, and that's when you see what we call lung rockets or B waves. This is what a pneumothorax would look like. This shows, you can see the patient's trying to breathe, and the lung pleura is not sliding here, so that's a pneumothorax. When you want to look on your high-risk patients and you're worried that you might get an esophageal intubation, you can look this view here, looking right over the sternum at the, here is the trachea, here is the esophagus here. And we call it the double bubble or the double trachea sign. If the tube goes into the esophagus, it's apparent as you're looking at the trachea, hoping something to happen here, and you see something happen over here instead. No need for test ventilations, you avoid oxygen desaturation, etc. One of the areas where the anesthesiologists are going to be the pioneers is going to be with gastric ultrasound. And this is going to be useful when you have an unclear NPO status, the mother isn't sure if the kid was underneath the sofa eating Cheerios, if you have a patient with delayed gastric emptying, and those patients with emergent procedures. And the basic view here is to take the transducer in an up and down orientation. In a small child, it can be a linear. In an older child, it could be a curvilinear. And in the up-down position, you see the liver overriding the antrum of the stomach. And here's liver, here's antrum of the stomach, and this stomach has a little bit of liquid in it. This is a typical empty stomach. You see the stomach collapsed in on each other. Remember that the stomach is composed of 4 layers, and the rugae collapse right in on top of each other. And you can see that here. And also this hamburger shape. You see the thick mucosa around it, and you see the rugae collapse down in on themselves. And this is a full stomach here. Here you see the muscularis around it, and you see fluid in here. This is actually chicken noodle soup, and you can see some noodles floating around inside the stomach. This is a pyloric baby pre-OG suctioning, and this is after the OG suctioning. And again, you see the muscularis and the rugae folded right down on top of each other. So with that, that was about the quickest introduction I could give you to point-of-care ultrasound. And I just want everybody to understand that you need to keep your eyes open, because this is a very, very powerful tool that is unfolding before our very eyes and can be used for those 4 questions in dire cardiac situations. Questions of adequate ventilation in the lung, and whether or not you have a full stomach, or what is the status for risk of aspiration. Thank you.
Thank you, Dr. Karen, for that very nice overview. We'll take questions at the end. I call upon, is Dr. Anju here? I don't see her. Meanwhile, shall we have Dilip then? Okay. So I call upon Dr. Dilip Chavan. He's going to be talking about central IV lines in infants. A little break from regional, yes?
Can you just, yeah.
Sorry? But we don't have the presenter. Yeah, so we'll, yeah. Meanwhile, Dilip can just get started and we can try, yeah.
So last 2 days, good afternoon everyone. Last 2 days you are listening about the regional and something odd man standing here and talking about the central venous axis. So greetings from Mumbai and Children's Anesthesia Services. So I'm going to talk about, as we know that central venous cannulation is an again important thing for the major surgical procedure or in the PICU which we require to put. There are so many options which are available. Today I'm going to talk specifically about the practical tips about how to do a central venous cannulation. There are various approaches and everything. There are so many things are there, but in 15 minutes I will try to cover up the most of the things which. So commonly what we do is the internal jugular vein cannulation and the femoral vein cannulation, and then the it comes around the subclavian. So I will most of the times I will be concentrating on the internal jugular vein cannulations, how to do a procedure in children, neonate or preterm babies, so that I will show you the practical tips and then we go ahead with the certain things. So coming to the most important part is that no children, you cannot do any procedure without the sedation. So it is most important thing, when you want to do any central venous cannulations, you need to have the sedation which is required. Yeah, there are certain situations which will come that you will not have an IV line. So either you can take those patients in the war room and then under the mask, which I'm going to show in the next few slides. So the best combinations, what is used is always is the midazolam ketamine combination, which is the best, fantastic, and then a lot of studies has proven that this is the best, where it maintains the spontaneity during the procedure. So how you should go with the procedure? There are certain things where if you get a call in the PICU, NICU, then you can put a nasal prongs, and then, as I said, that midaz ketamine combination. In extremely preterm babies, 400 grammer or 5 or 1 kg, if you are not comfortable, just intubate for a while and then you do the procedure and then you get away with the things. So there are other most important thing in the central venous clinician in IJV is that the shoulder roll, because you required a good, proper size of the shoulder roll so that the chest comes up and then you can have a good angulation. The angulation remains good in the children. So as I said, this is the video where you can see where this is what the first you can see is the use for the 500 grammer baby. So this towel usually is available each and every PICU or ward or anything. What are the other alternatives? What you can have as the 100 ml bottle saline or 250 ml saline bottle or 500 for a bigger children. So this is how usually what I try to do is that with the towel roll, you can just adjust according to the weight of the child, you can adjust the shoulder roll and then you can make. So again, important part about the IJV cannulation is you need to make an angulation. So little table inclination has to be there, or sometimes see what happens in ICU, if you are not able to do inclination, what you can do, put little bit below the chest, and then you can just make an angle, and so that it becomes easy for the angulation. So this is how the shoulder roll. So again, coming to the procedure, it is most important thing, as I said, that if you don't have an IV line, so what other technique what we use is that we have a mask, so take it under any inhalational agents, whether you have a sevoflurane or halothane, and then tie a mask, and then you can do the procedure. So there are a few things before showing the procedure which I'm going to talk about. Is the most important thing is that 80% of the children, as you see that the anatomical landmarks are very difficult to visualize because a lot of fat and it is there, subacute fat, everything is there. So normal anatomical position, what we see is that you will be able to see the sternocleidomastoid muscles, the sternal head and the clavicular head. It is extremely, believe me, practically it is extremely difficult to visualize the apex of the triangle. Very rarely you can just see in a children. So this is how, so this is the 3-month-old baby, what you can, if you don't have an IV line, so what you can do, this is what the mask patient is induced under the sevoflurane, and you tie the mask. This is the technique what we usually follow for the surgical procedures also. And once the mask is tied, then you can, this is, as you see, the shoulder roll and the head pad. And the head is tilted 15 degree, usually 15 to 20 degree. If it is more than that, we can show you on the ultrasound that the IJV just overlying over the carotid, and then there are chances of puncture of the carotid. So again, the preparation has, like whether you are a new person or regularly doing the procedure, this has to be that, like still the cannula and then the guide wire and the blade and everything has to be done in a proper way, so that once you're doing the procedure, you can just go ahead with certain things. Most importantly, as I said, that cannula in pediatric patient, it is important, specifically in the neonate, as I will show you in the another next videos, that the gelcos are important thing when you are doing any IV, the IJV cannulations, because it's a plastic cannula, so that once you puncture the vein, you remove the stellate and then it remains as it is. If you use the rigid needle, what will happen that it will, like, chances of counterpuncture are much more higher in this one. So as the things like you can prepare for the ultrasound. So this is the technique where I'm going to show about the ultrasound guided the IJV cannulation. Once the preparation is done, and then you can pen drape and everything and done, and then you can just visualize the thing. So this is what you can see here, the trachea, and the pulsation where the carotid, which is a non-compressible one, and then you can see, and then IGV, which is a compressible. So this is the as simple as it is. So all three you can visualize in a one plane. So ideally for the infant, you should have a smaller gauge, the hockey stick probe, but whatever the probe which is available, you can use it. So only important thing here I would like to mention. So when you are using a bigger size of the probe, what you can do is that you can use your little finger on the chest, and that's slightly you can put the probe on the neck area, and then so that if you try to pick a bigger probe, so it will get compressed, and there are chances of counterpuncture which will be much more higher. So this is how you do with the ultrasound, and then once you enter, so usually what for a bigger children, again, most important thing is use a smaller size of syringes, either 5 cc, 2 cc or 1 cc. As the child or in extremely preterm babies, usually what we do is that we just slowly you can withdraw the catheter, and then you can see. So once, say, a constant flow of the blood, and you can start putting a wire. Again, important thing here I would like to mention about the guide wire is always measure the distance. Always measure the distance. Never try to even forcefully put the guide wire. Any slightest force which is there, you can just stop over there and then again redo the procedure. This is how it is. Once you put the guide wire with the appropriate length, and then you can just puncture with the knife. And again, most important thing when you are doing the dilation, where what you can do, usually you can do a screw driving action, like you can do a screwing action, and then you can you entered you can puncture the you can dilate this one. So this is how you can go ahead. So there are sometimes you can get a resistance. So what you can do is just slightly stretch the skin, and then you can just again do a screwing action. So this is how you should be doing. Once the dilation is done, then you can put the catheter which is required. And again, important thing here I would like to mention about, once you fix the catheter, once you the fixation is an important thing, where you can see from the, you can see the two wings where you should put the stitch has to be from the front of the wing. Why it is important? Because if you put on the side, so catheter can get stretched out. So this is how aspirate everything once the confirmation is done, and then you go ahead with the procedure. As I mentioned, I was talking about the suture material. So this is how the IJV cannulation has to be done in the pediatric patients. So normal position, as I mentioned, that it should be RA-SPC junction. So coming to the neonatal cannulation, so procedure remains the same thing. As I mentioned, once you puncture the vein, because veins are so small. So this is the cannulation of 600-gram baby, and then slowly you can withdraw. So you can see the blood into the cannula, and then you start putting. Either don't aspirate. If you try to aspirate, vein can get collapsed or something, so you can have a false sensation. And then again, if you see how already measure the things, and then you put the guide wire. So this is how it is to be done. Again, the same thing in preterm babies also, it remains the same. Once you puncture, sometimes you will not able to see the blood slowly, because this was again the 400-gram baby where did the cannulation. So this is again, the rest, all the procedure remains the same. I'm going to come in the next few slides where, so again we have a lot of difficulty when we we get the vein on the left side, and you can see we got the vein, but we are not able to cannulate. So what you can do is that little bend, you can just bend the little guide wire with your rigid needle, and then you can insert. Once you can start putting and then you can thread the catheter or the gel-co, we can just put, and then you can insert. Again, the procedure remains same, because there is an acute angle of IJV meeting to the brachiocephalic vein. So it becomes really difficult. So if you have Siam machine in the OR room, then definitely you should be looking under the Siam guided so that the position of the catheter remains the same. So again, the landmark technique, as I mentioned earlier, that it is extremely difficult. You can see this is a chubby baby, 1.5 month, 5 kg child, and not able to visualize any anatomy. You can see what we usually we try to do. We see a cricoid ring, and then slowly go ahead with the move on the lateral side, put little one finger on the carotid, and then extremely lateral, just go exactly lateral to the carotid artery and towards the ipsilateral nipple. This is what it is, and then slowly you try to aspirate. So this is how you get even with the landmark techniques. As simple as it is, always remember that you should keep your one finger on a carotid till you find the vein. This is how the landmark technique, what you do. So what are the catheter sizes what we use? This is a very complicated slide, but what our protocol, what we do is that less than 3 kg, 3 French, 6 centimeter, because it is available here in India, so what we do. And then 3 to 15 kg is 4.5 French, 6 centimeter, and more than 15 kg we use 5.5, 8 centimeter. This is what our simple protocol what we have made. And then this is the complication. So as I mentioned, the guide wire, never ever try to, even if you get the vein, if you try to forcefully put the guide wire, and this is what happens. So it has punctured the vessel, and then it has gone into the lungs, and then the pneumothorax which has happened. So to avoid this sort of complication, as I mentioned, even if you get the vein, guide wire, measure the length of the guide wire, how much distance you need to put the guide wire, and never ever try to do anything forcefully. So to remember, size of the catheter, as I mentioned, distance from the skin, and Gelco cannulas are plays important role in IJV cannulations, and the size of the shoulder roll, which always matter when you do a IJV cannulation. So coming to the femoral vein cannulations, where you can see this is the position, little external rotation, and put the little below the buttocks some towels or something which is like lift the hip. And this is what I'm going to show in a neonatal femoral vein cannulation. Again, this is with the blind technique, which is here important point I'm going to mention about is that you can see a little finger on a femoral vein, and then the Gelco again has been used, and the direction is toward the umbilicus. So this is how it is. And once you puncture the vein, and then you can slowly come out. Here, sometimes it is a lot of difficulties you get in a femoral vein cannulation. So what in the cath lab we got a Terimo wire. So this is the wire which is a very flexible. It moves around it goes with the flow, blood flow, so that it becomes very easy to cannulate the vein. And then once you goes into the vein, puncture the vein properly when you do the guide wire, and then you can put a bigger size of Gelco, and then you can do again the procedure remains the same. You insert the guide wire and this sort of thing. So this is how the femoral vein cannulations what you do. And again, it is, I'm not going to talk about the interosseous line. Thank you about.
Thank you, Dr. Dilip. Very nicely explained all the approaches. We can go ahead with the next talk. Dr. Anju Gupta, may I invite Dr. Anju Gupta on the dais?
A very good afternoon, everyone. At the outset, I would like to thank the organizers for this opportunity to present my talk in front of the elite gathering. And also a big thumbs up to the organizers for such a wonderful organization of the conference. So my talk is on elementary essentials in pediatric anesthesia. I bring greetings from my institute, All India Institute of Medical Sciences, which is the apex institute of India. I have nothing to disclose. This is the flow of my talk, but mainly I would be focusing on imparting some of the practical tips in pediatric regional anesthesia to improve the safety. I would like to begin with this statement from Swafford and Allen as late as 1968. Pediatric patients seldom need medication for the relief of pain. They tolerate discomfort well. This statement reflects the insensitivity regarding the pediatric pain management as late as 1968. And in 2003, there was hardly any 34% of the neonates who were receiving any kind of pain relief following painful procedures. So this was the state of pain management in pediatric patients. However, we are well aware that the pediatric patient, the neonate, beginning from the 20 weeks of post-gestational age, they have a well-developed nervous system and they can feel and mount the stress response as much as the older patients do. And there are multiple hemodynamic and systemic effects. Other than that, chronically, the untreated pain can lead to developmental behavior kind of responses in future. So there are certain general principles before we barge on to the pediatric anesthesia. We must acquire dexterity and experience with regional anesthesia in adults. We should know the sonoanatomy and anatomy well. We should be friends with the anatomy and sonoanatomy before we go on to pediatric regional anesthesia. We should be aware of the differences in anatomy and the pharmacokinetics of these young kids, because this is the main thing which will improve the safety when coming to the pediatric regional anesthesia. Children are not small adults. We should be aware of the differences. Another very small point, but it is important, that we should avoid neuromuscular blockers if we are planning to use nerve stimulator under general anesthesia. Then a type of block, mind you, are only limited by the interest and the skill of anesthetist. So it is no excuse that I am going to anesthetize a neonate, so I can't give regional anesthesia. There is no such age group which is barred from regional anesthesia. So this is the paper in pediatric regional anesthesia. Double the risk, double the anesthetic, double the risk. Is it so? The pain control with regional anesthesia, it decreases the opioid use, it improves the recovery, it provides a rapid recovery, decreases the surgical stress response like no other drug can do. And it decreases the MAC, and then we can even avoid general anesthesia. So there are so many benefits. Then why is there a hitch in using regional anesthesia? And it is a fact that it remains underutilized in children. The first and the foremost is that not everyone is a pediatric anesthesiologist. Most people are occasional pediatric anesthesiologists. So there is a limited knowledge of the pediatric drug metabolism and dosing. There is a diverse changes which happen when the child grows on. So we need to be aware of the developmental and physiological changes which keep on happening. And the efficacy, there is a perception that it is difficult to assess the pain in children. There is a need for sedation and general anesthesia. So there is a lack of incentive of providing pain relief in children, because in adult, we can just get the surgery done under general regional anesthesia. And safety is a very important concern. And surgeon's perception of pediatric regional anesthesia is a pain in progress. So surgeon should always be your customer if you want to practice pediatric regional anesthesia. So coming to the anatomical and physiological differences, there are certain key differences. The nerve, the vessels, they are very, very small, very tiny. If you are practicing adult anesthesia, like if you are looking for a femoral nerve, when you go on to look for the femoral nerve in child, you will just see tiny little dots. So it is so small, so that increases the potential. There is a potential risk of injury to the nerve and the structures around the nerve because they are very, very small. And we need to have a great skill in ultrasound imaging to improve the accuracy of the needle placement. Endoneurium has less connective tissue. Nerves have shorter diameter and incomplete myelination. And therefore, there is an early onset of the sensory and the motor block, and also there is a risk of prolonged motor block. In neonates, the dural sac ends lower down. So if we are practicing spinal anesthesia, we have to go lower down, L5S1 or L4S5. And also with caudal anesthesia in preterm and term infants, there is a risk of dural puncture and total spinal anesthesia, which is not there in older infants. Now, physiological changes, there is a high cardiac output, which leads to rapid reabsorption of the local anesthetic. And there is a relatively high proportion of cardiac sodium gated channel in the open state, and hepatic metabolism is not well developed, and there is a reduced concentration of alpha-2, alpha-1 acid glycoprotein until 1 year of age. All this culminate in the increased risk of cardiac toxicity in this age group, which is a very dreaded complication for all pediatric anesthesiologists. So also there is a risk of accumulation with prolonged infusions. Coming to pharmacological differences, there is an increased risk of toxicity, as I have already spoken about. We generally use local anesthetic in long-acting local anesthetic like bupivacaine, ropivacaine, levobupivacaine. Despite these challenges, there is a silver lining that the pediatric patient, they need lower concentration of local anesthetic for the block to be effective, because their nerves have thinner myelin sheath and the fiber diameter is very small. So even surgical concentrations can be achieved with a concentration as low as 0.2 to 0.25%. Now coming to caudal epidural, this was the when we talk about pediatric regional anesthesia, for many years, it was only about caudal anesthesia. Why? Because as Vrushali ma'am also says that it is about simplicity, simplicity, simplicity. So it is very simple. It is easily adaptable to ambulatory practice. It needs very basic equipment, just a hypodermic needle will suffice. And also the anatomy is very easy to identify, and this block is easy to learn. And we can even achieve high thoracic blocks because the catheter can be easily threaded. So anything from the upper thorax till the lower extremities can be covered. Now there were some complications which were possible in this age group, but with the advent of ultrasound, we can identify these things. We can identify the lower end of the dural sac, and we can avoid the lower end of the dural sac. So many complications can be averted and anatomical anomalies can be identified. Now epidural block, this was another which was relatively practiced in this age group, but the ligaments are thinner and it is difficult to identify and feel the LOR with the epidural technique in this age group. Midline approach is preferred because lamina are not well developed. Epidural space is more superficial. The distance, we need to be aware that it is only 6 millimeter at birth, and it increases to 10 to 12 millimeters. Hence, thoracic epidural should be practiced only by those who are very expert in pediatric regional anesthesia. And the dosing can be 0.1 ml per years of age per segment for those more than 10 years, and for less than 10 years, it is 0.04 ml per year. Then now coming to pediatric peripheral nerve block, there is a surge of pediatric peripheral regional anesthesia because of the advances in the safety information, advances in pharmacology, improvement in equipment, and ultrasound application. You tell me a surgery and I will tell you that a block exists which can cover that. So why ultrasound-guided regional anesthesia is important? In this graph, you can see that there is a increasing utilization of the peripheral regional blocks with the advent of ultrasound. Why? Because ultrasound allows you to decrease the dose of local anesthetic, because it is very important in children. We have a very small margin, then it improves the block efficacy and increase the precise localization and decreases vascular puncture. This is a study by PRAC study where 100,000 pediatric patients were assessed for pediatric regional anesthesia complications, and you will be happy to know that there were no permanent neurological sequelae. So it is basically silver lining with pediatric regional anesthesia, that till now no permanent neurological sequelae have happened, and transient neurological deficit are also very less common. However, you will be amazed to know that the complications are much more when the patients were awake. Another important series by French Language Society of Anesthetists found that there was no increased risk under general anesthesia, but complications were 4 times more in infants less than 6 months and 6 times more when there was central neuraxial blocks. So this debate about awake versus asleep, there is no debate. All the children should be given regional anesthesia under general anesthesia as a rule rather than exception. It is very safe. Now, selection of the drugs, we can use bupivacaine, levobupivacaine, ropivacaine, anything can be used. But we should preferably go for safer local anesthetic like levobupivacaine, ropivacaine. This also increases the margin of safety and it gives us the more dose of the drug which is permissible. But we should mind the continuous infusion rate, and infusion rate in infants less than 6 months is halved as compared to older infants. Now, this dose of regional anesthesia, it is also another challenge because every patient will need different dose. So this is very simplified by the ISRA. For upper extremity and lower extremity, a dose of 0.5 to 1.5 milligram per kg is sufficient. Whereas for facial plane blocks, a dose of 0.25 to 0.75 milligram per kg is sufficient for all the blocks. Now, there are certain tips to avoid systemic toxicity. We should choose a less toxic drug like levobupivacaine, ropivacaine. Then we should never exceed the maximum dose. We should use in small aliquots and we should aspirate repeatedly. Ultrasound should be used whenever available. We should be beware of repeated doses, and continuous infusion should always be abundant after 48 hours in neonates. If they are used, you should go for 30% lower doses. Epinephrine containing test dose, though it is not reliable, it is still used. All children given local anesthetics should always be monitored continuously. This is an algorithm, very simple algorithm by our Aora. regarding the local anesthetic toxicity, how to treat it, and how to identify the early signs we should be aware of. And then 20% interlipid should always be kept handy. However, it is not easily available, so we should always assure that it is available in our setup. Once I faced this situation, we had only 10% interlipid. I went ahead and used that, and we could save the child. So now coming to the adjuvant, these are all the adjuvant which have been used in adults have been used in children also. However, I am very fond of clonidine, and we have used it to prolong the anesthesia in spinal anesthesia as well as peripheral nerve blocks with very good result, almost double the duration. Now, multiple incision site, if sometimes the surgeon is planning multiple incision site, we should communicate with the surgeon and know what sites are planned. Then how to plan the block. We should calculate the total permissible block dose, then divide it into individual blocks which are planned. We should go for most distal blocks where lowest amount of local anesthetic is required. And we should dilute to permissible lower concentrations. Then we can also space out the block. One block can be given in the beginning and one can be given in the end. Now we can avoid the complication by watching the needle end. We should always be watching the needle end in this age group to avoid many complications like intraneural, intravascular, pleural puncture. All this can be avoided. But also the use of triple monitoring will be very good, like use of ultrasound, nerve stimulator, as well as the injection pressure monitoring if it is available. However, a vigilant anesthesiologist cannot be substituted. Then appropriate equipment will always decrease the risk of toxicity. Consent and documentation is very important. This is one case of brachial upper limb surgery where infraclavicular block was given and catheter was secured. However, 6 to 8 hours later, I got a distress call that the child is having this watering of the eye, redness, ptosis. So this was basically a Horner's syndrome which developed later. So I just assured them, and in the morning the child was fit and fine. So key to planning pediatric regional anesthesia, make friends with the surgeon, communicate with the patient and parent, never assume. There was a child who was adamant of getting the surgery done in awake. So don't assume that they will be very happy with general anesthesia. And then communicate with your anesthesia team regarding your plan. How to choose a block, the anatomical considerations regarding the area of noxious stimuli, then limitations and contraindication, analgesia, whether analgesia or surgical anesthesia is required, medical condition, anticipated duration of the postoperative pain. And we should always try to be site-specific. Make ESP block your friend, I would say that, because all our children are receiving ESP for majority of the surgery, especially pyeloplasty. I have seen very good results with ESP. And now from head to toes, I would say neck to toe, so many cases can be covered with the ESP block. Now, continuous versus single shot, there is not much of the literature in this population. However, it is very much possible, as this paper by Vrushali ma'am on sciatic catheters. This is just the literature is coming up, not much literature is still there. But if we are using infusion, we should be very careful of infants who are receiving infusions. Now, regional anesthesia is a very powerful tool to avoid general anesthesia in patients who have comorbidities, and we should make friends with the patient. We should pay a visit a day prior to become friends, and then it is very much feasible. So these are the reports where the regional general anesthesia was avoided by use of regional anesthesia. This is my own experience where preterm infants with lot of comorbidities, bronchopulmonary dysplasia, they were anesthetized by sole spinal anesthesia. This another cretinism child was anesthetized by low dose spinal anesthesia. This is a child of osteogenesis imperfecta where I gave continuous spinal anesthesia. This child was posted for multiple osteotomies of 3 hours duration. But with Dexmed sedation, the case went well, and the child came to meet me later on. So technology, make friends with your technology if you want to practice awake regional anesthesia. We should be aware of new kids on the block like pudendal block and the sacral ESP so that we know that there are alternatives. Like alternative to caudal block is this pudendal and this sacral ESP. So we should always try to innovate and improvise whenever the need arises. Like I practiced this unilateral sacral ESP in 2 children for lower limb surgery. If it covers the lower lumbar region, then it also covers the lower limb. So I was able to get a very good analgesic response. And this is another syndrome, the KBG syndrome, where the coccyx was inflamed and sacral ESP was used as an alternative. Now, one very important aspect is training. We should never barge onto the younger infants. We should practice first on phantom, then adult volunteers, then older children, young infants. Now, to summarize, the points to ponder are that we should practice it on the right patient, right site, right equipment, right block, right drug, and the right dosage should be used. Always inject with careful aspiration in small aliquots. Then keep intralipid handy wherever it is practiced. Then document and audit regularly your blocks so that you have a safety data. Then train your juniors and keep yourselves also updated to safely practice pediatric regional anesthesia. But definitely there is a need for further research in this neonatal age group regarding the regional anesthesia. So I would say that pain is definitely inevitable, but suffering is optional. And all these young, tiny tots, they deserve our help regarding the postoperative pain relief so that they are also smiling and we are also smiling. Thank you very much for your patient listening.
Thank you, Dr. Anju, for really covering the topic so comprehensively.
Thank you, ma'am.
Yeah. Our next session is called Sense and Sensibility. I call upon Dr. Karen and Dr. Vrushali on the dais. So what we're going to do here, I think they're going to present some cases, and we learn best when we learn from experience. So over to you.
Who's the sense and who's the sensibility?
Do you want the block? Can you see us?
Stand taller, you see. Okay. Well, jokes apart, this is going to be a very interactive session. We both are trying this for the first time. And of course, the chair people are also in our team, and they could chip in as in when Nandini and Saroj, both of them, think apt. So you are free for your comments as well.
Yeah,
we have
so
20
first
minutes
comment,
to go.
I think, yeah, that screen was showing something else. We'll go back to our sense and sensibility.
Sensibility, yes.
I wonder where the confusion is coming from.
Meanwhile, yes, you could take a note of the book Sandeep wrote.
So we have slides to prompt our discussion, but this is going to be completely extemporaneous between us as we sort of argue out different ways of doing cases.
Sure. And nonetheless, we do have our slides.
Okay, so that's us, and this is our slide.
Perfect. So here is the first case.
Okay, so I was supposed to ask you. So I'm supposed to start. So I'm going to read the case, and then I'm going to put Dr. Ponde on the spot. So this is case scenario 1. This is an 8-month-old, 8-kilogram female baby who is diagnosed with congenital pulmonary airway malformation, what we call CPAM, over the left lower lobe. And the baby is put on the list for a lobectomy under Uniport VATS. And after the induction of anesthesia, one-lung ventilation is established. Elective post-op ventilation is planned. And I'm with Dr. Vrushali, and I'm like, well, Vrushali, what kind of regional anesthesia what are the regional anesthesia options available to us for this child?
All right, so, well, Karen, I think a good old epidural could be one option. I might go site-specific, time-tested, and I know my NICU as well as PICU understands and handles them. Paravertebral on one side is another option. I could put in a catheter, but it's a single port, so maybe an additive paravertebral, being, a peripheral block might linger for a longer time. And there is an ESP. What would you go for? And there is ESP, right? What would you go for?
Well, I am a big fan of peripheral nerve blocks. I always think of my peripheral nerve blocks first when I can. And so one of the reasons I learned how to do a paravertebral nerve block and catheter was so that I could avoid putting epidural catheters directly next to the spine in some of these young babies. And so for me, I like paravertebrals, which are really it's just a one-sided epidural with a little bit of an added margin of safety in terms of neurologic damage, in terms of bleeding. I tend to not favor the ESPs. I think the data is conflicting. I know earlier today there was a woman who spoke and she said, look, if you know how to do an ESP and you're not an expert at doing, you know, 0.5 millimeter, you know, thoracic epidurals, do what you can do best, and any block is better than no block. But I'm not convinced that the ESP is as reliable as your epidural or your paravertebral. And so I would shy away from an ESP if I felt that a paravertebral was possible.
Would you keep a catheter in the paravertebral place for this case?
Yes.
Hold on. They have actually said that they want elective ventilation. Would you still go ahead and put a catheter in the paravertebral space?
Why would post-op ventilation preclude good pain management for an intubated child?
Yes.
She's taunting me. Yeah. I don't consider mandatory or elective ventilation to be a contraindication or an excuse for not doing good regional anesthesia. Can you comment on the benefits of regional anesthesia in suppressing the stress response in especially infants?
Yeah, sure. Other than analgesia, which is staggering and very, very tangible, there are other positive immunohormonal, positive stress responses. Absolutely no stress. So, yes. So these are the various metabolic advantages of a good regional block. So paravert catheter would be a good option.
Yeah.
And would it come in the surgical field by any chance?
It would. So when I was in Pittsburgh, I put the paravertebral catheters in ahead of time, and my surgeons were putting in a mid-axillary port. When I moved to Boston Children's, I was so proud. I put in very carefully, put in the very first paravertebral catheter that was going to be done at Boston Children's. The surgeon comes in and very graciously thanks me for my time, and he says, "But that's exactly where I need to put my port." So the last communication is very important. In that position, I would likely do a single shot up front and then go back and place a catheter at the end.
I totally get your logic. I get your logic of the choice of paravert. I know you're trying to go peripheral. I know that it, in fact, is a denser block than epidural because the roots are bare here. However, one thing I want to ask you, if this was an infective case for decortication, suppose, or lung sequestration, would you have still chosen paravertebral? Would you have had any other concerns?
Whether or not if you have true fulminant septicemia or infection at the site of your needle insertion, those are considered contraindications to all regional anesthesia. And so exactly how close the needle would be and whether I feel I'm separated from any contaminant and whether or not the patient is going to be on antibiotic would weigh my decision. And if it was the higher the risk the patient, the more likely I am probably to go ahead and put the catheter in because I feel that I'm going to struggle with them more post-op and they're going to be more fragile. If a patient's a little bit more robust, I might be able to cheat them a bit on the anesthesia and do a single shot with an adjuvant, such as maybe, I'm becoming a fan of dexmedetomidine in some of my peripheral nerve blocks. I do believe it does prolong the regional. How about you? What do you do when there's an infection risk?
An infection risk in the lung and the pleura and the paravertebral space, which we somehow know can communicate with the epidural space. For me, it is a direct communication to the epidural space, and I almost have this fear, which probably is not documented in hard data that maybe I might percolate the infection inside the epidural space.
Yeah, so Vrushali, actually, if I may say something. So,
Yes, please.
When you have infections like empyemas, that's some things where I would shy away from putting in a paravertebral block and probably go with the ESP in that case.
So we have various views here. So could we give one take-home message to the audience?
No room for 3 of us. No.
Yeah. We'll take another platform.
It's
so can we give that one take-home message, Karen, for the audience who's listening to us? Because we've given them a plethora of indication. I mean.
No, you tried to press me on this, and you try to say that between the three of us, we have various opinions, and there really is no right answer. I cannot give you a take-home message other than that regional anesthesia would be very beneficial in this child, and whether or not you do a catheter, whether or not there's a risk of infection, whether you go neuraxial peripheral, your take-home message is to be smart, use your skills and your judgment, and always think of regional anesthesia as your best friend.
Sure. So choose your block.
What's your take home?
Actually, you know what, I would put it in one line, but then of course you and me may agree to disagree. I would say that maybe thoracic epidural or a lower thoracic epidural, or 8 months, even a higher lumbar and the catheter going a little higher up may be an easier job for a person who's not doing paraverts day in and out to do. I know that's a better job, but I mean a better block, but probably in somebody's hands that is a better thing. We are away from the infection site, but somehow we should put the catheter tip at the surgically congruent level.
Vrushali, can I ask you both a question? Because this is a VATS surgery.
Yeah.
Do you really think the pain would be so much post-operatively as to warrant a thoracic epidural catheter or a paravertebral catheter?
Yes.
I mean, my surgeon sometimes says, I'll just give port side infiltration or I'll give an intercostal block. What do you say to that?
The surgeons say, they always say, oh, this isn't going to hurt. And it's true, it doesn't hurt them. But minimally invasive surgery does not mean minimal pain. And there is at least one adult study, and it's titled, I think it was an opinion piece, and it's titled Paravertebral, what was the title? They actually did, and they looked at this question, and they said that even though it's a VATS and it's minimal surgery, that there was benefit to the catheter, and no one wants their baby to start crying at 2 o'clock in the morning when the block wears off.
Also, I think many a times the position which is given, I mean, to suit the surgeons, the positions are sometimes very extreme kind of extension and all that. So that also hurts the baby. So we need to take care of that also. Maybe not bi-regional, but some other multimodal
That's an
approach.
amazing point. Actually, coming back to what Nandini was trying to say, yeah, I do get your point, but we have had given single shots. And from the PIC, we got a feedback. We did all the time continuous. For a couple of cases, we did single shot. But a very astute intensivist told me that they all sit like this in spite of being VATS. They act as if their shoulders are frozen. They would not do this. They would not do their spirometries because the stretch pain and the pain of, how should I say, avulsing the tissues from inside the pleural cavity does create fair amount of pain for children to at least wholeheartedly do their spirometries and mobilization. Then we again came back to catheters. However, there have been 2-3 cases where the surgery itself has not been extensive inside. And then they were okay with a single shot ESP, So each case, I'm sure, tells us a different story.
And one of the take-home messages is that any block is better than no block.
Yeah, sure. Yeah. And then if it is a single shot block, may as well give an adjuvant of clonidine.
Yeah. And if your surgeon...
Any thoughts on adjuvants, your favorite adjuvants now that we are both here?
You want to start?
All right.
Your favorite adjuvant?
Clonidine. I'd say 1 to 2 micrograms. If it is in neonate, we would stick to 0.5 to 1.
What about Dexmed?
Yeah. Dexmed is off the label. It's not yet approved by any body for peripheral and intrathecal or
epidural use is what I would. So I would shy away. I would keep that drug for IV sedations.
On the other hand, ropivacaine, do you use any ropivacaine or bupivacaine in infants?
Yes.
That's off-label. It's not approved by the USA. Ropivacaine is not approved for use in children less than 12 in the United States.
I'm going to be off job. Jobless.
So it is true that, clonidine is at least on label for peripheral nerve blocks with adults, and there's extensive use in coddles in infants. So that is a very safe choice. Dexmedetomidine is a new and emerging choice that there's starting to become literature in the adult literature that it does prolong it by as much as 100%.
Could we take this gentleman's question?
Yes.
Dr. Narayanan, a small doubt. What is your take about the dose or usage of dexamethasone as an additive in pediatric peripheral nerve blocks? Dexamethasone.
Should I?
Dexamethasone.
Dexmedetomidine. Dexamethasone, to be honest, I know literature says so, but I have never used dexamethasone neither perineurally nor epidurally in in pediatric regional anesthesia, because I feel that the IV gives an equal effect and an addition of a strong PONV effect. So why would I lose one over another? But if you put me in an adult operation theater and you want me to give a brachial plexus block, I would put dexamethasone as an additive for sure.
The dosage is same, 0.1.
Dosages is 0.1 milligram per kilogram intravenous. Analgesia as well as PONV.
Thank you.
Two birds in one stone.
Agreed.
Agreed?
Yeah. Karen, do you use any additives in your practice?
My additive is dexmedetomidine. I don't use dexamethasone because like Vrushali, I go with the evidence that says that it should be, it's just as block prolonging IV as it is perineural. And perineural, it also augments or exaggerates the potential the theoretical neurotoxicity of the local anesthetic when directly applied to the nerve. So again, I'll just give it IV. I don't see any reason for dexamethasone.
I'll go to case 3 because this is something that we already discussed. I'm going to ask you this question. 1.2 kilogram male baby, premature birth and pulmonary hypoplasia. Initially, this baby was mechanically ventilated, and right now, he's come out after 48 days of struggle and is on non-invasive ventilation, very, very low FiO2 requirement, and is posted for bilateral herniatomy. So how would you handle this baby?
Okay. I would speak to my surgeon and the parents, and I would like to see this baby receive an awake spinal anesthetic. I do worry, though, with a male child for bilateral hernias that it might not that the surgery may outlast the anesthetic. So I would have to see how fast, I would have to see which surgeon I'm working with. More likely, though, I would augment it then with a caudal. I'd do a caudal anesthetic as well as the spinal to prolong the post-op analgesia as well as prolong the spinal.
So that is a good thought. I mean, spinal gives a total operability and caudal is going to give you a lingering analgesia.
It's a little complicated, though. Do you have anything more simple?
Yeah, what I would do is I would do something like what we do. We'll give whiff of sevoflurane. We would give 50-50 oxygen and air. We would give a strong caudal epidural, but we would see to it that the soakage time is given. We would ask the surgeon to wash up after we've given the caudal so that when the incision is taken, it has given the entire operability through the block. How many of you all would really choose spinal for this particular case? 4, 5, 6, okay, 7, 8. How many of you all would choose both? Oh, 1, 2, 3. How many of you all would choose caudal epidural? Wow. And What about the rest of y'all?
Who would do general with either an ilioinguinal or a ilioinguinal hypogastric or a caudal to augment general anesthesia?
You would do that. Yes. Here here is a baby. Our NICU people have struggled a lot with the pulmonary hypoplasia and have extubated the kid, so they wouldn't want to go back on ventilation. So probably if you put an ilioinguinal iliohypogastric, you would have to intubate and take it as an analgesic block rather than the block which would give an operability. So you're 4 steps behind. However, yes, it should be done if that is the best you do, and let the NICU people go back with the tube if they wish to, or you assess at the end whether you can extubate the baby.
Vrushali, if it wasn't a baby with pulmonary problems, if it had been say a 2.2 kilo male baby who was less premature, who wasn't oxygen dependent and didn't have pulmonary disease, would that change your thoughts about general anesthesia?
No, not really. Although an LMA, although a tube and a laryngoscope would be handy all the time, although I know that the tube would go in a jiffy because this is the surgery where the baby's head is right going to be where I want it to be, I would still go with a mask, sevoflurane, and a well-placed caudal, epidural. And we believe that it gives operability because that's our experiential truth.
What kind of dosing do you use? Because I was, in my training 100 years ago, I was taught that 0.25%, that if you were going to try to do just a surgical caudal, that you couldn't get, that you would have to compromise either the volume or the concentration, and by compromising one or the other, you wouldn't be able to achieve a block that was surgical. That if you went with 0.5%, you would only be able to use half cc per kilo, which wouldn't be high enough. Or if you use 0.25%, that wouldn't give you enough anesthesia.
This sounds like a viva.
A what?
Exam viva. Oh. Just because you're my senior. All right, fine. We answer the question any which ways. I hope you agree. What you do is, you take 1 ml per kilogram of 0.25% ropivacaine or 0.2% ropivacaine or 0.25% bupivacaine. 2 kilogram baby, 2 ml taken. And then you take 5 milligram per kilogram of lignocaine adrenaline, the lower dose of allowable lignocaine adrenaline, and that comes to around 1/4 of the total body weight. So if it is 2 kilogram, you take 0.5 ml. So in fact, you get a good dose of 2.5 ml actually, which is 1.25 ml per kilogram. So I'm quite sure I will reach T10 is what I feel with this. And this will give a solid block, which would be actually seen as the baby not moving the lower extremities after the surgery.
Because I do a lot of the way you describe, I do a lot of my sort of perineal GU surgeries that way, but I've been a little bit nervous about seeing if I could get a surgical anesthetic. I'll have to try that. Do you add anything? Do you throw in any clonidine or?
We could add clonidine. It's always an option.
We could. Do you though?
Sorry?
I'm asking you, do you? I mean, you could. Do you?
Let me be very honest to you. We are a private practicing group. After a hernia, probably there is a hip dislocation somewhere waiting for us to be induced, and we are always on a run. And we leave the child, of course, in the recovery, absolutely wide awake. And before we go, we would like to give instructions when to feed the baby, meet the parents, and see to it that the baby is wide awake, if not howling, but definitely wide awake. So we would not, I know it should not actually give that lingering a sedation, but that is the reason. However, we see to it that diclofenac or paracetamol suppositories are definitely given in the favor of multimodal analgesia.
Yeah,
to give a more scientific this thing. I mean, I work in a hospital. I don't have to go to any other place. But the ex-preemie, I wouldn't add the clonidine. But say an infant who's more than 3 months, I would be quite happy to add just 1 microgram per kg of clonidine, and it really doesn't cause any bradycardia or respiratory depression in my experience.
Do you want to explain why you would not use clonidine in the younger child?
Oh, yes, because there is a risk of, respiratory depression in a small child or bradycardia. And this is a kid who's just come out of a long NICU stay. And although there are some reports where they've given it even to newborns, I haven't really tried it. I don't have that kind of...
The literature's a little bit mixed, and my reservations are that there's a handful of case reports of former premature babies who have had coddles with clonidine, and they've gone on to have devastating respiratory depression. And so that handful of cases gives many pediatric practitioners pause. So that's why I wanted you to explain that and elaborate that there might be an age cutoff below which clonidine may not be, the risk may not be worth the benefit.
Anybody in the audience would like to comment on additives or any experience to be shared here? How many of y'all use clonidine? Ekta, okay. All right. And any other additives used by anyone? Yeah? Morphine? Yeah. Okay. Dose? One institute work? Work under one roof? Yeah, hi. Please.
Dr. Vrushali, if I may share, we had similar situation where we had a preterm baby, and we thought, because there are not much literature available regarding the hypotension, bradycardia because of clonidine, so we went ahead and gave clonidine. We really struggled with bradycardia. We had serious bradycardia in that kiddo. We tried treating it with atropine, and it was actually not responsive. So finally, we had to give a touch of adrenaline to get the heart rate up. So after that, less than 3 months, or sometimes even we go like less than 6 months, I don't want to give clonidine.
How much was used, clonidine?
We gave actually 0.75 microgram per kg.
0.75 per kg.
So you were trying to tell us something.
Good afternoon, ma'am. Dr. Parveen, we use dexmedetomidine at 0.5 to 1 mic per kg.
You do?
We had instance of bradycardia, which was easily correctable with atropine.
Yeah. I use it as an adjuvant. We haven't seen bradycardia with it as an adjuvant. I use very little fentanyl in my practice. I can tell you probably only 5 to 10% of the patients I take care of get fentanyl. And if they get a little bit tachycardic on after induction or with the incision, I usually control it with a little bit of dexmedetomidine. And I actually like that the heart rate will come down 10% with the dexmedetomidine. And I've, knock on wood, I've not been plagued by a hemodynamically significant bradycardia.
Okay, we come to the fourth case. Is there anything to be added in the case that we just discussed? Could we go ahead with the fourth case? We have a luxury of good 9 minutes. So.
Yeah.
Actually, Aaron, just a question. The Dexmed was not for the really small babies, right? The IV Dexmed, you were talking about little older kids who would have a heart rate response on incision?
Yeah, I've actually used with my spinals, I've used Dexmed, as you call it, for sedation when the babies were getting a little bit agitated with their spinals and I needed to calm them down. I choose a small dose of dexmedetomidine because it's the only IV sedative used in children that has not been implicated in neuroapoptosis and neurotoxicity.
So you would have no lower age cutoff limit for using dexmedetomidine?
Nope.
Okay.
Not at all.
Okay. Yeah.
I want to ask one question. How you sedate the baby in premature for hernia and undercaudal? So what sedation you prefer? Whether propofol, whether sevoflurane, or will you give the fentanyl?
All right. You want to take up the...
The answer would be I would use Dexmed, and you would use sevoflurane.
Yeah, typically, you know, if I'm driving to work, I would put a phone call to the neonatologist and the surgeon one by one. I would be on speakerphone. I would come to know all the history, and I would know whether the surgeon is going laparoscopically or open. So if it is open hernia, I would know all the history prior. I would also know if the baby has a good IV line. So most of my concerns are addressed before I really reach there. After which, I would obviously talk to the parents and whatever it is. We get the baby inside. Yes, as she said, I would use sevoflurane. Sevoflurane, depth, tire mask, or put in an LMA, I would tie a mask, and whether the decision of going ahead with the mask as a sole airway holder would be decided by how the child is breathing in front of me when he goes a little deeper with sevoflurane. And most of them actually behave pretty well with sevoflurane and 50% of O2 and air in our experience. Then we gently give the position ourselves. We see to it that the back is moving all the time, because this plays even a bigger role when airway instrumentation is not being done. And a pretty much good depth is kept while we give the block. The SpO2 beep is all the time going on in our ears. We aspirate our drugs and give the caudal block. But we make it an emphatic point to keep the patient definitely deeper to get the block. After which we start, in fact, dialing down the sevoflurane.
So some of the times there is a respiratory depression with sevoflurane.
Yes.
So would you prefer some propofol and sevoflurane combination?
Well, propofol and sevoflurane combination, propofol probably would depress the respiration even more further. So I would still go gradually under with sevoflurane.
Yeah, I don't like to mix drugs either. Just pick one and go with it. And when you really start to get into trouble is when you start to mix things up, because then your responses are unpredictable.
Okay, thank you.
We actually use a bit of ketamine to get that caudal in.
Dose would be in a premature or a neonate?
In the premature, because those are the babies
0.5?
where I would do it, yeah, just 0.5. Sometimes max 1 per kg, that's it.
Okay.
And with propofol, I feel the BP drops too much, and we
Yes.
don't even realize that. That's what happens.
Ekta?
She's saying ketamine propofol.
Ketfol.
Again, why mix drugs?
Yeah.
All you need is to get that hypodermic needle in, isn't it?
Yes.
I wanted to go back again to that the hernia case where preterm baby is coming for bilateral hernia repair. When you give caudal and spinal together, question number 1, how do you calculate the toxic dose? Second, how do you assess what level will be achieved when both the blocks are given? Or you give one after other? I didn't get.
Yeah, you give one after the other. And the dose of the, for the spinal is, if I'm giving I usually use 0.2% ropivacaine as my caudal. And so that would allow me to use another 1 milligram per kilo in my spinal of some amide, and that's how I do it. I go up to the 3 milligram per kilo using my ropivacaine calculation, and then just add them. And you do have to add them, and if the surgeon wants to give some local, you have to add that in too.
Ekta, I was just thinking of, while she answered, I was calculating in the head. Probably another way of looking at the same thing could be 0.08 ml per kilogram of hyperbaric bupivacaine, which you would have otherwise given for an adult, which will now have a very minuscule amount of bupivacaine in it. So that would be the spinal drug. And then I would actually tailor down the volume as well as the concentration of both, and I would get in the lignocaine adrenaline, just in case if somebody ever asks me to do it.
And we do quote the dose for spinals as being 1 milligram per kilo of point one. Right, yeah, I'm a woman, I can't do math sometimes, sorry. So 0.08 to 0.1 milligrams per kilo is your spinal dose.
So So when you do one after other, means you put the catheter?
No.
But the surgery is on. How to give the next?
So you give, that's why the caudal lasts, it stretches out your spinal, and your caudal's gonna last 6 hours.
So you give both of
both
them
together.
Okay,
Together.
First spinal and then caudal.
Okay, okay. And why not an option of spinal with ilioinguinal nerve block as it's fading away? The surgeons can give that block as it's fading away. Because spinal fading away means obviously the peak plasma levels coming down. And when it's coming down, you can give another. So probably that's an...
Yeah, but you want a block which gives operability. That's why the caudal in. Yeah. Analgesia, yes.
But if you've already given the spinal, you have already had operability, and it's just kind of getting a little thin. So the point is, if it's the thinness, you can give the surgeon can give some local. If it's that you want post-op analgesia, the surgeon can also give some local. So again, there's many ways to do these things, and what works in your hands, what you do best, what your surgeon, like if he wants to feel like he's contributing and that makes him feel important, you know, hand him a syringe of saline if he wants to inject something and you've already exceeded your dose, if he feels like he wants to do something. There's a lot of ways.
Yeah, I don't get the point that you both are trying to make, but in my mind, I've already imagined what's happening in the OR. When the spinal starts fading, I'm sure the surgeon has completed one hernia, and I'm sure he has begun with another and probably is in the midway. All right, and at that time to ask the surgeon to give any other thing, because surgeons, if you observe surgeons carefully, they're very uncomfortable, at least when I see them. Even the astute of the astute surgeons do pay a lot of respect when it comes to hernia of a neonate and a premature, because tissues are very supple. They don't want to add or give anything in their planes. So this is what at least my surgeons would not at all like the idea of me giving them a local to inject while doing it.
Well, it depends on how fast your surgeons are.
Sure, but
now, back in, again, 20 years ago, we used to do all of our hernias as mass cases because our surgeons could do two-sided hernias in 40 minutes. And we didn't even have time to put an endotracheal tube in because they would be done.
No, our surgeons are tricky. You never know. They might work in 20 minutes. They might work for more than an hour.
Yes. It's been a lovely session, and I hate to interrupt you, lovely ladies, but I think the chronic pain enthusiasts are going to elbow us out if we don't move.
Absolutely.
So
I can all see them.
So do we have any questions for the entire session? Any questions for Dr. Dilip, the earlier POCUS session? Do you want to say something, Dilip? Use the mic, please.
One question to both of you is for a pediatric anesthesiologist. In lobectomies or thoracotomy, do you still consider putting epidural or a paravertebral catheters? What do you practice?
For a thoracotomy, we would do I would do a paravertebral catheter.
Even in the VAT surgeries.
I think she answered that earlier. Karen said very, very emphatically so that even though it's a VATS, the pain is still quite significant, and she would go in with a catheter. Yeah. So, thank you all for that lovely session. Thank you to the audience. Thank you.
Thank you.
Good evening, I'll say. Yeah, good evening, everyone. And after this previous extensive pediatric anesthesia by Ponde ma'am and Dr. Karen. We will switch to chronic pain, and I would like to invite Dr. Murali Thonde Bhave sir and Shahida Parveen ma'am to be the moderator and grace us with their presence. Thank you.
Good afternoon, everyone. We have come to the end of a couple of days of wonderful scientific sessions. So we present to you a symposium on chronic pain. And we have a team of very senior, experienced chronic pain professionals who will take you through the journey in the next 1 hour or so. So to start the session, I would like to welcome Dr. Vijay Bandikatla, who will be speaking about pain generators in low back pain. Over to you, Vijay.
Good evening, everybody. At the outset, let me thank the organizers to give me an opportunity to speak here and my good friend Murali. So, yeah, so Murali was my senior at Norwich in UK. So we worked together before. So my topic is about pain generators. So first of all, what is a pain generator? Anything which is an anatomical or a pathophysiological function that is responsible to cause some pain, particularly the lumbar back pain, we call it as a pain generator. So that's where the pain is starting to come from. And now look at this picture, which is going beyond the pirate. Just look beyond him. So what do you see? So what do you see is there is a pirate ship, and then on the pirate ship, what do you see is a mast. So you probably would know those 3 tall pillars which are standing there are the masts, right? So that has got a lot to do with our spine related problems. So essentially, if you look at the mast, it is a mixture of few pieces of wood, and then they have to stand together by various guy wires and all these kind of things which will go along with it. So our spine pretty much works in the same way. So basically, you have to keep your spine erect. At the same time, the muscles should be acting, all the discs, everything. They should be working in sync, right? So now coming to the pain generators, broadly classified into 3 groups. The most common things are the non-mechanical and the visceral pain. But they only form about 10% of the entire pain. So in the non-mechanical causes, you have neoplastic causes, infective causes, and the inflammatory arthritis and various other things which will go along with, which we are not considering it today due to lack of time. And coming to the visceral problems, what we have is the pelvic pain, abdominal pain, and maybe renal causes, and all these things fall under the visceral causes of this lumbar back pain. And of course, the aortic aneurysms and all these kind of things that we know can also cause the lumbar back pain. So now let's start to focus on the mechanical causes which form the biggest bulk of the pain per se. So coming to the mechanical causes, what you have is a disc which essentially takes about 39%, almost like 40% of all lumbar back pain is just because of the disc. So we'll have to understand the disc a little bit more. That's what we would do, and a little bit about facet joints and a few other things. So we will not have time to go through every single aspect of the pain generators due to the time factor. So in the disc, what you find are the annular tears, the herniated discs, which are nucleus pulposus, and the follow-up is the nerve impingement. So essentially, in a spine, what you get to see is a vertebral body, and in between 2 vertebral bodies, you've got a disc, and the disc has got a structure, which is what we're discussing about right now. And then you've got the spinal cord, which is present in the dural space. And then you've got the interspinous ligaments and all these kind of elements as anesthetists we all know when we do our epidurals and spinals. So, and then we will also discuss briefly about the canal stenosis and the muscular sprains, strains, and all these things very often. So just let's discuss about the disc. A disc basically works like a shock absorber. So if you look at a shock absorber, you've got an inner shock absorber kind of thing for a car, and outside you've got a coil spring. The shock absorber, if it is a disc, the coil spring is pretty much like our annulus. So you have an annulus which is sitting around, which will prevent this material to be leaking out. So that's how it works. So whenever the annulus is starting to leak out, patient will start to experience pain. So that's how it happens. But there are lots of risk factors which will cause this pain. For example, aging, wear and tear, things like driving, jumping, horse riding, and all these things. And at the same time, there are a few other factors like smoking, obesity, but most of the times it is the genetic causes which will cause this breakage of the annulus. So now, how does the disc pain start? Most of the times, as I was telling you, is very genetic, but there are lots of other contributory factors. So we'll briefly discuss. So as I said, a good looking disc will have an annulus here, and then it will have a nucleus pulposus. So we know that. So when you put a lot of pressure on the disc itself, it will start to break at some point. So these are the two tests which they're doing. So you have a screw, which is as it is tightening. So once you are tightening up the plates here, as the pressure increases, the annulus will start to break, and then the nucleus will start to leak. So as it is leaking, the nuclear material is more of an acid. Once the acid starts to go and hit the nerve, you will start to get an inflammatory reaction. So there is a mechanical component. At the same time, there is a chemical component which is causing the discogenic low back pain, which is where all our problems are coming from, and that's where our treatments will be aimed at. So as we go along, we'll see that. So this thing, with prolonged and recurrent irritation of the nerve, we will start to get the pain. Not only the pain, we will also get the central sensitization. Slowly, it will start to go to your brain. So you will have neural plasticity, and then it's hardwired. So we will have to try and reduce it. So how do we reduce it? So basically, the pathophysiology here is a dysregulation of the extracellular matrix. So what is this dysregulation? So if you see a cataract, you have a very transparent lens. Slowly it will start to go away. Okay? It will start to get opaque. Very similar, you've got an inner transparent substance which has got a crystalline structure. So as the inflammatory material is building up, inflammation is building up, this will start to lose its the structure of that, the crystalline structure is lost, which is how it will slowly start to turn this way. But most of us will have an inherent capacity to regenerate. So this capacity, as we are aging, or when you have certain problems like inflammatory substances, you will start to lose the regenerating capacity. That's when the disc will start to get degenerated. So this is how it will start to happen, and then the inflammation will start to kick off, leading to all the problems. Now, when you have a disc problem, what do you notice? So essentially, what you call it as a disc degeneration, as I mentioned, and in the disc degeneration, what you start to notice is the blackening of the disc first. So this is one thing, and then you will start to get little tears inside. As I showed to you in the previous picture on the anatomical model, so where you have a tear, this is how a tear looks like on an MRI scan, where this is a high intensity zone, which is pretty much correlated with your the pain of the patient. So you have this, very commonly seen. And of course, you will have certain modic changes. There are various varieties of modic changes. So starting from type 1 to type 2, type 3, all these kind of modic changes will be there. These are around the end plates, you will start to develop this inflammatory response. So these are the kind of things on an MRI scan. But then, once you found that the patient has got a discogenic pain, or maybe the patient has got, from a discogenic pain, they've got a radicular pain going down into the leg. Now, how do you treat them? So you've investigated, now you've got a diagnosis, how do you treat them? First of all, no disc will tell it is causing pain. So you only know that there is a change. So to establish that, the only way you can do it is a provocative discography. So provocative discography is a diagnostic test which you do in the operation theater. It's an invasive procedure, so we'll look at it a little. And then there are lots of different procedures. If you have pure discogenic lumbar back pain, so the IDET is being done. It's done mostly in the US. So it's done, it's not available for us. But these red circles, what you see, they're available for us in India. So we are able to do these procedures. most of them are the percutaneous mechanical decompressive techniques. So the nucleoplasty, which is done in the UK at least, so where we have done quite a lot of cases, this is more or less like a coablation technique. Like an ablator, like a radio frequency ablator, you go into the disc, you take out a cone of the disc, so you annihilate it, and then you remove the, you reduce the pressure. Similarly, you've got baculoplasty. It's a cooled radio frequency for the disc annulus. So that's another technique. Disc FX is another one. And finally, ozone nucleolysis. It's a relatively cheaper and more affordable technique that we have. And apart from that, spinal endoscopy, PRPs, lots of things are being tried. So just briefly about what is this discography. It is basically to find out two main components. So the pain, whether if there is a functional pain response, when you inject some air into it, does the patient develop a pain response is what you would see in a discography. For that, you have got a technique where transforaminally you enter into the disc and then you start to apply some pressure and there is concordant response to the pressure, the patient starts to develop pain. So that's a positive response. The second thing is anatomical, where you enter into the disc, where there is a tear there, and then if you start to get the spread of the drug, the spread of the contrast, and then if you can see that, that is a anatomical response. And that's a discography. So once you establish that the patient has got a concordant response and they've got pain, now what you have to do is decompress the disc. So the mechanical decompression, as I mentioned to you, is a coablation technique, a radio frequency probe. It is slowly starting to enter into the disc. So transforaminally, you enter through the annulus. Most of the times it is through the rent, but you can also come through the opposite side. So once you are entering into the disc, as you can see here, it has got a little 5-degree bend. Slowly, you go around and you take out a cone-shaped disc material. So once that is done, this is how you do it, and once that is done, over the due course of 6 weeks or so, slowly the disc will start to tighten up, and the pressure is reduced. So that's the whole thing about the nucleoplasty. As you are going inside, the water is annihilated, where it is converted into hydrogen and oxygen. It just comes back through the needle hub. The other one is the followed by the thermal treatment. As you are taking it out, it will cause the cauterization so that it doesn't leak any further. So that's how you do it. The other affordable thing, as I mentioned to you, which is available in India, is ozone nucleolysis. There's a lot of evidence out there for ozone nucleolysis, where again, with a normal 15 or 20 centimeter Quincke needle, you just enter into the disc. You enter, once you confirm it, then you inject some ozone into it, about 5 to 10 ml of that. And once it is done, you take it out. Over a period of time, patient will start to get a good response. Within about 2 to 3 days, they'll start to notice the response. 7 days, they can go back to work. And generally, it avoids quite a lot of operations. Back surgeries can be prevented. And if you can see here, this is before and after ozone nucleolysis. Sometimes you can actually get the shrinkage of the disc material. And I've got a number of pictures of these, which I've been doing myself, and I've been impressed with the technique. So the third one which I was trying to mention was the facetogenic pain. So in the facetogenic pain, the other name, the more technical name is the zygopophyseal joint. So mostly the zygopophyseal joint pain is because of the arthritis. So there is repeated, the mechanical wear and tear and the stresses which are present on the joint will make the facet joint to wear out very quickly. It is the arthritic component of it. It is a synovial joint. It will have a little cartilage. It will start to wear out. And like a knee joint or like any other finger joints, you will have bony spurs which develop around this area. So once you have a bony spur, you will start to get thickening of the joint. That will slowly start to go and press on the nerves which are present right in front of the zygopophyseal joint. So this will cause arthritis. And then they will also get pain which is traveling down into the leg. It's very common from lumbar back to the referred pain which will go down. So they will have obviously irritability and pain which will come along with that. There will be inflammatory chemicals again which will be developing into this area. So the treatment components, mostly they divided into two varieties. One is the ablations. You all know about the facet ablations, right? So the facet ablations, largely the radio frequency is what we all aware of. recently we've been doing cool radiofrequency ablation, which gives more defined, much larger lesions where you can get the medial branch much better than before. And then, of course, there is cryonucleolysis. The other things are the regenerative therapies recently that we are developing. So you have platelet-rich plasma. So there is a decent evidence which is building up for the PRP. People have tried bone marrow concentrate. People have tried the BMAC and then the nanofats and microfats which are being done recently. So that's you take the patient's fat here, you process it, and then you will have some stem cells going on into the fat that you inject back into the facet joint, which will help to recover it. So the other component is the spinal canal stenosis I'm talking about. So where this epidural canal that we are talking about here, it's starting to, the vertebral canal is getting narrowed from all directions. So basically the disc can be bulged, your ligamentum flavum can be thickened here, or maybe the facet joint is getting bigger. So when any of these three things, or maybe something else happens there, a tumor or things, so gradually the canal is getting narrowed down. So just a couple of minutes. So there is mechanical compression as well as the chemical irritation. Both of them happen. As it happens, there is loculation of the inflammatory chemicals inside the epidural space. There will be fine adhesions forming inside. Gradually, they develop into fibrosis. So there is, eventual thing is fibrous adhesions, they will start to develop. So you will do procedures like epidurolysis. For fine adhesions, you can break them up by doing a mechanical washout as well as breaking it with the catheter itself or the fluid. Use some chemicals like Hylase to open up the spaces. And you can also use things like epiduroscopy, where this is more for fine scars that develop inside. You enter through the caudal epidural space, you reach to the area where you have these filling defects. So once you reach that place, you use hydrodistension, dissection, and then slowly open up and free up the nerves. So that will be helped. So essentially, this is the technique that you do. And then you enter into the space, caudal space, and you clean up under vision. So there is an optical fiber which goes through it, as you can see here. So this is something that we do for epiduralisis. So, and you require the usual operation theater setup to do more advanced procedures. So, and then there are lots of other things, physiotherapy and non-invasive techniques that we use. And this is recently we started utilizing this for managing the patient for diagnosis. This is called PulseStar machine that we are using to diagnose patients who have got lumbar back pain. And that's my team, and hope you understand it. Thank you.
Thank you, Vijay.
Yeah, next I call upon Dr. Pratibha to deliver the lecture on epidural steroids, past, present, and the future.
Good afternoon. It's always a pleasure to come to Pune, and it's a wonderful meeting, Aora. Pune being my armamentarium for the medical schooling and a lot of friends. It's a pleasure to be here. And today I'm going to talk about epidural steroids, past, present, and future. Vijay has already made my talk a little easier by explaining about the other pain generators in the low back. And I'll be only focusing about the epidural steroids. I bring greetings from JSS Medical College, JSS Academy of Higher Education, Mysore, where I'm heading the Pain and Palliative Care Unit at the Department of Anesthesia. So we all, as an anesthetist, I'm sure everybody sitting here has given epidural steroid injection some or the other point of time, whether you are a trainee, whether you are a senior consultant, whether you are a mid-level consultant. It is one of the most commonly performed procedures in the world, with lot of support from the 45 placebo-controlled studies and dozens of systematic reviews. But despite this extensive literature on this subject, there still remains a controversy about its safety and efficacy. So why epidural steroids are given basically? Just now we just said that there is a mechanical cause and there is a chemical cause. Basically the steroids are given for the chemical cause, the chemical irritation caused by the inflammatory cytokines which are released by the herniated disc, which causes the irritation of the nerve and which is causing the radicular pain. And what steroids which are instilled in the epidural space do? They decrease the inflammation around the nerve, suppress the ectopic discharge, enhance the blood flow to the ischemic nerve roots, and thus leading to decrease in the pain. So coming to the past, since I have to talk about what happened in the past, what is present, and what the future holds for us. So it was first recorded, the first recorded epidural was given by Sicard in 1901, where he gave cocaine, he used cocaine. But it quickly fell out of favor because of the toxic side effects and the potential for addiction. And the next one was given in 1952, the first epidural steroid for lumbar radiculopathy. And it has been given for many years till now, but it became popular as an anesthetist. We always gave it as a landmark guided procedure. And it was given mostly in the sitting position or sometimes in the lateral position. And it was always a landmark guided using a 2-His needle with the loss of resistance technique. There was no real-time visualization. We did not know where the needle is going. There was no guidance which was used. And the drug which we are injecting is always in the dorsal epidural space. So the injection is far from the nerve root, which is a pathology. And since we are using a big needle, we are not using any image guidance. So naturally, the risk of dural puncture is very high, causing PDPH. So what happened? We did not know exactly where the drug is going. We are giving a high volume in the dorsal epidural space, thinking that it has to reach in the ventral space, where epidural space, where the nerve root is the pathology, and it has to work there. And we also gave a high dose of steroid. We used a big needle. So these are all the factors that we were using in the past. So here, this is one study where the importance of image guidance was done for the epidural injections, and they found that 9 to 50% of the epidural injections and up to 30% of the lumbar interlaminar injections, which were given by non-image guidance, were out of the epidural space at the expert hands. So this is a very big message that I would like you all to take home, that even if you think that every day, I am giving every day, no, but even if you are giving every day, still, this is the study that an eye-opener for us. So what is happening in the present? So I would like to see you this epidural steroid injection from the pain physician's perspective. So advancements in the imaging technologies such as fluoroscopy and ultrasound have improved the precision and safety of the epidural steroid injection procedures. So these are performed by 3 different approaches: interlaminar, caudal, and transforaminal approach. So interlaminar is capable of delivering the medication closest to the site of pathology. Caudal epidural, it requires a relatively larger volume, but lacks specificity to the site of pathology, but it is very safe, easy procedure, and minimal risk of inadvertent dural puncture. And we do regularly it as a hybrid procedure, because lot of radiation exposure is there when you're doing these spine procedures using fluoroscope. So here, this becomes a very easy and very short time you can take. You just put under ultrasound, you identify the sacral hiatus, put the needle, take one lateral view, one single view, where the needle is, inject the dye, and then go ahead with the drug. It is also preferred for the failed back surgery, or it is called as a post-surgery syndrome. So next one is the transforaminal. I'll be more focusing on this procedure. That is, transforaminal epidural steroid injection is the most target specific, requiring smallest volume to reach the site of pathology. This transforaminal can be performed by 2 approaches. Traditionally, it was performed by a safe triangle approach, or it is also called as a subpedicular approach, and a Cambin's triangle approach, or it is an infraneural approach. So the subpedicular approach, mostly, if any of you have witnessed or seen this procedure being done, then this is something all pain physicians will know, or the learner who is starting to learn the spine procedure will know one friend, that is Scotty dog. So you have to identify the Scotty dog in the oblique view, and you are going in the end-on or a tunnel vision below the pedicle. And then in the lateral view, you see the depth, and you should be in the posterior superior or midpoint of the upper part of the foramen, and you will give the dye and see the spread of the dye in the AP as well as the lateral view. And that completes your procedure. Here, these procedures are done in the operation theater, securing an IV line, a proper standard monitoring, asepsis, and most importantly, with the dye guidance. So most of these procedures are performed in the prone position, contrary to what we were traditionally performing in the sitting or lateral position. So what are the advantages of transforaminal? So we are locating the pain generator. We are going into the transforaminal space where the root is lying, and that root which is impinged or inflamed, you are going very near to the target place of pathology. Fluoroscopy allows the physician to visualize the needle in real time, ensuring the accurate placement. And contrary to the traditional way, when we were going in the dorsal epidural space, you are entering into the ventral epidural space. And you are giving the targeted delivery of medicines, that is the epidural steroids that you are injecting. So you are site specific, you are giving a very low volume, contrary to what you had to give in the interlaminar 10 ml. You are giving here 2 to 2.5 ml of local anesthetic with steroid. The dose of epidural steroid could be, if you are giving 8 milligrams of dexamethasone or 80 milligrams of depomedrol, here you will be giving almost 1/4 of the dose. 1/4 of the dose, both for the steroid as well as the local anesthetic. So it also allows you to avoid vital structures like blood vessels, nerves, and reduces the risk of damage. So, and dye. The most important thing is, it is very, very important to follow the dye, and you have to see that the dye spread, because it will also tell where your drug is going. And also it rules out the intravascular or vascular uptake. Sometimes even when you give a dye and you have negative aspiration, still it is possible that you are in the vessel. And that's the reason why you do the live fluoroscopy. You have to inject the dye under live fluoroscopy, which sometimes you may mistake with the still. So in the still image, the IV contrast may not be seen. But if you inject it under live fluoro, then you will definitely be able to catch up the vascular uptake. So this is also useful for some of the challenging conditions, like where the patient has an kyphosis, scoliosis, anatomical deformities, where there are calcified ligaments, or the patient with a failed back, and obese patient, where it may be a challenge for you to do an landmark guided epidural. So here the guidance will definitely make your life comfortable. And most of all, nowadays we all know that we are all worried about the medico-legal aspects. So when you do under the image guidance, you have this images which are stored, and you can definitely have it for your legal purposes. So the transforaminal with the precise needle placement, it has a high success rate compared to the blind techniques. It ensures that the medication reaches in the intended area, and definitely it is going to maximize the pain relief and reduce the inflammation. So we have a lot of studies. Since I have a shortage of time, I'm just going to skip through the studies, but there is an evidence here which had the good evidence for the interlaminar also, but it was a short-term good relief at 6 weeks, but there was a limited evidence for the long term. Whereas for the transforaminal, both short term and long term, it was strong, as well as the moderate evidence was there for the epidural steroid done by the transforaminal approach. The European guidelines for the management also have a favorable level of evidence for transforaminals. Now this is very, very important thing that I would like all of you to see, that after injection, more than 30 in this study, after the transforaminal injection, more than 30% of the patients who were originally considered for surgery decided against surgery. This is a very, very important thing that we need to look at, that cost effectiveness was also demonstrated by avoiding the surgical intervention. And we always say that the virgin back is the best back, because once you have undergone surgery, the next time definitely the surgeon is not even going to entertain you. So there are a few more studies which have said that the comprehensive, there were better clinical benefits with the transforaminal, and also the patient had better results in the second study because of the clinically significant or clinically modest reduction in the mean pain scores. So I would like to say that landmark guided epidural is making same mistakes with increasing confidence for an impressive number of years, versus if you go for a guidance, that is fluoroscopy guided epidural, then it is learning from the mistakes in the past and practicing evidence-based medicine. Amongst the evidence, like the guided epidurals, transforaminal injections are more likely to yield positive results than interlaminar and caudal epidurals. So I'm not saying that everything what I say is good. You also have to know what are the disadvantages of the transforaminal or the guided procedures. Performing fluoroscopy guided procedure definitely requires a specialized training and experience. It has a long learning curve. So that definitely is one of the disadvantages. So what do you need to adopt? Like whenever you wanting to shift from one old system to the new system, you need to adopt a lot of things like which you have to understand a proper fluoroanatomy, the sonoanatomy. The physician must be proficient in operating the fluoro. It is a challenge to first in the beginning, you will definitely find it as a challenge how the C-arm works, like how much degree you have to take, or whether it is caudad, whether it is cephalide, whether it is lateral view, oblique view, or AP view. These are all the things which take some time for you to understand the operating of the fluoroscopic equipment, as well as interpretation of the images. And inexperienced practitioners may have higher risk of complications, and the effective outcome will be very bad. The cost, definitely the fluoroscopy equipment and the equipment which are required for these guided procedures have to be available. And in some cases, the patients may need to travel to the specialized centers for very far, and this might cost an inconvenience to the patients. There is a lot of radiation exposure. I am sure all the pain physicians will agree with me that this is something we are all worried about. And there are complications, even if we are doing under guidance, there are a lot of complications. I'm going to deal about them a little while. And the common complications could be infection, bleeding, nerve damage, allergic reactions, and sometimes the rare paralysis because of the steroids, which I will be talking. So another thing that we need to understand about the epidural steroids is the use of different types of steroids and local anesthetic has been explored to optimize the pain relief and side effects. So there are two types of steroids that we use in the practice, that is particulate steroid and non-particulate steroids. So particulate steroid has an advantage of giving a longer duration of action due to the local depot effect. So these are the different local preparations of the epidural steroids which are there. And the chemistry of neuroxyl steroids has taken a center stage in recent years due to the complications following specifically the transforaminals. So a complication like paraplegia secondary to the spinal cord infarction associated with the use of particulate steroids. So we have to be very, very careful when we are using particulate steroids, especially in the cervical. My take-home message for you would be, don't use particulate steroids for the cervical space. And if it is a higher lumbar space, then it would be better to use a non-particulate steroids. And non-particulate steroids could be used in the lower lumbar space. Occlusion of the segmental artery, embolization of the vertebral artery were the possible mechanisms involved. It's very important for us to understand the particle size. So the particles of the particulate steroids are a little bigger, and shaking the solution, this is one practical aspect. I'll just finish my talk. So this is one important thing that I would like to tell, that when you're using a particulate steroid, you tend to shake the syringe. And what happens is when you're shaking the syringe, the particles are going to become smaller. And the moment you shake and inject, they will enter, but then once they are inside, they will become coalesce and become a bigger size and cause a blockade. So this is one important practical, important thing. And dexamethasone is one of the choice of medication that is a non-particulate steroid for most of the lumbar procedures. And here we have one of the study which says that though there is not much of a difference between particulate and non-particulate in the VAS scores, so it is always better that we weigh the clinical relevance in the light of complications. And since we recently had the FDA recommendations on the use of particulate steroids, so we should be using the non-particulate steroids. So the optimal interval, how much it should be given, how much dose should be given, is always a controversy. There are only few things which I would like to tell is the interval should be at least between 3 to 4 weeks. 2 injections should be given at the interval of 3 to 4 weeks. The total dose should be 3 milligram per kg and 210 milligrams per year and lifetime of 420 milligrams dose. And the future lies in the targeted delivery systems, the use of ultrasound for the epidural steroid injection, and also there have been reports of using robotic-assisted transforaminal epidural injections. So to conclude, epidural steroids have evolved over time with improved techniques and better understanding, and continued research and innovation will definitely will likely to contribute further advancements. So at the end of the day, whatever we do, it is very important that it is not only pain relief, but it is the quality of life of the patient. And to conclude, I would just like you to see this video.
सी ही चल रही है।
बट एक पॉइंट के बाद फीचर्स पुराने हो ही जाते हैं। बॉडी पुरानी हो जाती है, लुक्स पुराने हो जाते हैं, इंजन पुराना हो जाता है, नई का मजा ही अलग है।
पुरानी अपनी जगह, नई के अपने फायदे।
So my take home message is, पुरानी अपनी जगह है, नई के अपने फायदे हैं. So you just weigh the advantages and disadvantages and take your call in the setting that you are working in. Thank you.
That was a very illuminating session, Dr. Pratibha. We'll take up the questions at the end. Next, I call upon Dr. Raja Reddy to speak on the knee pain management, what's new in it.
So I see that Dr. Raja Reddy's CV slide has not come up, but just to briefly mention, he's a passionate teacher, a pain physician, an anesthetist working in the UK, and he teaches across the globe on all major courses with regards to chronic pain, and was also an examiner for the SIPS and WIP exams. So over to you, Dr. Raja.
Good afternoon to all the delegates, and thank you, Murali. This is about knee pain management. What's new? I think Pratibha has already helped me start that, because if you don't know the past and the present, you won't know what's in the future. So this is one of my favorite slides, and I always ask God to give me this, not these two, and this is the reason. When not to speak is also, and what not to speak is also equally good skill and attitude. So these are the few things what I do, and we advertise for a pain registrar fellowship program. The current one is from Pune. So she's excellent. She's got a 2-year residency program. We call it as a medical training initiative. Thank you, Pune, for a wonderful registrar who's with us. There's lots of statistics about epidemiology for any pathology for that matter. In this case, we know age and obesity is a risk factor, and there are other risk factors including injury, occupational factors, and valgus. This thing fascinates me, symptomatic knee osteoarthritis. You ask an orthopedic surgeon how he decides a patient for interventions including a knee replacement, why there is discrepancy between the joint space on X-ray and the clinical features. There are many reasons why they say that, and I'll tell you why it is. Remember, when you describe to your patient you have arthritis and pain because there's narrowing in the space, when you demonstrate that to the patients, you're wrong, because cartilage is aneural. And these are the nociceptive input which comes from. And most important thing is this subchondral bone. And what's the reason there's a discrepancy? If there was uniform narrowing of the cartilage without exposure to the subchondral bone and there's no inflammation of the synovium, you will definitely see some reduction in joint space radiologically, but there is no pain symptoms. And there are other reasons as well why the discrepancy is here. If the patient has got advanced symptomatic osteoarthritis, the gold standard is still knee replacement. In spite of this last line, more than 20% of the patients will still have post-surgical knee pain with normal biochemistry and normal X-ray without any change of implant. In spite of that, people would still go for a knee replacement in advanced symptomatic arthritis. So who are the patients who don't have non-surgical options? Very simple. I don't want a knee replacement because of the risk factors. I cannot have a knee replacement. What's the reason? This one. Very mild to moderate arthritis, young age, very elderly, very obese, lots of comorbidities. And also, I've already had a knee replacement, and therefore I'm still in pain. So these are the candidates whom we consider for surgical options. There is a big question mark about post-knee surgery and then interventions on the knee, which I will talk about it when it comes to that. So what are the options we have? Weight loss and exercise and anti-inflammatories. So these are the common things what we have. But these are the things I'll be talking about. Intra-articular Hyalase, steroids, this popular thing, prolotherapy, orthobiologics. When you talk about denervation, I always use all the three. And then finally, a few things which are available on pain clinics, including neuromodulation and peripheral stimulation. The treatment of choice for knee osteoarthritis is weight loss. It's as simple as that. Because we all evolved from four-legged creatures, and the evolution of mankind is made us erect. Therefore, sometimes when I'm playing the fool, I let them go on all fours, and you shouldn't have any back pain and knee pain, because there is no weight bearing. And also a simple thing, 10% reduction of weight improves your function by 28%. And then there was this excellent trial where even modest reduction in body weight gave them excellent relief, both functionally as well as pain relief. I always ask, why do you recommend physiotherapy for these patients? Does it change back the architecture of the cartilage? No. It increases the strength, mostly the proximal muscles, and therefore there is an enhanced sense of proprioception, which prevents falls. And that gives that's the advantage of physical rehabilitation. So what are the recommendations we have for treatment? We have topical anti-inflammatories as well as systemic anti-inflammatories, and there's a level of evidence why we have to give, and we know most of them they don't last much except for up to 3 months. So this was one of the trials where they compared saline with intra-articular steroids. And then they compared both pain relief as well as the volume of the cartilage. And look at that, there was no difference in new pain. Or for that matter, the patients who had steroid had lost the volume of the cartilage as well. So the proponents of intra-articular steroid was not very strong in this paper. And so was this thing called as hyaluronidase or viscosupplement. It's very popular though, but its mechanism of action is different. It doesn't have any anti-inflammatory properties. It's more of a mechanical or viscoelastic. And what happens with this study was, there was relief, but only for a limited period of time, irrespective of how much you have given, in terms of whether it's a low molecular weight or a high molecular weight, and also multiple injections. So, and there was another paper which says it's a very small and clinically irrelevant benefit, and the other one said improvement in pain only up to few weeks, but no change in function. So this was an excellent editorial where they said there's a flawed strategy in managing mild to moderate patients, because I think at least in America you get paid for every prescription. And viscosupplement, there was no clinical effectiveness. What I meant was, it was a very short-term benefit. And with steroids, there was improvement in pain, but no change in function. I think one of the indications for MRI in knee pain is when they have mechanical symptoms or when they have cartilage involvement, like knee locking, etc. So under these circumstances, the surgeon would like to do a knee arthroscopy. But what the evidence was, very small improvement with a knee arthroscopy for patients with knee osteoarthritis. Before I start my next slide, which is about treatment, I just wanted to say about the mechanism of tissue healing. It takes with 3 phases: inflammation, proliferation, as well as remodeling, and the platelets are involved in all the 3 phases. Now, there is something called as chronic inflammation. What happens in chronic inflammation is there's a variety of factors which stalls the inflammation. It could be obesity, it could be diabetes, and many other reasons. Under these circumstances, the inflammation halts. And then what we do under these circumstances is a very good indication to do platelet-rich plasma. So the rationale to use platelet-rich plasma is that it's alpha granules has got platelets. The platelets have got alpha granules, and when they release, they've got many factors which helps in healing. And these are all the mechanisms by which platelet-rich plasma works. And there are many preparations in the market. There are approximately 156 preparations of PRP, including the systems. So there is no uniformity or homogeneity at all, especially when the trials are involved. And there is a new one called as intraosseous PRP. The reason being the subchondral bone being one of the very important nociceptor in osteoarthritis. So in this trial, what they've done is they inject both intra-articular as well as subchondral with a new terminology called as intraosseous PRP. The mechanism still remains the same, but there's no further studies, not many. There's one case series in this. But they've injected other drugs called calcium phosphate, etc., for osteonecrosis. But for osteoarthritis, this is the only thing I could find. So this was a very positive paper for proponents of PRP in knee osteoarthritis. But this neutralized the earlier paper because this was multicentric, and what they found was did not find any difference in symptoms or joint structure after 12 months, where they compared saline with PRP. And then also we have other combinations of PRP called leukocyte-rich, leukocyte-poor. We never use any leukocyte-rich preparations for osteoarthritis because it can cause damage to the chondrocytes, whereas we use leukocyte-rich mostly for tendinopathies. So at least right now, the current clinical recommendation for PRP will be the lateral epicondyle, which is the gold standard, and then we use something for osteoarthritis as well. And there are other quality evidences available, but this is the one we are talking about. Then coming to the stem cells, we are talking about mesenchymal stem cells. Here it is, they can differentiate into chondrocyte, osteocytes, and that forms the basis as to why they use these stem cells. And the mechanism of action are these: paracranial signaling, vascularizations, cell repair, etc. And there are also 2 types of these. One is the adipose-derived. I think Dr. Vandikatla talked about that. And also there's a bone marrow aspirate concentrate. But the thing is, there's not enough evidence. So what all we got is half of the evidence is level 4. And the remaining says that the long-term maintenance of this is controversial. So the prolotherapy is quite popular. Whenever we've asked let me be very honest, I've never done prolotherapy. But there's lots of people asking why prolotherapy cannot be used, because the mechanism of action is the same as PRP. And I found on one paper for knee osteoarthritis where they compared, and what they found was very good improvement in pain, very good improvement in function, and there was no side effects. So this was the summary from the consensus conference, that what has happened is our treatment has outpaced the evidence, and therefore they had said a halt to all the regenerative therapies what we use right now. The next one is a radiofrequency denervation of major joints. And we know what is radiofrequency causing coagulation necrosis. But important thing is we use 50 hertz, 2 hertz, and also what we burn is usually the sensory articular nerves. We don't do the mixed spinal nerves with this. And also bigger the lesion, the better, because there are different types of radiofrequency, and it's already been spoken about. And we always wanted to know the innervation of the knee joint, and it was first described in 1948. And all the nerves, what we are doing now, is already been described. And based on this, the first report came in 2011 by Choi, and they targeted 3 nerves. After that, the whole world woke up to start investigating as to how this helped both in terms of pain and function over a period of 6 months. And there were quite a bit of critical analysis of this paper. But what happened next was they started investigating about the targets. So with Franco, he said there was an additional target required called as intermediate. And the next paper said we were doing the wrong way. We had to sit on top of the condyles to get the genicular nerves. And therefore, with this team, Philip Peng and John Tran, what they did was they divided into 4 zones, and they came up with that there are almost 12 nerves supplying the knee joint, and you're targeting only 3 nerves. So here, Murli, I'll take a little more time, I'll finish it. So these are the number of nerves available at each level, and even if you do a single lesion, there's not enough space to burn all of them to get meaningful response. And these are how you do it under ultrasound as well. If you want to do both fluoroscopy and ultrasound for all the 3 nerves, superomedial, lateral, and infromedial. This is a longitudinal view. This is a transverse view. And they compared PRP versus radiofrequency ablation. Of course, the RF had a superior outcome in this, but what happened was this was a pulse radiofrequency. This is not a radiofrequency ablation of the nerves. And then it was agreed that the treatment profile is good when you are using RF, and therefore it did not report any serious side effects. So this was the bipolar radiofrequency ablation of the genicular nerves, which it came last year. And look, they've done radiofrequency at the levels what was recommended in literature, but even then, there was not much improvement compared to sham RF. And this was another paper from Belgium where they compared cooled RF versus conventional RF, and again, they didn't find any difference in this paper as well. And this was a beautiful editorial. They said, the more the nerves we get, the more the questions rather than the answers. And this was one case of peripheral nerve stimulation for knee osteoarthritis. It's being done quite a bit in Stanford for implants. I think because of the cost, it's not been very popular. And these few things I found on literature, and I was telling my friend Ravi, they will inject anything into the knee. We have people injecting Botox and the others as well. And this one is called a genicular nerve, what's it called? Genicular nerve embolization for knee osteoarthritis. Thank you very much. Thank you.
Thank you, Dr. Raja. We'll take the questions at the end. Next, I would like to invite Dr. Ravi Kalathur, Senior Consultant Anesthesia and Pain Management at Apollo Chennai, who will be speaking on ultrasound-guided therapies in myofascial pain.
Good afternoon, Dr. Murli, Dr. Shahida. Thank you. Always difficult to follow Raja. I mean, I'm only following him for past 7-8 years, I think. Thank you. The next slide. It's only 7 years since I've been following Raja. Every time I listen to his lecture, it's a nice validation as to whether you're doing the right things. And whatever you're doing, is it in line with those evidence? Like he was showing the last slide, except coffee, tea, everything else they've injected into the knee joint, I think. So saying this, again, I have to say something about Murli since already 1 minute lapsed. Every time he chooses a topic for me, I don't know, I have a feeling he still likes me, but the last time was ISSP in Bangalore. He gave me something like spondyloarthropathy. That was difficult. This one, myofascial pain, none of the chronic pain practitioners, textbooks, they just don't want to bother about this. Thank you for giving me this because it opened up my I would say, yeah, I was insensitive to these patients, but I think the literature, at least the physiotherapists, the physical therapists, and our colleagues, they have done a lot of work, and it's only fair to help them with whatever we can to help the patient out. So saying this, I would like to start the lecture. That's about, 2.5 minutes up already. Myofascial pain, it's a very, very common one. Like every patient who comes into your clinic, the chronic pain clinic, has myofascial pain. By definition, it's a non-articular musculoskeletal disorder, which is typically characterized by trigger point. Now, the trigger point is a term which was introduced by Steinler. I guess he is a German. Basically meant stiff, tender nodes and lumps and bumps in wherever it's hurting. So the thing that not all lumps and bumps can hurt you. Then you have the ones which don't, which are called latent, and the ones which are active, which hurt wherever they are. And some of them hurt where they are not. That's the referral kind of trigger points. Now, this is something I thought we would like to respect these guys. This is the husband, wife, Lois and David Simmons, along with Travel. They've done a lot of work on this, on myofascial pain. I mean, I was really happy Murli gave me this because I had a chance to buy this book and I enjoyed reading it because it just mocked at my ignorance. So many days, so many patients we would have seen with triggers, and we just were so insensitive to these patient population. Yeah, all of us know what is pain. The myofascial pain is a hypersensitive spot, generally located wherever those tight taut bands are, generally within the skeletal muscles. The term myofascial means muscle and the fascia. But the trigger points, what we are going to discuss for a majority of our lecture today for the next 10 minutes, is predominantly in the skeletal muscles. What are the questions that come to my mind now? There were plenty of questions when I asked, what causes one? If every patient who's walking into the pain clinic has a trigger point, what causes them really? And some of them cause pain, some of them don't. And then after you do something like you send them to the physiotherapist, physical therapy, and then sometimes you inject them. Sometimes you tell them yoga is good, stretching is good. You tell them take amitriptyline, whatever you want. You've done the spectrum of things in the clinic to help these patients. Something causes them to disappear as well. So this is interesting. What initiates one? Naturally, the abuse and overuse of muscles. That's something that you need to keep in the back of your mind. And then the excitation, contraction, coupling, the EC coupling that you need to have that in the back of your mind when you are trying to understand these pains. And then there is an ROS mechanism, that's the reactive oxygen species, which are triggered, and that in turn causes the pain part of it. So the ones which are latent don't have this, they're not actually having a lot of ROS around them. Then the enzyme that is predominantly responsible for the ROS is the NADPH oxidase enzyme, which we all know leads to production of ATP. That means there is energy depletion in these trigger points as well. So what causes the pain? Obviously the ROS. And there are two receptors, though these two culprits are, one is the ASIC, that is the acid-sensitive ionic cell. That's the receptor. And then the other one is a TRPV, that is the capsaicin receptor. So that is exactly where the capsaicin, local application of capsaicin helps in blocking the second receptor, that is the capsaicin receptors. So this is actually the one which causes pain, that is the active and the latent trigger point. Now, when does it disappear? That's interesting as well. But there's so much of research, and whatever it is, the proposed hypothesis, there are two proposed hypotheses. One is the integrated hypothesis, and both were actually, the integrated hypothesis was put forward by Travel, and then the muscle spindle theory. So both have been responsible. There were different phenotypes responsible, and for the nociceptive phenotype of the trigger points, you have the integrated hypothesis, and for the neuropathic phenotypic or the nociplastic trigger point, you have the muscle spindle theory as well. So this explains what I went through for the past month or so. Each one, ultrasound is easy to read and practice. I thought each one to go through and remove, and unknotting each of them was the most difficult one. Of course, the commonest modality we use is the NSAIDs. I don't use much of NSAIDs because of the GI and renal disturbances. Of course, we use the tricyclics. Amitriptyline is what I use, 20 to 100 milligrams, and of course, other muscle relaxants as well. But the topic of the day today is ultrasound and myofascial pain. So after going through the ultrasound, you have the grayscale, you have the color Doppler, and you have the power Doppler. All three have been used to classify whether they are active. One, to diagnose trigger points. Of course, you can feel one. Suppose there is a situation where you can't feel because of the obesity, you can use the ultrasound. And then you diagnose one, and then you actually validate whether it is an active one and a latent trigger point. And then, of course, you use it for the therapeutics, that is injecting trigger points as well. This is a nice article again from, I think this is from Ontario, Philippines group, but this is the PMNR group of Western, I think it's Western Toronto Hospital. This is the fascia there, and this is the skeletal muscle, but you see the hypoechoic area, that's the trigger point. Now, injections are generally into this, but if you need to, but the commonest muscle which most people inject is the upper trapezius. For some reason, the neck is highly abused area, so trapezius is the most common, wherever there is chronic pain, there's myofascial triggers. So trust me, you just have to feel them. Okay. Now, now that's the hypoechoic area, and there's lots of hypoechoic areas. That's the entire length of the trapezius with 1, 2, 3, 4 there. That you could have multiple trigger points in each area, wherever you're. Now this is a normal trapezius muscle, and that is switching on the color. You could realize that there is the hypoechoic trigger point there, and that's how the trigger appears under the color Doppler. And of course, there is a grayscale scoring for the trigger points, and we have the color Doppler scoring as well. You should always make sure that any trigger points with the vascular thing, then you know that you have to be careful when you're injecting as well. Now, this is a very nice ultrasound validation for trigger points. So the ones which are active are the ones which have flow. This is switching on, this is the trigger point. That's the power Doppler. The diastolic phase has actually a flow, versus the one which is latent, there is no diastolic flow. That is the single most important factor which causes pain, possibly. So that is, we are actually talking about the resistive index. This is the ratio of the peak systolic volume, the difference between the peak and the diastolic volume, end diastolic, I mean. It's a ratio. So it actually gives you a vascular compliance of the vessel which is involved in this trigger points. And this diastolic phase flow is the one which determines the pain of the trigger points. Now, the shear wave, that is like the elastograms, have been used as an additional way to validate these trigger points. Now, this is a grayscale imaging. This is the fourth compartment in a young male. That's the radius lunate, and that's the tendinous portion. So when you switch on the color Doppler, and when you actually see the shear wave, an elastogram, it gives you a colorimetric index. Now this is the green, which is normal, versus the red, which is more stiffer. The more stiffer a tissue is, it shows up closer to the red, otherwise it's closer to the blue. Simple. Now this is the bone, which is giving you the red, which is closer to that area, which is giving you the red color, and the rest of it is green, which is normal tissue. Now this is the shear wave elastogram. I don't know if anybody is interested, but this is sending a shock wave, seeing the displacement of the tissue, and how much of displacement you come up with a shear modulus, which is simply put up as a color there. Now, why do you need ultrasound? Yes, for whatever various reasons that we spoke about for the last 3 or 4 slides. Now, needling them, always be careful about important structures. I'm done, Murli. 2 minutes. That's about it. Yeah. Always target the band. Make sure there are no vessels. The local twitch response is possibly the one which gives you a fair bit of indication whether your injection is worthwhile or not. The local twitch response seems to be something which all of us have neglected. So watch for the local twitch response and make sure there are no hematomas. Make sure you give a proper pressure. And repeat injection if there is more than 30% pain relief. And why 3 times of half-life? That's the hydrodissection and the mechanical factors that you're negating in dealing with such a thing. You can see that the needle is there within the thing. This is the skeletal muscle. And potential complications, the more fluid you're injecting into the skeletal muscle can cause contractures, fibrosis and whatnot. You can infect it, so be careful of whom suppose you're dealing with an immunocompromised patient, make sure you're having an aseptic precaution. And of course, sometimes you could have a spasm of the muscle, so the range of motions could be limited following an injection. So make sure you're actually identifying it and making sure that you're calming the patient down. And of course, you have to make sure that you're not injecting excessive doses of local anesthetic. And this is what we just spoke for the last 10-15 minutes. Thank you very much.
Thank you very much, sir. Next we call upon Dr. Sadasivan Iyer, sir, to speak on safety in the interventional pain management.
I was seeing that lady there walking towards the door and was getting a little worried, but I'm glad she came back and sat. So thank you so much. For the last 1 hour, I've been looking back to see if there are people in the audience. So before I start, I'd like to thank all of you for staying back and listening to a talk on pain at probably the fag end of the conference when most of you would want to be enjoying. All my previous speakers have thanked Murli sir. I can't thank Murli sir enough, but I'd specifically like to thank Dr. Vijay and Pratibha ma'am for essentially completing my talk as part of their talks, right? So my lecture is going to be more like a Viva session for all of you, right? So I will put up the slides. All that is there that I intended to speak has been already spoken by my previous speakers. So we can have a small MCQ or a Viva session just to see if you're paying attention to the previous speakers. Yes, most welcome. Depends on how many you can answer though. Right, so yeah, today's Saturday. I'm sure all of you may have plans to watch the next release on Netflix or Amazon Prime or Hotstar or whatever, go to the nearest theater. But if any of you could spare about 1 hour, 27 minutes, I would request all of you to watch this documentary called To Err is Human, right? It's on YouTube, right? It's, I think, 1 hour, 23 minutes on YouTube. And it's a brilliant, brilliant eye-opener about what we can do with regards to patient safety. Obviously, you know, a documentary has to have drama, so there is a little bit of drama as to how a child lost its life for various reasons, but the entire documentary was so moving and it was so much on patient safety, something that we don't tend to follow as much as we should be doing. Right, so this is a hard fact, which okay. So if you see, my pointer has come on the right place. In 2018, before the onset of COVID, accidents due to medical negligence was the 3rd highest killer in the United States. Of course, in 2020, COVID did a favor, and pointer, thanks. Yeah, so COVID did a favor, and the number of deaths because of COVID stood at number 3, whereas accidents due to medical error came down to number 4. So every complication has a triangle called a complication triangle. So the whole purpose of doing this is that you can prevent a complication. How can you prevent a complication? By practicing safety norms. Once you have had a complication, it's imperative to recognize, and then, of course, treatment. So the emphasis is on prevention, and like the old saying goes, prevention is the best form of cure, right? So how can we prevent? By being safe. Now, from the year 1984, when the anesthesia claim started, so initially all claims were because of anesthesia, you know, acute pain. But in the late 2000s, you can see the chronic pain claims have increased more than 10-fold. So it's important for us, even in chronic pain, to be worried about claims, right? And the most common cause of claims in the US is doing a cervical epidural, right? Of course, there are other causes, but The causes because of cervical and lumbar epidural, which is like the bread and butter for most pain physicians, can be quite scary. So when we talk of safety, we can talk of safety in the pre-procedural area, during the procedural area, and post-procedure. The pre-procedural area, you can do a good check with regards to your proper history, okay? Take a good history, look to identify red flags, see if the patient is on antiplatelets and anticoagulants and stop them as per the guidelines, right? And review your image before you decide to stick in a needle to your patient. Now, how many of you follow this, the surgical safety checklist? Not for anesthesia, but for chronic pain procedures. I can see only Dr. Preet's hand. Yes, you do. This side of the tongue? Yeah, thanks. Sorry. Right, so this is very important. And I'm telling you, I've had a patient where, and I'll be very open about it, right, even on a public forum, where I have done an epidural on the non-involved side because I did not do a simple surgical marking. Because when the patient lies prone, you are confused whether which handedness it becomes. So it's very important to do a pre-operative surgical checklist, to do a site marking before you decide to proceed. Be careful when you position your patients for procedures, right? You can have a lot of position-related side effects. And be very careful with what you load, right? And this was a novel paper where instead of giving bupivacaine, tranexamic acid was injected and the patient lost its life, right? Look for similar sounding drugs, similar looking drugs. Do not have unlabeled syringes, right? And different concentrations of the drug should be kept carefully. Now, I won't go too much into the procedures because that's been covered by my previous speakers. So when we talk of lumbar epidurals, we talk of interlaminar, and then we talk of transforaminal and different routes of doing the transforaminal. So when we started doing the transforaminal, we spoke of a safe triangle approach, which is basically depositing the drug here right under the pedicle because that was thought to be the safer area because you're safely avoiding the nerve root that runs below it. However, what they did not realize was there's this notorious segmental artery that runs in this segment, which could be the target for your needle, right? And the most dangerous branch is your artery of Adamkiewicz, which runs horizontally. And if your needle enters this vessel, you could cause a segmental spasm of the vessel, leading to ischemia and long-term potential paraparesis as well, right? So to counter that, they found out a retrolaminar or an infraneural or retroneural approach where they went below the nerve root, but this is potentially a more challenging way of doing it. For beginners, I won't recommend this technique at all, right? Second is to recognize your spread of the contrast, right? So this is a good epidural spread of the contrast. Okay, this becomes where you have a blotchy spread of the contrast will become a subdural spread. And of course, this is an intrathecal spread. So very important to realize where your contrast has gone when you have done the procedure. Quickly about particulate and non-particulate steroids. So when you use particulate steroids, the size of the steroid is about 5 times larger than the RBCs. So it tends to aggregate and form clumps, thereby reducing the blood supply and causing ischemia. Now, particulate steroids in the cervical epidural is a strict no, right? Even in the lumbar epidural, for the upper lumbar epidural, it is not recommended. So it is recommended to use non-particulate steroids, right? So this is what I was saying. So for beginners, learn the subpedicular approach first. Check the level, check the side, and then appropriate needle, okay? Use an IV extension for injecting so that you don't land up pushing your needle wherever you don't intend to go. Use of contrast agent, and use contrast agent under fluoroscopy. And if you have better access, then you can also use a digital subtraction technique to identify a potential vascular spread. Now, a cervical epidural is much narrower in space, right? So the risk of damage is also subsequently higher, okay? So when we do an interlaminar approach in the cervical epidural, generally we go below the C5, okay? Use saline for using loss of resistance, and definitely no role for particulate steroid. A fluoroscopy or a transforaminal approach is not recommended because you can potentially injure the radicular artery that runs with the nerve root, causing spinal cord ischemia. Coming to facet joint injections, most of these facet joint injections are generally safe, right? It is also a very commonly done procedure. We look at, for long-term relief, we look at doing a medial branch block followed by a radiofrequency ablation, right? So if you want to be safe, choose your patient correctly, do a diagnostic or a prognostic block, check your equipment, and then maintain contact with bone, right? So bone is your best friend. Also important to get a good fluoroscopic view before you decide to put in your needle, because you can have overlap and that can potentially spoil your image and then lead you to putting your needle in the place that you don't intend to put. When you're doing a radiofrequency ablation, it is important to remain parallel to the nerves, so the knowledge of anatomy is profound. Do not oversedate your patients. You want your patient to talk to you and give you a feedback of what's happening. Check the depth, check the direction, and then check the depth back again. So toggle between using an oblique, AP, and a lateral view, okay? If you get a stimulation less than 0.3, you are probably closer to the nerve for ablation. And then you should not get any radicular twitches when before you do a radiofrequency ablation. Now we are in a regional anesthesia conference, and I will be failing if I do not talk about role of ultrasound, right? So the ultrasound has become like the eye of the hand, right? So it will see what, it will give you a feedback as to what your mind is seeing. So safety with regards to ultrasound starts with a thorough knowledge of the anatomy, a thorough knowledge of the sonoanatomy. Ergonomics. It's very important that if you want to do a successful ultrasound-guided procedure, you maintain appropriate ergonomics. Use the color Doppler to identify vasculature. Make sure your needle tip is visible all the time. You don't necessarily need to see the entire length of the needle, but if you can see the tip, you know where you are. Do not inject if you find more resistance than usual, and then have a resuscitative backup just in case things go wrong. We spoke about patient safety. It is also important for us to talk about our own safety when we do interventional pain procedures, right? And the safety aspect comes because we tend to use fluoroscopy as an aid to perform interventional pain procedure. So you should take care of yourself with regards to wearing protective equipment, not only for you, but even for the patient at times. And then try, and more importantly is this, everywhere you do must have a good radiation safety program, right? And now we have come to the concept of ALARA, which is as reasonably low as possible or as achievable, as low as reasonably achievable. So reduce the time that you're spending with fluoroscopy. Stay as far away as you can when you're trying to shoot, and wear appropriate protective equipment, right? So if you maintain this continuum, the risks of having a complication will also come down significantly. Remember, safety is gainful. However, the accident can be very painful. So to take home a message, it is very important that we call ourselves pain physicians only when we have appropriate training, right? Use of Campbell's triangle, infraneural approach can always, the debate will always go on. A fluoroscopy and contrast is a must, I would say, when you're doing interventional spine procedures, right? You can use ultrasound, but do not use only ultrasound to do, foraminal blocks. Use it as a hybrid technique, okay? In cervical region, please do not use particulate steroids. Follow ASRA guidelines for anticoagulants and antiplatelets. And if you have little more money in your kitty, buy a C-arm which has a digital subtraction angiography. Thank you very much.
Thanks a lot, Dr. Iyer. That was an excellent talk. Now we come to the last talk of the conference in this hall. And we have Dr. Vrushali Kenya, who is a pain physician from Pune. She is a professor and head of the department at Bharati Vidyapeeth, Pune. So I request her to speak on chronic post-surgical pain, the role of the anesthesiologist. We shall be taking questions after this talk, so please be ready with your questions and we can have a good interactive discussion.
Good afternoon, everybody. I can see that the previous speaker has achieved, most of the audience are still awake. So thanks to the previous speaker, they have kept the audience awake. Yeah, so my talk is not on the chronic pain, but how to prevent and possibly avoid post-operative chronic pain. So, there are no conflict of interest, and I disclose that I have few of the slides or points I have taken from previous 2 days. So yeah, what is chronic post-surgical pain? So chronic post-surgical pain is an epidemic that is turning on a large scale now, and it's giving a huge economic burden and loss of days of the activity. And the incidence is ranging from 5% to 20 or 30%, depending upon how you define the chronic post-surgical pain. So what is actually chronic post-surgical pain? We need to have all the 6 criteria to define or to name the pain as it is a chronic post-surgical pain. 1, it should develop after a surgery. At least it should be there for 2 months in duration, and it interferes with the quality of the life. It's continuation with the acute pain, and it's localized to the surgical field, and we have to rule out that it is not caused by any other factors. So chronic pain, as we define, outlasts the normal healing time. So when it occurs, if the pain after the surgery remains for more than 2 months, we can label it as a chronic post-surgical pain. Coming to the risk factors which can lead to chronic post-surgical pain, we need to know these, because then we are able or in a better position to treat or avoid those risk factors and take care of them. So apart from these risk factors, the important is the intensity of the post-operative pain, presence and intensity of the chronic pain immediately, pre-operative chronic pain before the surgery, and the time spent in the severe pain after the surgery, the intensity in the weeks, and pain in the other parts of the body. So these 4-5 factors we need to, as an anesthesiologist, we need to take care of these 4-5 factors. So let's see how. International Association of Study of Pain declared 2017 as a global year against pain after surgery in an effort to improve the management of the post-surgical pain, to increase the awareness, to provide information to various physicians and educate them to avoid the post-surgical pain. Coming to the pathophysiology of the chronic post-surgical pain, we all know that the acute pain transmission, how it occurs from primary order neurons to secondary order neurons to third order and then to the central nervous system. The pathophysiology which is responsible for the chronic pain, any pain to turn out to be a chronic pain, we all know that there is peripheral sensitization as well as the central sensitization. The peripheral sensitization occurs at the injury site or the incision site, where the peripheral mediators, they stimulate the A delta fibers and C delta fibers chronically, and there is increased sensitivity at this level, which in turn also sensitizes at the center. The glial cells are sensitized, and we know that wide dynamic range neurons, which are usually dormant, they get sensitized and they start firing, and they are responsible for causing allodynia and hypersensitivity. So in the last, yesterday Bala Venkat sir stressed upon all these chemical mediators, And also he stressed upon the need to take care of the acute post-operative pain so as to avoid the chronic post-operative pain. So what can we do? What, as an anesthesiologist, what we have and what is to be done? So we all know about the preemptive analgesia. The preemptive analgesia is you give analgesia before any inciting event, which can be done before incision. Usually it is done before incision. If we combine or try to give preemptive analgesia before incision at any point during the surgery where any other inciting events are there, as well as post-operative, then it becomes a preventive analgesia. So if we try to manage the preemptive analgesia at various stages of surgery, we can achieve to block or at least decrease the central neural sensitization. So the preventive analgesia is basically the broader definition of the preemptive analgesia, where the duration of the analgesic drugs outlasts the actual duration of that drug. So preemptive analgesia is treatment that is initiated before the surgery, as we all know, and it prevents the establishment of central sensitization resulting from the incisional injury. Naturally, it has a limited effect on sensitization, and it remains till the analgesic effect of the drug, whereas the preventive analgesia, its focus is not on the relative timing of the analgesic, but on the attenuating the impact of the peripheral nociceptive bombardment, both preoperative, intraoperative, and postoperative as well. And it can be administered at any stage of the perioperative period. So what are target periods to achieve or to give preemptive as well as preventive analgesia? So it could be preoperative, it could be intraoperative, and it's postoperative also. So at perioperatively, we need to act as an anesthesiologist so as our patient don't have chronic postoperative surgical pain. So what are the ways to head off the pain chronification? So let's see one by one. Multimodal analgesia. So we all know as an anesthesiologist, we have to maintain the new concept of multimodal analgesia. Give analgesia in whatever forms and which acts through various mechanism. So it's an important concept in the field of modern pain management, where we use variety of the drugs which are combined usually with the regional techniques, and each of them have a different mechanism of action at the central as well as the peripheral nervous system, and they have additive as well as synergistic action. So we block the various pharmacological targets partly through minimizing the side effects seen with the use of high dosages of any one agent. So in our armamentarium, we have variety of the drugs that we can use intravenously and which can be combined with the regional blocks, and we can give multimodal type of analgesia for the patients. So as we know the pain transmission, we can have the effects of the various drugs at various levels of the pain transmission. Combine this with the regional analgesia. It's strongly recommended, and it has a high quality evidence to avoid the chronic post-surgical pain. And it's an important part of the multimodal analgesic regimen. It's recently included in the ERAS and stressed upon in various ERAS protocols. They provide accepted levels of analgesia with fewer side effects and higher patient satisfaction compared to the established standards. And we all know that in oncological surgery, they reduce the risk of cancer recurrence also. So while considering the regional anesthesia, what factors do we need to consider so as to make the regional blocks tailor-made for that particular patient? So we need to estimate the degree of the post-operative pain the patient might have for that particular surgery. Identify the risk factors like age, preoperative pain, cognitive factors, opioid dependency. Define your procedure for that particular surgery. So right invention at the right time for the right duration is must. Understand the technique and approach of the surgical team and plan procedures accordingly. And it should match the predicted pain trajectory. The next question you need to ask for yourself is, what resources do I have? Choose evidence-based techniques and what are suitable for your institution at your work practice. And anesthesiologists must be proficient in the blocks what they are considering to apply for that particular patient. To incorporate the regional techniques or regional blocks in a day-to-day surgical procedures, ongoing education of all the team members is essential so that it can become as a part and parcel of your surgical management or perioperative care of the patient. And increasing patient access to range of regional anesthesia options for various surgeries starts having a critical mass of anesthesiologists. I mean, maximum anesthesiologists of your team should be able to perform that particular procedure very safely. There are various guidelines and to incorporate the multimodal type of analgesia in the surgical procedures, and we should follow those. So what is the role of anesthesiologist? In her editorial, Dr. Pallavi Lande has mentioned anesthesiologist as a perioperative pain physician, which I can extend that we are the best personnel to deal with the deal the pain perioperatively. Because the anesthesiologist preside over the care of the patient during the surgery preoperatively as well as postoperatively. And for this reason, we are placed in a better position to head off the pain chronification using our diverse pharmacologic armamentarium. Again, anesthesiologists are unique and very versatile, so as to learn every new drug coming in the market as well as the new blocks every another day. So let's start from the emergency department, where we can play a very important role and we can identify the risk factors, especially the preoperative pain, and we can take care control of that pain. And so any patient who has preoperative pain will have a likely more chances of getting more postoperative pain, so we need to take care of that. So pain predicts pain. So with this new concept, I won't say now it is a new concept, it was started to bypass the emergency department and take a good care of the patient where the patient was shifted directly to the preoperative room, resuscitated there itself and given a block so as to have a patient comfort, and from there onwards they were sent to the other departments for various diagnostic procedure. This concept now we have to elaborate and we have to take advantage and give the on-arrival blocks wherever possible, considering the patient risk factors and the infrastructure we have, and definitely the expertism. The Royal College of Emergency Medicine, it has given a best practice guidelines for the emergency medicine department, so need to incorporate those in the emergency department wherever possible. Now, you need to have a comprehensive plan which is tailor-made for that particular patient, where the factors preoperative, intraoperative and postoperative as well as the postoperative discharge period are taken care, very well advancedly planned, and wherever there is diversion or any difficulty, those are taken care and readjusted. So this is a tailor-made example. Example for a tailor-made analgesic protocol for various type of breast surgery, and similar protocols can be made individually for every patient. The concept of transitional pain services. Before that, I would like to tell that the acute pain services which need to incorporate immediately post-surgically, we can develop the protocols depending upon the surgery, and those can be applied for each and every patient Whereas an anesthesiologist, where we leave the patient in the post-op room, we should take rounds post-operatively for at least 2 days, plan the acute pain services at your institution level, and see and avoid the pain and treat the pain accordingly, so that it is not converted to chronic pain. Now, what is this transitional pain services? It is closing the gap between the acute and chronic pain. So it was focused on treating the patients who are at risk of transitioning from acute to chronic pain following surgery to prevent the development of chronic pain and related disability. It's a multidisciplinary team approach where clinicians work together to treat patients, with the goal of provide comprehensive type of pre and post-operative pain management, manage opioid medication while in hospital and after discharge, and improve coping and functioning in the immediate and long term to provide as a high quality of life as possible. I would like to end my talk with the saying that we had done in Coimbatore, that I hereby solemnly resolve that I will wipe pain and suffering of every patient, bring in brightness and smiles to every surgical patient. So God produced pain, and He also produced anesthesiologists to take care of the pain. That's the hearing we heard yesterday from Bala Venkat sir, and let's urge and let's strive to achieve that. Thank you.
Thank you, ma'am. I request all the speakers to kindly come up on the stage. We'll take a few questions. And once the questions are done, we'll have a group photograph. So that's the reason I'm calling. Any questions from the audience? We had some wonderful talks. Yes, ma'am. We can take the mic. Mic number 3. Yeah.
Regarding epidural steroid, I want to ask what is the difference between Depo-Medrol and Dexona? That is particulate matter and non-particulate, regarding duration.
Dr. Pratibha, that's a question for you. Yeah.
So you wanted to know the
Duration of action.
Duration of action. Yeah, so the particulate steroids, because they are depot preparations, so it will last for a longer time. So ideally it is 3 to 4 weeks, that is what is written. I think you would have seen my slides. I had given all the formulations. And dexamethasone being a non-particulate steroid, it doesn't stay for longer time. So it will wash out soon. So it doesn't stay for longer time. So theoretically, it is said that the particulate steroid will have a shorter duration of action and non-particulate will have a longer duration of action. But I had shown the last slide wherein a good study was done where they said that the VAS score doesn't make much difference. When they have compared between the particulate and non-particulate steroids, they did not find much of a difference in the VAS score, which we have been giving. The reason why we are giving steroids is for the pain relief. So since it is not much of a difference in VAS score, you will have to, I think Preet is sitting here and I am quoting his study for this. So they found that since there is not much of a difference, in view of these FDA recommendations, it is better to use a non-particulate steroid for
Dr. Pratibha, one question from my side. Now the dexamethasone that we get in India, is it different from the ones which are available in the Western countries? Dr. Preet also is getting up to answer this question. So,
can I answer that?
Yes, please, yes.
So dexamethasone that you get in the US comes in a formulation of 10 milligrams per ml. Whereas what we get here is, I think, 4 milligrams. In an ampule, you get 8 milligrams of dexamethasone.
8 milligrams.
Also, dexamethasone that we get here is not essentially preservative-free. Right? It does have a preservative, but in a very minuscule quantity. Whereas in the West and even in Singapore where I trained, the dexamethasone was available as a preservative-free formulation. So.
One more question regarding myofascial pain, as sir said, needling. So exactly what do we have to inject something or?
again, your question is, what are you injecting into the trigger points, isn't it?
Yeah.
What is the recommendation?
Yes, sir.
Local anesthetics, steroids have been injected as well.
How to
That's about it, I think. Botox, see, I understand. They have injected everything everywhere. Come on. Now, there are no guidelines. If you were to ask me, don't you have, yeah, you will get about 6 to 8 months of good pain relief with Botox. That's one of the literature out there. But it's very expensive. And in India here, it's not even reimbursed. So I stick to local anesthetics, ideally. And disappearance of trigger points is not necessarily high in Botox versus any local anesthetics. There is no such literature out there. Sometimes it disappears, sometimes it doesn't. So,
yeah, you've got one.
So
What about steroids, sir?
I don't know if you have answered your question, though.
See, it's not necessary that wherever you put a needle, you should inject anything. Just do dry needling or just do needling and break those triggers. That also works wonderful.
So when you're doing the dry needling, like she's mentioning, that's also, there's again literature.
Stimulate beta receptors and...
Yeah, so it's a repeated, it's not a hollow needle like you are injecting. It's a repeated injection. And make sure you don't cause hematomas and whatnot. That's the only thing. But watch out for that local twitch response. That is also paramount in what you're doing.
Just a follow-up question. What is the role of the percutaneous electrical stimulation into the trigger points?
Yeah, there is decent evidence, but then that's on the non-invasive, minimal kind of a thing. TENS is known. Biofeedback also has a great value. The local application of NSAIDs also seem to work better. 5% lidocaine has been shown to have great effect. But I don't know if we have 5% lidocaine as a topical. Yeah, so I got some patches when I was traveling outside. So
It's available. It's available.
patches I got as from there. So I still use them. I got bulk of it.
So regarding the local anesthetic injection into the muscle, they are a bit toxic, and steroid definitely bit no.
So that's why.
Yeah, so we should not be repeatedly injecting there.
Correct. So that was the complications thing which I've mentioned. See, the volume of the medication as well as the concentration. So it is a it causes a bit of necrosis, and it, of course, heals with fibrosis and contractures in the skeletal muscle is more, you're causing more damage than what was there already. So make sure you're doing it, you're not overdoing it.
Yeah.
So you wait up if there is recurrence. I always follow them up with the physical therapists. And then when they say, no, I'm not able to break this mechanically or whatever, they come back to the clinic again. So that's when I still maybe inject them the next time. But otherwise, by and large, if it's sitting in a peripheral nerve and it's causing some referral pain, yes, those times I do inject. I use some saline as well.
Yeah.
Dry needling, I don't do so much. I have to be honest to you. But saline, yes, I do a little bit of hydrodissections and stuff.
Yeah, so that probably works little better and safer for muscles. Little small pulses of normal saline can help.
Yeah.
Because injecting higher concentration of local anesthetic, as we are used to anesthesiologists, we use 0.5% or 2%. That's probably not great for the muscle.
Yeah.
So we should not be using.
That's not what
the
I
message.
meant in those slides.
Because we don't even know how does this work. There are multiple mechanisms which have been proposed for trigger point injections. It's simply the dilution, washout of the inflammatory mediators.
Correct. That's there are lots of hypotheses put forward by how some trigger points disappear, and some start not to hurt anymore. Some get into they decrease in size, over the, some actually respond to, there are a lot of variables in how the pain disappears and the triggers disappear. So I'm not saying this talk is having everything inside, but then you can do things which you're not causing more harm than what it is there.
Exactly.
I think so.
Thank you. Yeah.
I also do a lot of, I practice 5-in-1 injections for this. Most of the myofascial pains are in the upper neck and the nape of the neck. So I do 5-in-1 injection, that is rhomboids, trapezius, and the levator scapulae, and the dorsal scapular and the spinal accessory. Once I do that, after that I put the patient on physio, and the next sessions will be the dry needling, maybe around weekly once for a month. So I have been doing this consistently, and I really get wonderful results with this.
Again, I get your intense liking for dry needling. I have nothing against dry needling. It's your personal choice. I would like to agree if I see some literature out there, other than Lakshmi's presentation and some literature out there, very little literature. Trust me on this. The kind of literature that is there on myofascial pain, you'll be quite surprised with the modalities. Right from, you can read up the Manchikanti's article. They have done a nice review on myofascial pain. Of course, there is a 2022, there is a nice article in RAPM as well. I keep forgetting the names of the authors. I realize you have an affinity towards dry needling. I don't find anything wrong in that, but then to say something is only thing which works, I think I'm not in agreement with that.
No, we believe it's multimodal, multidisciplinary. Correct. Because we have to target. Correct. Pain doesn't come from one, and even if it starts with one, there are multiple generators which are created secondarily. So we have to definitely address many other ways by many other
I
modes.
totally agree with you, yeah.
So it's not the only thing definitely, but it works somewhere.
I don't want to give a wrong message to
Yes, definitely. So it is always multiple therapies that is, and I'm sure that many of us are practicing this. Unfortunately, with pain physicians, we have not been able to document or do some RCTs or case series to put it up. We are not finding enough, there's a lot of inertia in putting this up. So maybe soon it will come. In over next decade, I'm expecting.
I think I agree to her observation, seriously. Because, see, the same color Doppler or the power Doppler that I was doing, 7 to 9 years now, I've not even bothered to put it up anywhere. I've not even bothered to follow it up. I completely agree with you. Yes, I completely agree with you.
So I think the message here is there are things that are working, but I think it's not there in the literature. And we have seen, all of us have seen dry needling working, but again,
I was very intrigued by dry needling. I came across Mahesh's article, which Lakshmi was also part of the, she was the author for that. And then there were some couple of Korean articles as well. But not really, see, no guidelines out there.
Yes.
Nothing, no algorithmic
I would like to listen to what Dr. Raja has to say about this. Because he travels across the world, he's seen different practices in Europe and North America, Australia, so.
See, at least from my practice point of view, we have a 3-tier system. From the general practitioner to the community musculoskeletal practitioners who offer a range of treatments, and one of them is dry needling.
Like nice guidelines does come out with.
Yeah, they do. And then if they're resistant to all these treatments, then they're referred to secondary care where I work. So my experience is hands-on is not there, but I've read literature, and there are many theories why it works.
A lot of GPs who practice dry needling.
And they're trained physiotherapists as well.
Now that you have the mic, I'll ask a question regarding the knee pain, because I don't think anybody's asked. How do we prevent OA in ourselves? Like there are so many of us here. Now what would be your message? 10% of weight reduction, 28% benefit. right? So now that the wonderful food we have been eating for the past few days, definitely we are going to be putting on some weight. So are we in line for early OA now, or what should we be doing? Any supplements, anything that you have come across when you went through so much of literature?
I agree with you regarding preventive measures, lifestyle changes, exercises. Medications, no from me. I don't prescribe for knee pain because they had already been prescribed by the practitioner, general practitioner. So by the time they come to us, it will be a liaison between me and the orthopedic surgeon. Probably, unlike other hospitals, we work together, the orthopedic surgeons and myself. Sometimes I don't hand over the knee patients to the surgeon unless I feel they are ready for a surgery, because I manage a lot and they're very happy with it. So I don't do steroids. I don't do visco supplements. And in terms of genicular nerves, diagnostic blocks don't exist. Because unlike the lumbar spine, the amount of nerves to be blocked doesn't happen. Therefore, the first paper which was released about diagnostic blocks, and he was waiting for 50% pain relief for 24 hours after giving 2 mils of 2%. So people forget about placebo. The effect of placebo is very high, including steroids you were talking about. Saline and steroids, remember that on epidural thing, that is why. So there's a huge placebo influence in these things. So what we do is a prognostic blocks for knee pain, meaning we're going to follow it up with a radio frequency. So I've done my own audit, last 156 patients in last 4 years of knee. The results have been very bad with operated knees. So what happens with operated knees is there's this mechanism of surgical debulking, denervation, which causes pain relief. And then healing starts to take place. Then there's neovascularization, new nervous architecture. Therefore, the nerves where they're supposed to be, they might not be there, or they're more than double that. Therefore, what has happened is in post-surgical patients, it's not been reported as well. I've done a case series of L2, L3, DRG, PRF. Excellent results. Especially, one of the differential diagnoses for post-arthroplasty pain will be a local neuroma sometimes. It's very simple to treat. Or sometimes because there's normal biochemistry and there's normal radiology, therefore you're in a dilemma how to treat, and the surgeon says it's up to you. One of the surgeons got angry, he said, go to Dr. Reddy or I'll amputate your leg for pain relief. So anyway, we have struggled doing any local interventions for knee pain after arthroplasty. In terms of region,
Stopped or you started?
What's that?
You started doing interventions locally or you stopped?
No, I don't do. Once there is an element of central sensitization, it is telling you don't touch me there. Yeah? You go back more proximally upstream at the DRG to do this. Then in terms of regenerative medicine, we got multiple formulations of PRP, and I work with a surgeon called Professor Shetty, who's got the recent Ontarian Award because he does BMAC for knees. So what he does is, he does a knee arthroscopy, then he takes the water out, puts in the air, and he drills holes between the femur and the tibia. And then he's got his own patented technology called Lee Shetty. And then once he drills and he puts that, he closes the knee, and every month we do an MRI of the cartilage to see the growth. So that is his practice. He says, even that has not been very brilliant. So many times he says, arthroplasty, it is, end of the day, knee replacement.
Thank you, thanks a lot. I think we'll take the last question.
Preventive early OA, is regenerative therapy not showing good results?
No. Because when you say regenerative, there is a host of treatments available. It could be prolotherapy, it could be PRP, stem cells, BMAC, and the stromal vascular fraction as well. Probably, as I said, there is a 50-50 in terms of how it works for it to regenerate in terms of the cartilage. What has happened is sometimes we've seen a structural improvement, whether it is ultrasound or MRI. But when it comes down to pain function and quality of life, it doesn't seem to match what is there. So I think people are still struggling to accept.
I think we have to understand how exactly, and the patient selection, probably the volume of the drug that we use, I mean the GFC or PRP, all that might...
Yeah, I'll come to that, because if you do the maths right, so one of the rationale for PRP is you want 7, 8, 9 times the initial concentration. 20, 30 mils of blood you cannot achieve. You need more than 100 mils of blood to achieve that concentration. The newer machines now show a display about the platelet yield, how much it is. That means the actual practice should have a baseline value of the platelets for the patient before you start PRP. And then you see the yield. But the modern machines show how much they increase the spin, increase the duration to get more. So you need at least 100 mils of blood to increase the actual...
The newer kits are the growth factor concentrates. You need only 4 ml and it gives you 2 ml of yield. So if we are...
Yeah, that's what I was telling.
No.
There are 135 types of PRP systems and products, similar ones available. So there's no homogeneity. And that is why even when they do a multicentric study, what I quoted earlier, each one was using their own systems. So nobody was aware of how much they were injecting.
I think I'm getting indirect messages from the organizers that we need to wind the session up. I think we'll take this last question and we'll make it brief.
Madam, for you, madam, we're talking about the post-op pain. Especially after a cholecystectomy, once we open it, we plan for lap and we open it. So we have a tough time in combating that pain. So what is your experience? What do you give to those patients post-operatively for the next 2 to 3 days to reduce the pain?
So if it's lap chole?
No, I'm just giving you an example, ma'am, but what is the...
Lap converted to open, you mean to say?
Open and the patients have...
Because of the complications or, I mean, any other surgery? So the same patient has been opened up again?
Not again, madam. You are not able to do by lap. The surgeons, they just open it, and we think we do it by lap, and we have a tough time in combating that pain. So what is your experience?
So again, multimodal analgesia, what we had, maybe this case was started with IV analgesics and the blocks. So post-operatively, again, you can repeat the blocks and infiltration along the line when over the incision, and repeat the blocks, or can keep the catheter also, and top of the IV analgesic what you have used it peri-operatively or intraoperatively, continue post-operatively. And the most important thing is the timing of those analgesics, which we carry in the post-operative period. The sisters are in the habit of putting the timing 6, 3 and 9. So you change the timings with a gap, so the wide coverage for the pain is taken care.
Thank you, thanks. So I think I would like to thank all the speakers again for taking their time out from their busy schedules, coming over here. And I would like to thank Dr. Sandeep, who's here as part of the organizing team, for giving us a 1.5 hour slot for chronic pain. We have Mr. Anand Peter here for giving us excellent AV system throughout the past 3 days. Thank you very much. Thank you all.
I request everybody to stand up for the national anthem.
Group photograph.
Thank you, everybody.